Good morning to all of you. I'm Dr. Angavikramarachi, Secretary of the College of Surgeons. A warm welcome to Internship and Insight in Surgery. This is the pre-intern program organized by the College of Surgeons of Sri Lanka. Thank you for your enthusiasm by joining with us today. And before we proceed, a few messages. Number one, please keep your microphones muted during the session, but you may unmute during the question and answer session. The second one, there will be two assessment feedback sessions. First one will be at the end of the morning session just before lunch. And the second one is at the end of the program. May I kindly request you to provide your feedback so that the people who have participated throughout the program will be providing an e-certificate. Now, Professor Srinath Chandrasekhar, the President of the College of Surgeons of Sri Lanka, will welcome you and brief you on this program. Thank you. Over to you, sir.
Good morning and welcome to all of you. On behalf of the College of Surgeons and the organizers of this very valuable program, I warmly welcome you to this program on Insight into Surgery as an intern. Firstly, let me congratulate you on choosing and embarking on a career which is established to be one of the most challenging professions that one can choose, but more importantly, one of the most gratifying and fulfilling careers one may ever could choose. As you are aware, being a doctor requires many skills and many domains. A young doctor needs a set of essential knowledge and skills, and most importantly, soft skills and attitudes that will differentiate between the kind of treatment and the impression one may create amongst the patients we serve. Whilst all of you may have received fairly uniform inputs in terms of knowledge and education, you may hail from different backgrounds, different geographical locations where you received education, and most importantly, we called upon to serve as an intern in different locations where the ground situations may have considerable variation. So therefore, acclimatization into key aspects of the functionalities of being an intern medical officer is of paramount importance when you start this job. You should also be aware that the kind of human resources, technology, and additional support one may have could differ considerably in a country, in a developing country such as Sri Lanka, where you could well be in a teaching or general hospital setup, or a base hospital where you could be working hand in hand with a consultant with few people in between who may be able to assist you. As opposed to several or many other professions that one may choose, the other key differentiating factor for all of you as young doctors would be that overnight, your duties and responsibilities will transform from being a medical student and an observer to a person who will save lives and a person who will be responsible as the primary carer who might determine the outcome of patients who will be admitted under your care. So despite these diversities, the task that all of you will be entrusted with in the very near future is one and the same. And that would be to serve and to save lives. In doing so, the college believes that an acclimatization program such as the one that we have arranged time will be quite valuable to give more clarity about various knowledge sets, soft skills, and attitudes that will be of paramount importance to make your career successful and also enjoyable as a young doctor. So, whilst welcoming you once again, I also take this opportunity before we kick off the program to thank the team at the College of Surgeons who have worked tirelessly to put the program together and arrange all the logistics. And most importantly, to acknowledge, appreciate, and thank the faculty who have volunteered to speak to you and interact with you, to impart with their decades of knowledge and skills that will transform your career into a more enjoyable and productive one. So I think we have more than 20 resource persons, very senior and eminent surgeons who have served different parts of the country in different capacities. And they have taken time off their valuable time off their schedules to come and be with us at the college and to interact with you. I'm sure you are aware that more than 800 participants are registered for this program, which reflects the importance of this session. And I do hope that you will gain very much from this program. And this would only be a starting point of several other programs that the college wishes to bring to you. Thank you very much.
Dr. Balagobi, over to you to commence the first symposium. Please introduce the speakers and start them.
Thank you, Dr. Ranga. So the next symposium is going to be on first week challenges as a house officer. We have three eminent speakers who are excelled in their as a clinicians, an academic career, and administrators. So considering the time constraint, I have allocated my time also. I have invested my time into this session. So they are experts. They will, talk better way, and they will guide you better way. So 15 minutes each for three experts. We are starting with the first talk, who is well known to all Sri Lankans and surgical community, Professor Mohan De Silva. He's going to talk about the new setup and the new team, how to handle. Over to you, sir. So please unmute yourself.
Yeah. In this discussion, I thought I will share with you some of my thoughts and some experiences to help you to settle in and also to get the best out of your internship. When I saw the program, I was so happy to see that Professor H. Sheridan is going to address you as the last speaker, a very eminent surgeon in this country, with whom I did my internship. So I thought I will start by telling you my first day and first night experience with him as a young intern, as way back in 1970s. Yeah. And I can vividly remember that first day, and in fact, the first night. The system was such at the time that by the time we settled in after the administrative procedures, which is a little bit different now, was about 5 o'clock and then the visiting hour. So I actually settled in to look at my patients, and I had to get ready for the main ward round next day morning because there were only 2 house officers at the time, and the other guy is supposed to go back to the clinic on the next day. I knew nothing about anything about the patients, and I did not know about my nurses either. So by the time I started my ward round, starting at 7 p.m., by the time I went to the corridor, it's about 11 o'clock, and the nurses have put the lights off by 10 o'clock. Where I saw this young man who clearly looked unwell. He was groaning. He said he went to the washroom and he fainted and walked into the bed with difficulty. He was sweaty. He had a rapid ready pulse. I checked the blood pressure with difficulty with that dark light, dim light, and it was running around systolic around 60. I was not sure whether I was not checking the blood pressure properly because that's the first time in my life, and I started checking the blood pressure with some responsibility, not as a medical student. So this hypovolemic shock just flashed through my mind. Started the drip, collected the blood, sent the blood for cross-matching, and rang for the sheriff. And he has never seen me as a house officer because it's the first day. So all he said was, rush this patient to the theater, I'll be there. In 15 minutes, we were all in the theater. Eventually, the diagnosis turned out to be a subcapsular rupture of a spleen, which he had as a result of an injury he received in the golf screen a week ago when he was cracking a joke with some girls and he was assaulted with a pole on the left hypochondria. So that was the beginning of my internship. So long ago as a youngster, I always thought surgery as a very fascinating field, especially to start my internship. And that is my experience on the first day itself. Because I thought it gives me happiness to help people to get out of complex surgical problems. And especially when I got the opportunity of helping my seniors to get some patients out of near-death experiences when dealing with major trauma and major sepsis. It's a fascinating field, I'll tell you. So our president of the college and the council has laid out this practical program for all of you. To my knowledge, for the first time in the history of the College of Surgeons of Sri Lanka, and I must especially thank our secretary, Dr. Ranga Vikramarachi, consultant urological surgeon at the KDU, and Dr. Amila Jayasekara, consultant surgeon at the teaching hospital, Ratnapur, who was our previous secretary, for organizing this program so well. On reflection, thinking back, what took my mind, I thought in the faculty, I thought I learned mainly the science of surgery, a solid foundation for the science of surgery. But it is during my internship, in my opinion, that I really learned the art of surgery. So what do I mean by art of surgery at the level of internship? Well, to me, it is a set of skills during which I learned for the first time to diagnose with some responsibility. I learned to perform simple procedures. I learned to communicate with patients, with the relatives, with the nurses and other doctors with some responsibility. And also I learned for the first time to work in a professional team in the field of surgery. I don't think I learned these things, but it just occurred subconsciously. And I learned this during my ward rounds, when I clerk patients, when I perform procedures, and when I help senior colleagues to deal with major trauma and sepsis. These are all learning tools. So every patient to me was a learning tool and a challenge. So from whom did I learn these skills? Well, first it was from my consultant. I think you are aware that at the end of 6 months, your consultant has to sign what is called a certificate of good standing regarding your performance, and which has to go to the Sri Lanka Medical Council. But that's not the only reason why your consultant is important. In my mind, the main reason why he or she is so important to you is that he or she will eventually turn out to be one of your best learning tools to learn these skills which I mentioned before. Of course, you will not see your consultant all the time, they are busy birds. So you must try and get the best out of them whenever you meet them, during your ward rounds, in the operating theater, in the surgical clinics, and sometimes in the endoscopy suite. But to get the best out of their experience and expertise, you must impress them with your performance. Actually, what happens in practice is that during the first few weeks, your consultant will observe you to find out who you are. In my mind, most consultants are impressed with 7 qualities of an intern. First and foremost, your punctuality. It is extremely important that you have to be in the ward before your consultant arrives and be ready for the ward round. You must always respond to your emergency calls for on-call days. If your response is lackluster, before you know, your consultant will get to know why, whether you like it or not, nurses are going to tell you. Then you approach to work responsibly. Most interns would have a small book in their pockets. When you are asked to do something, you must make a note. So that's important, the responsible behavior of an intern. Otherwise, you will forget at the end of the ward round. Thirdly, your reliability. You are entrusted with a task, you do the task, you report, and then you do the follow-up. So it's the second one. Approach to work responsibly is linked to your reliability. Then you are enthusiastic to work. You are enthusiastic to work. What it really means is that if you're asked to do something, if you're asked about something, if it's not clear to you, it is important that you clarify that from your consultant or from anyone, so that you be very, very sort of inquisitive in exactly what is expected. And that's a nice learning tool as well. Then your honesty. Of course, people can do mistakes, but it's a noble habit that to accept the mistakes you have created, and then that is the best way of handling when you're honest about yourself. And your kindness, of course, it should come from you. And of course, the way you communicate. So these 7 qualities are extremely important, and you will learn as the time goes by. And if you have that, that really helps to settle in nicely. Remember, your consultant has had many interns before you. So they will pick this up very soon, before you know it. So it is you who can make your consultant your best teacher, your good friend, and sometimes your mentor. Vice versa. Very, very rarely. You might turn out to be that you can make him your policeman also. And that's not a good start. So depending on the hospital, as Professor Srinath mentioned, you will have a team of doctors. You will have senior house officers, you have registrars, you have senior registrars, you have in the university units, you have other professors, you have senior lecturers. All these are extremely valuable learning tools who are inquisitive, intelligent, enthusiastic intern. Also, we meet the other consultants in the hospital from other specialties, other junior. Treat all of them very professionally with a smiling face. In surgery, the anesthetic team is also very important. They are very important in the team in the surgery. They are very important learning tools, and from them you can learn to make the sense out of the physiology you learn in your faculty days and apply that to your day-to-day practice. Anesthesia is the best learning tool for that. You will meet them in the operating theaters, you will meet them in the endoscopy rooms, you will meet them in the ICUs. And sometimes they visit your ward for pain management or preoperative assessments. Treat them with a smile, entertain them, make sure that you help them when they come to your ward, and treat them nicely. You can learn a lot from them. I'll also tell you that if you create bad impressions on the anesthetists, sooner or later that will be transmitted to your consultant, because surgeons and anesthetists are working very closely hand in hand. Of course, different people have got different personalities. Some clinicians, some doctors, junior doctors, senior doctors can have difficult personalities to a young, naive intern. So it's a you who can get the best out of it. And it is an art. And I told you the technique, the 7 qualities, nothing more. Then you have the nursing team. Now the nursing team is led by the ward sister. Of course, above her you have the matron. Remember a very simple fact. Sister of the ward, I think sometimes even consultants forget this. Sister of the ward is the chief of that ward. Consultant, surgeon, is chief for the patient care. So the sister is very important in this entire team. And sisters and the nurses have seen many interns. And you are not the first one. There are many interns to come. They are a different shop factory, a different collection of people. They have their own impressions. I can tell you with my long experience, I can be a bit crude here. The impression about an intern might be very good. It might be bad. Very rarely, it can be ugly also. I've seen that happen. not physically, but your behavior. Remember, you meet the nurses at least 15 hours a day. They are extremely useful to you. They are the people who will help you to acclimatize yourself, to adapt, for you to adapt very quickly to that environment because they live there. They have a lot of experience and experience. Nice to them. Be nice to them. Always smile to them and be with them. They'll be extremely helpful and you can learn a lot from them. Remember, your consultant has worked with this team for a very long time. You will come and go. So if you have frictions continuously, that's not very good for your career. And it will not help you in any way. And it is up to you to get the best from this important team in the entire surgical group. Then finally, remember, irrespective of whether you work in a university unit or in a ministry unit, within the boundaries of a hospital, administrative head is only one, and that is the director or sometimes the medical superintendent of that hospital. That's very important for you to remember. Now, some of the other things which I'm going to say, I'm sure my senior colleagues will also touch upon, but I thought I'll just mention the way you dress during your working hours and at night can create an impression about you, especially on the patients. So, point to remember is that whenever you go to your ward, dress neat. Not dress well, dress neat. Going to the ward in slippers, your own ward. I'm talking about a proper ward going for a work. Going to the ward frequently with t-shirts, especially during the working hours. Untidy hair. They create bad impressions on you by your patients and also by your consultant about your personality. Of course, they may not tell you. Even the consultants sometimes will not tell you. But I'm telling you now. So remember, equally important, the way how you speak and address others. Now, hospital is a place where people expect the professionals to work. They have a lot of respect to us. It is our responsibility to maintain that respect. Remember, when you chat in a ward, patients hear what you discuss, what you speak. Even if you speak to your colleague, even when you speak to the nurse. Rarely I've seen interns fighting in the ward. Now that's pretty bad. It's bad, not only to the patient, it's bad for you because they will create impressions about your personality as a result of that. And also I'm telling you, it's not only for your internship. You'll be going up in your ladder. And when you go abroad, I'm sure a lot of people who are here want to go abroad. And you'll be compared with a lot of other people all over the world. There are people from other nations. Professional communication is an extremely important attribute and is a very important quality to learn and practice during your internship. And that's the best time to learn that. In a nutshell, this is what I want to tell you. Remember, you have a long way to go to reach your life ambition. What you learn in this professional setting, the first professional setting in your life, will greatly help you to achieve your dream. Equally, bad internship, developing bad habits will be a major obstacle to your progress. It is well-known fact that what we learn early in your life tends to stay with us. I have worked with interns for nearly 40 years in Sri Lanka and in the United Kingdom. On reflecting my experience, I've had many very good interns and not so good ones as well. I've had interns who have really learned very well during that 6 months. In my experience, it is very rare to have an intern who gets into the bracket of bad intern. In my experience, and I'm sure my senior colleagues will agree with me, that when patients we operate years ago, when they visit us later, maybe in 10 years, sometimes they used to ask us, Doctor, how is Dr. So-and-so? Mentioning the name of an intern. Even we have sometimes forgotten. In my mind, that is a recognition of a good intern. Because patients are our clients. They are the best judges of doctors. Thinking back, all such interns have done extremely well in their progress and eventually blossomed to be very capable kind and empathic doctors. Of many, that includes Dr. Ranga, who just spoke, and also Dr. Amila, and also Balagopi at the other end. Now, I've finished my part of the presentation, but I thought I will tell you two very simple stories so that you will remember this. My bad experience. I had, when I was working as a base hospital surgeon, I had an intern. He was difficult. I observed that, and I warned him once or twice, and then I've actually been extra careful, extra nice to patients and the nurses and everyone whenever I do ward rounds with him, so that I expecting that he'll learn. And the story goes like this. There was a 20-year-old girl who was brought in. Husband has severely assaulted her, want to kill her, pour kerosene oil onto her hair, and just before that, she managed to escape and got admitted to the ward. So the senior sister, who was very mature, nice, motherly lady, saw this, and because husband has threatened her that she's going to kill him, irrespective of where he's going to go, she kept this lady next to the doctor's station in the examination, because the open space in this government hospital. It so happened that during the visiting hours, when she was asked not to go, she happened to be in the open area, in the floor area, and this boy came and mercilessly assaulted her in the middle of the ward, and then with great difficulty, everyone managed to protect her. And I went to the ward and asked her what happened. And she said this. She said, that sister with this hat, that is a sister, she wanted me to stay here. And there was a tall gentleman with something around the neck, which is a stethoscope, I think what she was referring to. She's very young and naive. Came and said, I will tell in Sinhalese exactly what she told me. And she was chased out. There was a big inquiry. And senior administrative officer from the Ministry of Health came, and eventually his internship was extended. So that's one bad experience. And finally, I would like to also tell you that I'm not going to tell you the ward and it's a surgical unit, but hospital and the wards I will not tell you. One intern was so bad and so rude to the nurses that the day he left the unit, nurses lit firecrackers. So that says it all. May I wish all of you the very best and a most fruitful and a rewarding internship. Thank you.
Thank you, Prof, for that thought-provoking words. Next, we are going to discuss about the first week impression, your behavior, mainly about attitude, professionalism, and ethics, which will be delivered by Prof. Ranil Fernando. Again, no need of introduction. So, over to you.
Thank you very much, Dr. Balagopi. Good morning to all of you. Can you all of you hear me? Can somebody respond?
Yes, sir, we can hear you.
That's great. Thank you very much. Right. I must thank the President, the Secretary, and the organizers of this Congress, of this symposium, for giving me time to talk to you on various aspects. Now, I have actually summarized this into two things: the conduct of a doctor and professionalism. And I must thank Mohan, because Professor Mohan De Silva, because he has actually outlined most of the things that I would like to say. So it's a case of me trying to summarize things. And at any point, if you want to talk or ask a question or stop me, please let me know. So you know me, I'm Ranil Fernando, and it's going to be the conduct of a doctor and professionalism. As it has already been mentioned, as individuals, we have our own pattern of behavior, and that's not going to change, and we don't expect that to change. And whatever I'm going to tell you now is may or may not be qualities that you already have, but it is very important to focus on these qualities so that you can improve and develop them throughout your professional career. So nobody expects you to have all these things to start with, but certainly we hope that if we point the way, that you will acquire most of these qualities during your professional career, because you are just starting. But as a doctor, we must practice certain well-established professional values. I think that is the first thing to remember. All of us must know exactly what these professional values are. And it goes without saying that the doctor's first concern, apart from everything else, and everything takes second place, is to take care of the patients properly and to practice medicine safely and effectively. So all these attributes, these qualities, and all the other things that we will discuss should contribute seamlessly for you, enable you to do this thing of practicing medicine safely and effectively. Please remember, this is because the patients expect certain things from us. They trust their doctors or us or you because they believe that in addition to being competent, now that goes without saying, you as a doctor have to be competent. You must know what you're doing, and that your training and your medical school knowledge will give you that. But you must never discriminate in any way and treat everybody equitably and not take advantage of them. And Professor Mohanty has already told you a couple of instances where these things have not happened. And patients believe that the doctor will display qualities such as integrity, truthfulness, dependability, and compassion. Now, all these things all of you know, but the only thing is, unless you keep reminding yourselves about these things, in practice, sometimes these things don't happen. But we have to remind ourselves, very important: integrity, truthfulness, dependability, and compassion. And patients also rely on their doctor to protect their confidentiality. Now, in Sri Lanka, these things are a little bit difficult because sometimes the relatives come and tell us, don't tell about the illness, don't do this, don't do that. I think that's a very difficult thing. And you need to use your judgment because the doctor's main relationship is with the patient. So about making decisions, about revealing information, not telling the patient. Now, this sort of thing you will always come across. And please seek advice from seniors if you have this problem, because I think it's a very sacred and important relationship between the doctor and the patient and confidentiality. So it's a very important thing to remember to maintain confidentiality. Then doctors must be ethical and trustworthy. And the last bit I like very much, they must command respect. You cannot demand respect. To command respect, there are many things. It's your behavior, it's the way you treat them, it's the way you talk to them, and so on and so forth. And doctors have a responsibility to protect and promote. Remember, it's not only the ward, the whole community. So all these things, you will have to focus and remember these professional values and practice them and continue for the rest of your professional career. And let's look at more specific things. Attributes of a doctor. I think Professor Mohanty has outlined some of these things. I'm going to summarize and go through them again. I think this is probably the most important in my mind. You should be able to gain the trust of the patients. If the patients don't trust their doctor, they will not reveal all the information. Not only that, they will probably not comply with what you tell them. So it is so important, and this will have to come with practice. And you have learned this in various streams in the medical school and so on and so forth. But this is a thing that you must develop, the trust of the patients. And punctuality. Again, Professor Mohanty has told you, I'll tell you one thing. I know for sure doctors have lost a bit of respect in this country. Punctuality is one of the reasons. If you are supposed to be in a place at 8 o'clock, you better be there at 8 o'clock because the patients have come at 5 o'clock. So it is so important, particularly in clinics and so on. One of this punctual tardiness or not coming on time is a real malade or a problem with our doctors. So try to be as punctual as possible. And those students who are there in the audience, who are my students, will know that they cannot be even 5 minutes late in our ward. And dress appropriately. Again, Professor Mohanty says, I just want to ask you this question. Please remember the doctors that you would like to go to. Would you like to go to some doctor without who has not combed his hair? Would you like to go to a doctor who has not shaved or changed his dress? I remember when we were interns, there were a few people in the OPD where the patients used to avoid. They would wait for the turn and go to the next doctor because they did not like that doctor, particularly from their dress and so on. Then communicate effectively. And I think I put within brackets with compassion. You know, one of the qualities that you have to acquire and learn is this thing about compassion. This is what patients expect from us. So please remember that. And then this is also another quality that doctors must develop, a strong mindset, because we all have to deal with very difficult situations most of the time, sometimes life-threatening things. So if you are a weak-minded person, you fail and you sort of dither and you don't do your job properly, that won't do. This is not being unkind, but mentally you're strong. You can withstand and you can support the patient. You can have your own emotions later, but when you are working and when you're dealing with a patient, you need to have a very strong mindset because you want to be clear in your thinking and make decisions appropriately. So it's very important. Then also, you're accountable. Professor Mondis has always said, honesty is one of them. If you make a mistake, please accept it and say, sorry, yes, I made a mistake, and so on and so on. And you are accountable. Accountable not only to your boss, to your patients, to the ward staff, to everybody. And you are a team person. There are various grades in all sorts of wards. So you must learn your role as a team member. That is another very important quality. And maintain confidentiality, I already told you. This is another aspect that you will come across, that you must balance your personal life with professional life. Now this during internship is a bit of a difficult task because the word intern means that you're in prison. So you're not supposed to leave the premises very much. The whole thing that you're available 24 hours. So that's a little difficult, but you need to think about it. Otherwise you could get frustrated and you may not do your job properly. So try to think about balancing your personal and professional life. But and seek, this is another one as an intern that you must always do. You must look for new knowledge. Update your knowledge regularly. Read whenever you can, look at journals and so on. Perhaps even think about what you want to do for future and try to read a little bit on that as well. But remember, in the early part of your professional career, you will have to make certain sacrifices. And most times, what happens is, you will have to sacrifice a little bit of your personal life for your professional life. So, but hitting the balance is a very important thing. Right. So now there are other special considerations for a doctor and a professional. Number one, good medical practice of patient-centered, I told you that. It involves doctors understanding that each patient is unique and working in partnership with the patient, because you see patients' level of knowledge, their social status, the way they think about problems, their ability to reason out, all these things change a lot from patient to patient. So you need to understand this and then try to cater to the needs of a particular patient. And it's a partnership between you and the patient. That's a very important thing to understand. And also, you must realize that without even thinking, sometimes these social and cultural differences may impact the way you look at patients and treat them. We must avoid that. We must treat everybody equitably. And this professional embodies all qualities described, what I have described, but what I have highlighted, self-awareness and self-reflection. Please take some time to do some reflection about what you did and the things that mistakes you made, the good things you have done, and how you need to change your methods of treatment or whatever. But self-awareness and self-reflection during internship is a very important thing. It will set you on the right path for the rest of your journey as a professional. And you will learn every day of your life. I have been in practice for more than 35 years, but I learn every day. And I am not ashamed to tell that. I will learn something even today. And you will learn from everyone, including the so-called, I don't like that term, minor staff in a ward. There are many, many things you can learn from everybody. Never be ashamed to learn from anyone. And at the final MBBS exam, core knowledge and basic skills have been tested, and you all are competent in those things. And then that is why you are permitted to work as an intern. During internship, then you will get experience and so on, then you'll be a doctor. But does it prepare you to be a professional? Perhaps. But I think this aspect, you will actually start learning very well and practicing when you're an intern, the professional. So, what is the ideal conduct of a professional, particularly a doctor? Now, there are many definitions, but I found one which encompasses everything that we have to do, and it is very saliently put. And it is actually from the Rochester School of Medicine, written by a general practitioner and a medical educationist called Epstein and Hundred. And it says, just like in evidence-based medicine, professional competence is habitual and judicious use of communication. First thing is communication. You must communicate properly. Knowledge, technical skills, clinical reasoning, emotions. Now, all of us have these things. Values and reflection. See, it encompasses everything. In daily practice for the benefit of the individual and community being served. So if you can follow these things, if you are judicious, if you habitually use knowledge and good communication, technical skills and so on, then you are a professional. So during your internship, you need to develop these habits. Practice of medicine is a lifelong process. You must enjoy it. It is hard work, there is no doubt, particularly during your first, till you become a senior registrar or a consultant, it is always very, very hard work. You need to accept that and then adapt yourself to that. There is art and science to medicine, but art is the more difficult thing to learn, but you must. This art you will learn till the end of your career and perhaps till you die. So this art is something, the way you communicate, how you get on with the others, and all these soft skills, as somebody mentioned, you have to learn the art. And then only will you be a proper doctor. Let me finish with my favorite saying. The first thing you must remember as a doctor is called primum non nocere, or do no harm first. That should be your first aim. As an intern, please remember this forever. Every day, please tell yourself, I'm not going to do any harm. And the second one is given by a Roman philosopher called Cicero. And please remember, in nothing do men more nearly approach gods than in giving help to men. And this is why it is very true. And this is why this is probably the only the profession that gives you the best satisfaction. And this is the one that makes people respect doctors so much. So there is a lot to remember in these two last lines. First, do no harm first, and remember, people treat you like gods for what you do to them, and you have to respect that and give something in return. I know it's a long journey and it's a long process, but I also want to wish you good luck. Thank you very much.
Thank you, Prof, for the kind advices for juniors. The next, we are moving to the next discussion, which will be delivered by Dr. Mahanama Gunasegara, Senior Consultant, excellent academic and good administrator. He's going to talk about the daily routines of a house officer, which is expected by a consultant, and how to arrange yourself as a house officer. Over to you, sir.
Thank you very much, Dr. Balagobbi. And first, I would like to thank the current president of the College of Surgeons of Sri Lanka, that is Professor Srinath Chandrasekhara, for organizing this excellent workshop. I think, as Professor Mahan Silva mentioned, it is one of the first efforts to improve the quality of internship of yours. And then I would like to thank Professor Mohandi Silva and Professor Anil Fernando, who have been mentors to me in many occasions in my life. So you have been lucky to get excellent guidance from them early in the morning. So now There's hardly anything for me to say. So therefore, I would like to describe your first day and the first week. Wow, you have become a doctor. All this time you have been playing doctor at home with your siblings, giving injections to your pets and dolls and things like that, and dreaming to become a doctor. And now, really, you have become one. What happens on the first day? You come to the hospital. You have to meet the directors. Usually, nowadays, they call you to a audience, the auditorium, and they will speak to you. And my house officers have been telling me what happens on the first day. So I know what happens. Sometimes you travel from far away. My house officer, who is the second in the merit list, passed out from Peradeniya. She is from Kandy. She came to Colombo with all equipments, what she needs. And there was no place to keep. So she had to find a friend and then kept all her stuff, which including what the things needed to clean the bathrooms. And he kept all that and came back to the hospital. So therefore, be ready. And sometimes the hospital has been seeing house officers for a long time, and the hospital doesn't take it very seriously. So therefore, come to the hospital and keep your stuff somewhere else. Come to the hospital with your, probably dressed with your best official dress, and come into hospital and see these directors. And they are the first thing that usually do is they give a list of consultants, and then you have to select your appointments. And my present house officers tell me they have done an interesting thing. Before they came to the hospital, they had WhatsApp group if all the involving all the interns coming to National Hospital. And they had been discussing who the consultants are. They had already decided which first man is going to select and so on. They had a very good idea what is going to happen and who is going to select what. And unfortunately, they told me their directors played hell and they had a very bad arrangement to select. And then some people ended up with pediatric surgery and pediatrics. So then they had to advise the directors as to what to do, how to allocate them proper internship. So sometimes being prepared helps everybody. So that's what I do. Then after that, you allocate to your consultant, you go and meet your boss. And it's good to know the timetable of the ward. So probably you can find it out on the first day, on the previous day. What is happening on Monday, what is happening on Tuesday, then you have an idea where the team would be on that day. So you can go and meet the consultant in the theater or in the clinic or in the ward rounds or whatever. So then you speak to him, go back to the ward. As Professor Bhandi Silva mentioned, the most important person in the ward in official capacity is the sister. Many people underestimate. Actually, all the patients are under her care, and all the consultants are supposed to speak to the sister, and sister should introduce her patients to you. So, you being the house officer, you are the next person who knows all the patients. But on the first day, you may not know. So you speak to your sister and just get to know the staff that is there on that day, and there are a few things to learn. One of the things when you start your work is, again, my house officers have been telling me what difficulties they had, because things have changed over the years from my internship time. So I got little advice from them as what is happening now. So when you come to the ward, you just, there are a few things that to learn. First, find out where you are going to sit and where you are going to clap, where is your examination bed, and just learn the request forms, lab forms, and then what the patient's notes look like. I'm sure you have seen them, but if you have not done it, before you start your work, read all the investigation ordering forms, where the name is, age, BHC number, what are the things to read, things to fill, and where you write the consultant's name. You don't have to waste time to write the consultant's name and all the credentials. There is a frank, so you can use that. And sign where you have to sign. Don't write the name where you have to sign. And like that, you study that form. And then you understand it better. And similarly, you must find out what are the other details where you do various references, sending patients. So see the timetable, see where the clinic is, see what are the, check the names of the consultants at in other units where you may be referring patients, and then where the pathology lab is, where the microbiology lab is, where the radiology department is. If you are not familiar with this hospital, we have just come in, you better understand the anatomy of the hospital, and then find out the names involved and where you are going to work with next few days. Then, of course, once you have learned that, remember that you can learn so many things from everybody around. One, your consultants, you will meet less frequently, but you will be meeting your senior house officers, registrars, senior registrars, and particularly the sister and the nursing staff, and even the minors. These people have been working in these similar wards for a long time. They have seen many house officers, they have seen your mistakes, they have seen your good things, they have seen how committed you are, they have seen how you spend sleepless nights in the wards. They are respectful and they expect you to look after their patients. So they will be very happy to help you unless you go and spoil it. So therefore, first aid help, you try to get the help. When people like, when you ask for help, generally they like to tell you what they know. So that is a secret. Rather than you telling them, it is better for them to tell what they know. So therefore, always be friendly, ask them what you want to know, and find out where various things are there. That is one of the things that my house officers tell me all the time. I ask them, what were the difficulties in first? So one of the things that they tell me is they don't know where the forms are, they don't know where to take blood, where to find the syringes, they don't know where to find the saline bottles, where to do the wound dressings, where the surgical spirit is, and so many. So find out those things, and your ward staff will definitely help. And then, of course, you should be equipped with the things that you when you start the ward rounds. Of course, you will carry a stethoscope. May not be the most useful thing in the surgical ward, but I think torch would be better. And the notebook, Professor Mohandi Silva told you. And one of the things that saved me during my internship, as well as during my registrar period with a tyrant consultant who was very excellent teacher, but always very tough on me. But I was very happy with him. One of the things saved me was my notebook, because I had been writing little things, whatever, that I pick up during the ward rounds, and what my consultant tells me from time to time, that was with me. That was very easy at the end of the day, not to forget things and then complete your task without having a lot of things missing. As I told you, sometimes the blood pressure apparatus, sometimes the knee hammer in medical wards, and any other equipment that you may think is needed. And with time, you understand these are the things that you need all the time during ward rounds, maybe 2 pens. Red pen may be useful sometimes for you to see, highlight things for your references itself, and be equipped and go to see your patients. Now, what are the things that you see? Firstly, your priorities. You set up, organize your work, how you start your work. One of the things that I used to do was to look into emergencies first. And sometimes there are things called stamp cases. Sometimes in some hospitals, the emergency admissions come with a special colored form. Or sometimes your system will, they're nothing like that. It's a simple hospital. You don't have all these sophisticated things, but your system will tell you these are the new patients who are admitted as emergencies. So it would be useful for you to see the emergencies first. So after attending to very urgent problems, including pain, pain is an emergency. And after that, you probably may not be the first day, but the second day onwards, you just see whether there's anything else that you have left on the previous day to complete. And similarly, whether there are any investigation reports that you have asked on the previous night, which has come as an urgent report in the morning, and you must make sure that all the new reports which have come to the ward are seen because that is why you have ordered it as an emergency, is that it has to be seen. And it has been observed by many that some urgent investigations that has been requested has not been even looked at. So then, having done that, then after that, you start your daily ward rounds. Generally in a surgical ward, we used to start in the post-operative cubicle if it is a separate thing, or post-operative patients are generally kept in the front of the ward or in the cleanest area of the ward, and you start your ward rounds there. So one of as standard things, I am sure you have done professional appointments, you know what to see, but the temperature chart, the drip, what is happening, what is going on, and then of course the drains, what is happening to the wound, and as I told you, whether the patient is in pain, and input-output chart, and always make sure every day go through the drug list. Every day go through. There may be drugs that has to be added. More than that, patients are on drugs unnecessary, and try and remove the drugs that omit drugs that are not needed anymore. And talk to the patient all the time. Talk to the patient. As Professor Mahadi Silva said, house officer is the one who is closest to the patient all the time. Patients waiting in the morning to meet a doctor to tell their problems, so that you are going to listen to them carefully. And always, when the patient is telling you something, listen to them attentively, and that will help you, and that will avoid many problems, many embarrassments that you are going to face during the rest of the ward round when the consultant comes. Other thing is, as I told you, the investigation reports, you have to communicate with the lab if there are urgent things, or where your consultant has wanted you to find out, you have to talk to the lab. So therefore, you know the lab staff. You must go and once in a way speak to the pathologist, microbiologist, radiologist, sometimes a consultant anesthetist, and sometimes other consultants in other wards. So try to find out all the information required during the ward rounds. And any reference to be made, find out who the consultant on call on that day is. That will be very useful for you to tell the consultant when he is doing the ward rounds, today you are going to refer this patient to the orthopedic surgeon, this is the orthopedic surgeon who is on call, and so on. Similarly, when you are, other thing is in the operating theater, it would be useful to have a little summary of the patient, particularly if it is a major case. And on the previous day, you better go through all the investigation reports, pathology reports, radiology reports, and any other cannulas, drugs that has to be sent, or any other equipment, surgical equipment that has to be sent from the ward. Think about it. And when you go to the theater, take the notes and see whether all imaging is available. Imaging is one of the things that surgeons always look for just before surgery. And if there is imaging, even a chest X-ray, display it. That would be very useful and comfortable for you. And always make sure that the particular imaging is the correct one and that belongs to that patient who is to be operated. And that when that surgery is over, immediately remove it from the display, and then of course insert the new one. And another useful thing is to have a discharge summary. And some hospitals, it is compulsory to have a discharge summary. There's a separate form. But other hospitals, they don't have discharge summary. So you write everything in the patient's notebook or in the diagnosis card, whatever it is, complete those tasks early. If you know that the particular patient is to be discharged next day, you try and finish it today itself. And internship, there are a lot of things to do. Therefore, try not to postpone things to the next day. Always try and finish most of the things on the same day, because next day you do not know what will happen, and because you are still not yet used to the setup, there are new things, more things happening on the next day, then you have more free time to attend. End of the day, there are a few things to do. And when you go back to your quarters, speak to other colleagues and see what happens. what difficulties they faced, what tactics they used to overcome difficulties in the hospital, deficiencies in the hospital. Always help others, always think about others. When you help others, others will be willing to help you. And as Professor Mahadisilla said, you are one of the most loved doctors. So doctors always remember their house officers. So you talk to them and don't forget that you are the most sick doctor in the world. So talk to them nicely and try to create a friendly environment in the ward, along with patients, staff, and other doctors, colleagues, and other consultants in the hospital. Thank you very much and wish you good luck.
Thank you, sir, for the valuable advice. So 3 experts have finished their discussion. So in summary, you are going to be house officer. So treat your ward as a house, make everyone happy, be flexible, and enjoy your career. So thank you very much again for the experts. That concludes our first symposium. We are moving to the next talk. Next talk will be delivered by Dr. Jayendra Fernando, Senior Consultant Surgeon and our immediate past president. He's going to discuss with you regarding the communication skills, the very important communication skills, which is expected from the house officer. Over to you, sir.
Thank you, Balagobi, and good morning, ladies and gentlemen. I am privileged to speak to all of you on this very important topic, which is an integral part of practice. It is not a separate subject, but part and parcel of the intern and surgical practice. So I believe you have already been a good communicator because you have been able to communicate your basic core knowledge and skills to your examiners in order to be here, be qualified. But I'm going to share with you some thoughts that may help you in your work as an intern and later in your career. So I want to start with a little story from my own internship, where my consultant had prepared a patient for surgery, and I had to get the consent. And so I got the patient seated and was giving this patient a very long, clear explanation that he's going to have a hemicolectomy and the form of anesthesia. And when I asked him to sign, I found that he was not really ready to give consent. And then it struck me that actually I had done some very basic errors in my excitement. Communication is not a one-way process of talking or writing. It is a two-way process. So one part is to talk and to give information. And the more important part is actually listening. So that's the first error I had made. The second thing is that I realized that communication is not only words. There are 3 things in communication: words, voice, and body language. And it is said that about 55% of communication is actually body language. About 40% is the voice, and just about 5 to 7% is the actual word. But remember that though it is a small component, the specificity of your communication is through the word. So it has to be very carefully done. So over some time, I actually got into the practice, and I learned from colleagues, seniors, that it is always good when you communicate either orally or over a telephone call to have a certain format. So first, we need to be identified if you are not already identified by person or not been introduced. And then you need to have a greeting, because that establishes the rapport. And it is good because during internship, time is short and the message you have to give is fairly serious. This is not a social conversation. So it is good to, mention the purpose of this communication. And if I may use some slang, it is good to cut the crap and be on a very specific note. As has been mentioned already by my previous colleagues who made presentations, it is always good to keep a note of actually what you are going to talk or what you are going to speak on the phone. And while I'm communicating this to you, I have a note myself so that I don't miss anything important. And the notebook has been emphasized over and over again. And something I realize is, do not hint and hope that the correct meaning will be portrayed, but be very specific in trying to portray the exact meaning you want to convey in your communication. And in the same way, when you are listening, try to get the exact meaning. And if it is not clear to you, you need to tell the person who is talking that you don't understand and to repeat it. Now, already, I think my colleagues have mentioned that communication involves for an intern, it may be communicating with the patient's relatives, your own consultant, your own co-house officers, other colleagues, the nurses, very important, other junior staff in the ward. And then from the ward, you go outwards. You need to sometimes communicate, as has been already mentioned, with the anesthetist, the labs, the other consultants, and so on. So remember, as a young person, don't wait till the information comes to you. Sometimes it is better to just be on your feet, go to the place where all this information is available, be it the lab or theater or wherever, and get that information and come back. I found that during my internship and registrarship, this was very fast, reliable, and I had the information where it was required. So a very important aspect of an intern job would be to give information. Now, I cannot overemphasize that a lot of complaints about Sri Lankan hospitals is not about the patient care, but it is the fact that information regarding patient care has not been delivered. So I think the intern would be in a very key position where it could be required to give this information. Now I want to introduce to you two words, which is very important as a principle. The traditional concept of giving information has been called the prudent doctor, where the doctor knows what best to give. Coming back to my story that I started, I had given a detailed explanation about the surgery, and that is what I thought was important to give. But that is not what is required nowadays. What is required nowadays is the principle of the prudent patient. That is, that the patient, you need to give the information what a normal patient would like to have, and the specific patient that you're dealing with wishes to have. So it is not the prudent doctor principle you need to follow. It is the prudent patient principle that we need to follow. And then, of course, patient is your responsibility, but sometimes you need to give the information to the next of kin. And as has been already mentioned, you need to be very, very clear about confidentiality and the ethics. And if you're in doubt, please ask your consultant. So, one day, I was woken up when I was a consultant. I was woken up at 2 in the morning by a very enthusiastic junior doctor who said that there's a patient admitted under me with Ogilvie syndrome. Now at 2 in the morning, coming out of a deep sleep, I couldn't remember what is Ogilvie syndrome. Then actually I was very honest and I said, I don't know what is Ogilvie syndrome. Then he said, no, there's a patient admitted with a dilated large bowel. My point is, that is jargon, obscure, pretentious language. Try to avoid jargon, even with your consultant and your colleagues, and particularly with patients. Now, in that story I told you at the very beginning, I was probably using jargon, using words that patients don't understand. Now, if I tell a patient
we are going to do a lap chole, they might not know. But if I tell them we are going to remove the gallbladder, then that will strike into some understanding. So avoid jargon. And then consenting. Consenting is a very, very important role of any doctor-patient relationship. And coming back to that first story I said where I was trying to take the consent, the patient was not responsive because my explanation was in Sinhala and this gentleman didn't understand Sinhala. So language is a very key thing. And the next thing is to know whether the patient has capacity to consent. Same story. That patient was actually poor in hearing. So he didn't have the capacity to understand what I was giving and thus no capacity to give consent. And as junior doctors, please remember that patients have a right to refuse consent and you must respect it. So consenting is a complicated process. I think you will learn it as you go on. But remember these small things to start with. And then we are in a funny job where things go bad at times and there is bad news often. And you need to convey bad news to our patients and their loved ones. So there are a few things you can do to soften the impact of bad news. Always start with the positives. And in life, bad news comes also with positives. There's always a silver lining. So mention that first. Then don't blurt out all the bad news in one go. It will be hard for a patient and the family to accept. Take it one step at a time. Sometimes we spread the bad news over a couple of days or maybe a couple of hours. So take it step by step. Just make sure the patient is understanding and is able to tolerate it. But finally, you are not supposed to withhold any information from the patient. Your relationship is with the patient. Unless there's a serious reason to withhold information from the patient, ethically, you are bound to give all the information to a patient. But you have to do it gradually and with some responsibility. And always empathize. Try to understand the patient's situation when you are delivering this bad news. And be guarded. Don't give statements like probably life expectancy is only 1 week. Supposing this patient lives for 10 days, you will be found to be a liar. So be guarded. And as a junior doctor, be safe. And do not blame anybody. Now, whatever good you do, sometimes you get very difficult patients and very difficult relations. And I'll just give you a little hint that you can use in a difficult patient. 3 steps: isolate, negotiate, and refer. So if there's a group of people who are, being a bit violent and difficult, you need to isolate the patient from the others. Try to negotiate and come to a settlement. If you cannot, refer this to another, maybe senior person or your consultant. One important aspect is something called emotional intelligence. Our emotions can be actually plotted on a graph on 2 aspects: the level of energy. At the moment, my level of energy is high, and the level of pleasantness high. So I'm happy. Now my patient may not be the same. Patient may be very lethargic and low in energy level and be very unpleasant because you have given them a bad diagnosis. So try to understand this and try to match and try to bring the patient towards a good emotion. Finally, I got a call one day and said, "Sir, the Korean patient is giving trouble." Now, what does this Korean patient mean? It does not mean anything. If I was told the patient with appendicectomy is having some problem, then it means something. So don't use any discriminatory or bullying language in your communication. It's very important. Try to avoid indecent gestures and language with your patients, relatives, and colleagues. So, ladies and gentlemen, I like to summarize by saying that I have rearranged the few facts I have given you, 10 in fact, in alphabetical order. And I will just read it out to you. So A for aspects of communication, B for bad news, C for consenting, D for difficult patients, E for emotional intelligence, F for format of your communication, G for covering ground, H for harassment and discrimination, I for information and disclosure, and J for jargon. I finish my 15 minutes of allocated time by saying that today's intern is tomorrow's consultant and community leader. I wish you very best and hope that one day few of you will be here delivering this message in a much better way that I have attempted to do. So good luck to all of you and enjoy your internship. And that's the main thing, is to have fun. Thank you very much, Professor Srinath Chandrasekhara, Dr. Amila Jayasekara, and Dr. Ranga Vikramarachi for organizing this and giving me this opportunity. Thanks. Bye.
There's a small housekeeping message. Could you please display your name? Use the same name for your device, the name you used to register, please, so that we can mark your attendance. The next will be Dr. Mahinda Malwatantri, consultant surgeon, who's going to brief you about how to handle a surgical priority case. Over to you, Dr. Malwatantri.
Good morning, all of you. Can you all hear me clearly? Hope that all of you. All right. Okay. Good morning. And I would like to thank College of Surgeons, the President, Secretary, and Dr. Amila Jayasekara for inviting me to give this lecture. And it is like your first day now, right? You are very excited, and then I'm also very excited as a consultant because you are new, right? So basically, what you see in ward setting is admissions coming through various sources, right? So when you get admissions through the OPD, it can be an admission which is coming straight away through the OPD without going into primary care unit. And most of the hospitals, for you all to be aware, there is a place called primary care unit where the medical officers, they admit the patient. They see the patient's problem, and then they see whether there is any acute problem where they go ahead and then resuscitate. Sorry about these technical things. Then I think I need to get back to my previous slide. So if you all have seen, give me a little time for me to get this thing closed. Can you all hear me clearly? Right, if you all see again that a scenario, if you all have seen this slide that I have given you, a young man coming to the primary care unit where the medical officer sees the patient without any serious physical signs, and he's talking and he's very stable. And his pulse rate is normal, his blood pressure is normal, and he's talking nicely, and you don't feel anything bad about it. And then you think that everything is fine. Okay, what's the big deal about it? He's complaining a little bit of left lower chest pain. He had a little bit of alcohol with his friends, few drinks, and smell a little bit of alcohol and smiling. And once in a way say that, doctor, I'm having a little bit of pain lower down there. So he will stay like that, or he might change his picture after a while. So this patient probably will stay in the PCU or the primary care unit, or a medical officer will contact you, the ward, the on-call SHO, and then SHO will say it's in the night, 11:30, not a very good time to get an admission like this. Just over the phone, tell the house officer, okay, there is a patient, will be coming to the ward. We'll take the patient and then we'll have a look. You take the history and then just keep an eye on him. So after a while, the picture changes. In 2 hours time, suddenly the pulse rate goes high. The blood pressure falls. And then most of the time when you manage emergencies, sometimes you do initial blood investigations, what we call full blood count, and then some other investigation that you think is justified, maybe chest x-ray in the PCU. You will do suddenly get panic, right? If you don't keep an eye on this patient, right? If you think this is very simple, like just a little bit of pain, and then he had alcohol, right? You sometimes feel like, oh, he's coming right in the middle of the night and enjoy it with friends, and then now he can't look after himself, had a fall on the stairs. So this is what you see, right? So you see sometimes the case comes with all the deteriorating signs, and then sometimes the medical officer admitting the patient will detect it, and then they put the stamps saying inform HO stamp, right? Just imagine that this patient just come to the ward, and then if you don't look after the patient, and then if you don't think seriously about the mechanism of injury, the patient will deteriorate without anybody's notice. So the patient may be deteriorating slowly, and you don't anticipate what can go wrong. So the stamp or not stamp patient, whoever comes into the ward, you need to think about these things. You have to think fast, especially in the night, because that few people are around, and sometimes some of your colleagues are not in real mood. Sometimes maybe there was a party, or maybe some are enjoying with some friends, right? So you are always very effective in your communication. So to be very effective in your communication, you need to get all the relevant information properly. So there is a thing called golden hour, right? So this golden hour is very important, whatever the specialty you do, and that includes surgery as well, right? And then there are certain guidelines how to manage patients when it comes to trauma, when it comes to acute abdomen, right? So do work out about the patient yourself, right? Don't depend on others' information. You check the patient, you talk to the patient, talk in a language as my colleague Dr. Jayendra mentioned, a language that they can understand, especially when they are under influence of alcohol. You have to be a bit careful, you have to go slow, and then not to get annoyed with the patient's behavior, right? You collect the relevant information. Maybe if you don't get the relevant information from the patient, maybe there is a company person or maybe a group of people, you need to get hold of somebody who you can get direct information. And then just do a quick run through about the patient, right? You talk with the patient. If he's not talking, then you need to think why, right? Is it the problem that comes with, or is it something else? Intoxication, maybe a head injury, right? And then once you do your initial bit of assessment, so you have to document it nicely. So there are pitfalls. Sometimes young people don't show any signs of deterioration till the last moment. You need to think about this. Sometimes patients with various medical problems, patients with various drugs on board, like beta blockers, antiplatelets, anticoagulants, right? Their picture is totally different. Even the slightest injury, they might be having a weak hematoma. With severe bleeding, they may be having normal pulse rate. So all this information is important. So you need to communicate, gather information, look for sinister signs of various presentations if you think the mechanism of injury is not that simple. And then when you get too much of patients or a group of patients, we'll say that you see road traffic accident, patients coming in and then few to attend, right? So you need to look into what you call something triage. You identify the bad patients first. The ones that you can't attend, then you leave them. And then the last but not the least, think as a team member. When you think as a team member, and then when you are clear about your responsibility as a house officer, and then how far you can go, then it's very easy. You help each other, your colleagues, your other house officers, your senior house officers, your registrars, senior registrars, your consultant, whoever is there in the team. If you work together, it's very pleasant. There is no big stress. Communicate. So, very important message in my lecture to you is always do your bit, do a self-assessment of each and every patient. Don't depend on somebody else's pulse rate documentation. Don't depend on somebody else's Glasgow Coma Scale scoring. Don't depend on blood pressure reading. Just make sure that you do it at that point, and then always revive the patient, and then always check the patient again. It's not only once, till the patient is stable. Or if somebody comes stable and then get deteriorated, and then you resuscitate, and then you make sure patient is safe and not deteriorating anymore. If there's any special management that the unit seniors or the consultant decides, then you can help. So this is how we deal with admissions, and always think stamp may not be real stamp. Sometimes the medical officers, they just stamp, or maybe the minor staff who take the patient, they mistakenly put the stamp, right? Or maybe that's the case that should be stamped may come as not stamped. So I would like to wind up here, and then I hope you all got the message, and then it's the communication and always be accountable, and then think rationally, stick on to protocols. Different hospitals has different setups, so you will get adjusted very soon after a few weeks, right? We'll say that 2 weeks, it's more than enough for you to adjust yourself for the setting that you are fitting in. Good luck, and thank you very much for all of you. And then I'm looking forward to see you all soon when you start your internship. And good luck.
Hello. can I make a small message from the organizing side? There are a few lines drawn on the screen. Technically, we won't be able to make any changes here. So the person by mistake who has drawn the lines, could you please undo so that we can maintain the clarity of the screen, please? The time is 10:01 and another 4 minutes we'll be starting, and we'll take a 3-4 minutes break now. And we'll be starting with Dr. Duminda Ariyaratna's presentation, hypervolemic patient, role of the intern. Hey, welcome back to the program. Next presentation will be by Dr. Duminda Ariyaratna, consultant surgeon. He's going to talk about hypervolemic patient, role of an intern. Over to you, sir.
Yeah, good morning, everybody. Hope you can see my screen. Can you see my screen?
Yes, sir, we can see.
Can you see my PowerPoint?
Yes, please. Yes.
Yeah, so bear with me a minute, right? Good morning, everybody. The topic that has been assigned to me today is about management of the hypovolemic patient and the role of the intern in managing this condition. Actually speaking, hypovolemic patient is quite a common encounter in surgical practice, and the intern is the one who will institute the initial management of the patient. Just before I elaborate much on hypovolemia, let me tell you the fluid compartments of the body. Excuse me. The fluid compartments of the body, when you talk about it, 60% of a person's body weight is the fluids, out of which intracellular compartment, as you all remember, has 2/3 of it. Extracellular compartment has 1/3. Out of this 1/3, only 1/4 is in the intravascular compartment. This intravascular fluid compartment is very important to perfuse the organs, vital organs and the others. You have a little bit of transcellular fluids which do not contribute to circulation of fluids, like the fluids in the CSF and the eyeball. So with that background knowledge, let me progress further with the hypovolemia. Hypovolemia means reduction in the intravascular volume. It's not the reduction in total body volume of fluids. Dehydration is the condition which is called reduction in the total body fluid volume. So hypovolemia is intravascular fluid volume reduction, which leads to shock with reduced organ perfusion. We are worried about perfusion of vital organs here. Vital organs are the organs which are vital for bodily functions: the brain, the heart, the kidneys, and the lungs. So vital organ hypoperfusion is lethal. So what are the causes of hypovolemia? Commonest cause of hypovolemia that you would encounter as a house officer would be the blood loss. The blood loss that happens due to trauma is quite common in any part of this country. And then patients sometimes present with hematemesis. They bleed a lot of blood and they present it with hematemesis or melena with resultant blood loss. And the patients with ruptured ectopic pregnancies will come into your surgical casualty due to a misdiagnosis. Sometimes they will think it's appendicitis or something other than that. And you will be don't be surprised if you find a gynecological cases coming into your surgical casualty. So ectopic pregnancy is one such case where the patients will come with hypovolemic shock. And then ruptured aortic aneurysm in the elderly patients, if they come with unexplained hypovolemia, you have to think of that diagnosis. So these are very common diagnoses, but the list is this is by no means complete. And there again, you have an increased third space loss. Whereas if you have a patient with intestinal obstruction, the fluids will accumulate inside the bowels. In pancreatitis, they will have fluid accumulation inside the tummy as well as inside the peritoneal cavity as well as inside the gut. So these fluids will constrict the entire body volume, and hypovolemia will result as intravascular component will also be constricted. And there again, the fluid will be lost through skin in case of extensive burns and diarrhea. So all these will cause hypovolemia. So this is a very common sort of a grid form of putting through the stages of your shock. I'm sure you all are familiar with this in physiology. The amount of blood loss and the amount of shock. We have divided shock into stages: stage 1, stage 2, stage 3, stage 4. Until your blood volume is lost by 750, you will not see a increasing tachycardia. So tachycardia will set in after about you have lost about 750 ml of blood. That you have to remember. If the patient has tachycardia, that means about 30% of the blood volume has been lost with marginally reduced blood volume. So with that background knowledge, as the time is limiting, let me come out with some scenario. This scenario is quite a common scenario that you will encounter as a house officer. 35-year-old motorcyclist admits after a fall. He has fallen from a motorcycle. His airway and breathing are okay. He's conscious and rational. This indicates that there's no chest injury, there's no problem with his breathing, and his higher functions are normal, and he said no head injury. He has deformity and swelling of the left thigh, indicating a fracture of femur with internal bleeding. As you all understand, fracture femur can bleed a lot. And then he has developed tachycardia, and his blood pressure has dropped to 70/50. So this is class 3 shock, as you all can see. His respiratory rate has increased because he is trying to get more oxygen to perfuse the organs with his reduced hemoglobin level. So this is the patient that you will find in your normal practice as a house officer at odd hours. There you won't have your seniors to help you. It will be you by yourself with the nursing staff. So how do you manage this patient? This is a case of hypovolemia due to hemorrhage. Here we go. Management. This diagnosis is hypovolemia due to hemorrhagic shock. What class of shock? This is class 3 shock. So how do you manage this patient? The most important thing in management of hypovolemic shock due to hemorrhage is to stop the bleeding. Now this man has internal bleeding into the thigh. How do you stop this bleeding? You can't stop it completely, but of course, as a house officer, you can reduce it. How do you reduce it? You can apply a splint. That is the first thing to do. If you apply a splint, that will really reduce his pain, stabilize his fracture, and prevent further damage. So the first thing is to stabilize with a back slab, long back slab, high AK back slab to stabilize the fracture. At the same time, you elevate this so that the gravity will help to reduce bleeding. And if there's an expanding hematoma, you can apply a bandage. All these are temporizing measures which you can undertake as a house officer. And that is the way of stopping the hemorrhage. Then how do you need to resuscitate this patient? I am sure you know how to do it. You have to insert wide bore cannula into forearms, both forearms. That is where you can infuse fluid fastest, not elsewhere, not to the neck, not to any other place, but to the forearm veins. Insert wide bore cannula like 14 gauge or 16 gauge, and take blood flow grouping and cross match. In this patient in class 3 shock, of course, you will ask for about 4 to 6 units of blood. In the form, you will write life-saving emergency. And you will get somebody to call the blood bank and tell them, look here, there's a patient coming with exsanguinating hemorrhage and we need blood urgently. So that with that, you continue to resuscitate the patient. Initially, you won't have blood coming, so you will connect him to IV crystalloids. Whatever is readily available is what should be given to him. So normal saline is a good fluid to start with. You initially give about 1 liter of normal saline and see how the response is. If his blood pressure is peaking and you are happy, that means he's consolidating. But more often than not, the blood pressure won't be stable and won't be stabilized with normal saline transfusion in a patient with class 3 shock. Then you have to think of to replace the loss with likes. Now the loss is blood, so you have to give the blood. There's no other way. So what is the next question is, what is the target figure of his blood pressure? Now you might think that this is a young fellow who has a high blood pressure of about 120/80, and you might want to raise the blood pressure up to 120/80, which is not the correct thing to do. If you raise the blood, what will happen is his peripheral blood vessels will open up due to this increased blood pressure, and the clots will get dislodged. He will bleed more and more. So therefore, we don't elevate the blood pressure to his normal blood pressure. We will leave his blood pressure at a lower pressure to perfuse only his vital organs. His peripheral will be shut down. His skeletal muscles will be deprived of blood supply. His gut would be deprived of blood supply. His skin would be deprived of blood supply, but his heart, brain, kidneys, and the lungs will be perfused. And that is enough to keep the life going. And that will make sure that he doesn't bleed much until you go to the theater and completely arrest bleeding, at which point we, of course, can increase his blood pressure to his normal. So that is the target figure. This lowering blood pressure resuscitation is called hypo. With what? As I mentioned earlier, it's increase crystalloids 1 liter, and then you have to, after 1 liter, you have to get going with the blood. So if you have time, you go for cross-match bloods. If you don't have time for cross-match blood, which takes about 15-20 minutes, you go for group-specific blood. Group testing takes only about 5 minutes, but in a patient who can't wait for that even. Now, this patient records a blood pressure. In certain patients, they don't record a blood pressure. In such patients, of course, you can get going with O negative. If O negative is not there, you go ahead with O positive blood transfusions. What is the target blood pressure? As I mentioned earlier, it would be like 80, 90 systolic, not more than that. Of course, one thing you have to remember, if a patient has head injury, you have to bring his blood pressure up to normal level, like 120, because cerebral perfusion pressure is mean arterial pressure minus intracranial pressure. Therefore, in head injury, you can't offer the patient the benefit of hypotensive resuscitation, but you will have to maintain the blood pressure at normal. All the other patients, it's better until you achieve definite hemostasis inside the theater, you maintain his pressure at a lower level. So you maintain low blood pressure only adequate to perfuse the vital organs, and elevating the blood pressure may cause dislodgement of clots. Raise blood pressure normally only after achieving complete hemostasis, and you have to inform your seniors, inform the theater, inform the anesthetist, and prepare the patient for definitive surgery. So that's a scenario. So this is the cause of death in case of hemorrhagic hypovolemia. You have a triad called lethal triad. Lethal means deadly. deadly triad where you have hypothermia, you have acidosis, you have coagulopathy. All these taken together, if you transfuse blood, the blood will be in room temperature, and that will cause hypothermia. Patient will lose blood, and along with blood, the body temperature is lost. When you have hypoxia, that hypoxia will produce lactic acid, and that will lead to acidosis. And when you have temperature loss and acidosis, that will affect your coagulopathy. When your coagulopathy has set in, blood clotting needs these two, and then he will bleed more, and that will lead to hypothermia, and that hypothermia will lead to acidosis. This is a triad. You have to break this triad to treat. So when you transfuse blood, one more thing is where you anticipate the patient's blood volume be replaced within 24 hours. That is called massive blood transfusion. If you suspect half of the blood volume to be replaced in 4 hours, then that is again fall into this category called massive blood transfusion. In big hospitals, they have massive transfusion protocol where you have to mention in your request form, please activate the massive transfusion protocol. The blood bank will issue you blood in packs. But in peripheral hospitals, this protocol might not be that effective, especially on social hours. Then, of course, as a rule of thumb, whenever you give a blood transfusion where you think that the patient blood volume, half of the blood volume will have to be replaced in 4 hours, or patient's total blood volume is going to be replaced in 24 hours, where you approximately anticipate to give about 10 units of packed cells, then which each red cell that you transfuse, you have to give 1 unit of platelet and 1 unit of FFP until you do a proper hematological referral and get advice on this. So that is the hypovolemia due to hemorrhage. Now we come to another hypovolemic scenario with acute pancreatitis or paralytic ileus. Here, of course, the patients go into hypovolemia due to several reasons. The patients with acute pancreatitis or paralytic ileus or intestinal obstruction, their secretions are getting accumulated inside the gut. These fluids, which are in liters, are not going to take part in body homeostasis. These fluids are going to be accumulated inside the gut, and that will lead to hypovolemia systemically and dehydration. And they also have reduced intake, they will vomit, and due to sepsis, they will have vasodilatation. All these will lead to patient becoming hypovolemic. So how do you manage this kind of a patient? Intestinal obstruction, paralytic ileus, pancreatitis, or any other condition that leads to paralytic fluid accumulation inside the gut. You have to keep them nil by mouth. You have to insert an NG tube to drain out secretions. And then you have to give IV fluids. Here, of course, blood transfusions are not necessary because you are not losing blood. This hypovolemia is due to secretions and fluid and electrolyte rich fluid getting accumulated at a place where it doesn't contribute to body homeostasis or circulation. So replacing with crystalloids, normal cell and Hartmann's, correcting of electrolyte imbalances, because these fluids that are accumulated inside the gut are rich in potassium and sodium. So you have to replace those electrolytes, and you have to maintain input-output chart, input by IV fluids, output by the NG losses and the urine output. If the patient in a hemorrhagic, if the patient is in a sort of a septic shock due to vasodilatation, probably with judicious use of inotropes like noradrenaline might be required. Mind you, in hemorrhagic shock, there's no place for inotropes. It's always volume replacement. In this situation, probably if the patient has an ongoing sepsis, then of course, judicious use of noradrenaline might be required. In this type of a patient, you have to always ask for senior help, and patient would better be managed in a HDU setup. So going to another case scenario, this is due to constraints of time, I'm going to be a little quick. It's a 65-year-old man on dual antiplatelets, clopidogrel and aspirin. This is a quite common happening in the current day practice, because a lot of people are on stents, coronary stents, and they are being anticoagulated. They develop a bout of massive hematemesis. Aspirin causes gastric erosions, and these to make the matters worse, they are on clopidogrel. So they collapse and they present with massive hematemesis and Manila. This is something that we encounter in our clinical practice every day. Cold clammy extremities means he is hypovolemic, pulse rate 120, blood pressure is, the other way around, 80 over 50. His respiratory rate again is, how do you manage this patient? The challenges that you may encounter in managing this patient. He has coagulopathy due to antiplatelet medication. As you know, clopidogrel has its effects going up to 7 days. Aspirin, of course, 3 days. Even if you stop it today, the effect will be in the system for about another 5 to 7 days. So how do you manage this patient? Fluid administration causes cardiac failure, though you might not be able to give that amount of large volumes of fluids at once. So You will have to start PPI infusions like pantoprazole or omeprazole infusions. You have to get fresh blood and correct coagulopathy along with blood transfusion. From the first point itself, you have to get the advice of hematologists, cardiologists, and physicians when you manage these patients. You will give blood, you will have to at the same time give platelets. Mind you, platelets are lost in storage. So platelets are like, you have to ask for the blood that you transfuse doesn't have effective platelets. So you will have to get the platelets from the blood bank separately. When you give blood, you have to give warm blood. You don't give blood as they are taken from the storage, because it's stored at -4. The patients will be pushed to hypothermia. You remember this lethal triad where hypothermia plays a major role in setting up the lethal triad. So always warm your fluids and use a fluid warmer, and then administer platelets, FFP along with blood. Urgent endoscopy and definitive care should follow. So to sum up my lecture, I just wish to give you some take-home message. Always arrest bleeding whenever is possible. Splinting, a fracture, application of a bandage, elevation. If there's any sort of a soft tissue bleeding, you may probably do ice packing. That may also, every little helps. So you could try those. Fluid resuscitation with crystalloids. In case of hemorrhagic shock, don't give more than 1 liter of fluids. If you give a lot of fluids, what will happen is the fluids will not have any coagulation factors. It will not have hemoglobin. It will be in the room temperature, whereas your body temperature is 37. You will be pushing the patient into lethal triad by giving a lot of normal saline or Hartmann's in a patient with hemorrhagic shock. So you just give 1 liter until your blood is ready. Get going with blood early in the case of hemorrhagic shock. Early blood transfusion in case of hemorrhage. Cross-match, group specific, and if there's no time, go for O negative or O positive. If there are problems, we can manage those problems later, but you need to have a living patient to have to sort out all this. So hypotensive resuscitation is something that you have to remember in case of a trauma where you don't raise the blood pressure to its normal level. You maintain the patient's blood pressure around 90 systolic to perfuse his vital organs. However, you can't institute hypotensive resuscitation if the patient has head injury or if the patient has heart failure. Of course, heart failure is rare. Head injury is quite common. Say about 25% of the people will have head injury. If the patient has head injury, then you have to resuscitate them in normotensive fashion. Normotensive resuscitation. All the other patients try to resuscitate hypotensively until the definite hemostasis is achieved. Prevent setting up of lethal triad. Prevent hypothermia, cover the patient, give warm fluids and warm blood, give coagulation. Always think of correcting coagulopathy by giving FFP and platelets, and then acidosis by maintaining his blood pressure to an acceptable. Always inform seniors early, prepare for surgery, and prepare for interventions where the surgery is not necessary. Any questions? Anybody wants to ask me any question? Anybody wishes to ask me any questions? Okay, in the absence of any questions, you can always send the questions later to us, to the college. We can go through them and do that. Thanks so much for participating in this lecture. Wish you all a very happy and successful career ahead. Thank you.
Now let me introduce you to Dr. Kirti Abajiva, Dr. Rohan Sirisena, and Dr. Narendra Pinto for a panel discussion on management of trauma.
A very good morning to you. Nice to be talking to pre-interns after a long time. I think we will carry on this trauma, I won't call it a lecture, it's interactive discussion. So I would like to you all to respond whenever a question or discussion goes on. The time constraints also may prevent us from answering a lot of questions, but of course we will try to accommodate as much as possible. So we have myself, my name is Kirti Abejiva. I'm a general surgeon working at the National Hospital. And we have two eminent other speakers here, Dr. Narendra Pinto, who is a very senior orthopedic surgeon, and also a trainer in trauma, and Dr. Rohan Sirsena, who is a consultant general surgeon at the Javadhan Hospital. So we will start with there'll be first of all there'll be some sort of overlap between some of these lectures, because like Dr. Govinda Aryapan's lecture, which you all just listen, of course also addresses the hypovolemia in trauma. So and also Dr. Pinto's next lecture again on limb injuries will have some bit of common topics. So we have a 35-year-old patient here who has been knocked down by a truck, a common scenario that you will come across sometimes maybe in your first week of your internship. And these are quite young patients and most severe and life-threatening patients. So what we want you all to do is to address these, to do the basic things in the first few hours till your seniors are available, which is crucial, as we know. The time is very important in trauma management. The more the time is spent, the less the chance of a patient surviving, unless the correct thing is done. So as we know, commonest cause of preventable deaths are hemorrhagic shock. So that is the very thing that you all as interns can prevent in your capacity. Like simple thing like putting a pressure bandage or pressure dressing or starting blood or fluids will prevent these patients being sort of going into irreversible status. So we'll start with this 35-year-old patient who has been knocked down by a truck and been transferred from a peripheral hospital to your unit. And usually they land up in your hospital at the very unhospitable times, maybe 10 o'clock, 11 o'clock, or even maybe 1 o'clock in the morning. So it will be you and the patient and maybe your colleague, another house officer or a nurse, and the nurses which you will have around you to manage this patient. So he has been put on a spinal board and a collar, and he has been given oxygen through a face mask. And his parameters are blood pressure is 100/60 and pulse rate of 130, and oxygen saturation is 92 with 10 liters of oxygen. So I would ask Dr. Pinto first, what do you think of the immobilization process that has been done?
Kirti, I just want to emphasize certain things. I mean, the history is very important because this motorcyclist, the mode of injury is important so that you can understand the energy transfer and the seriousness of the injuries this patient must be having. Now, this motorcyclist, whether this collision was head-on with a speeding vehicle or just brushed off, that also determines these various injuries. So the history is important. Don't mention just the RTA or something, and that's an important point. And he was not wearing a helmet, means that means he's liable to have the head injuries as well as spinal injuries are a great possibility. Always you have to assume a spinal injury in all polytrauma patients, high energy accidents, or the accident involves any, the mechanism of injury is likely to cause spinal injury. So you have to protect his spine. Now this patient had been placed on a spinal board and with a cervical collar, And ideally, you have to have a Philadelphia color, and these latest spinal boards, they have the blocks, the inbuilt blocks to protect the head. But in the absence of these things, if the patient comes just on a brought by without a spinal board, you have to place him in a firm bed and protect the spine with the Philadelphia collar and place 2 sandbags on either side of the head. And mind you, if you are suspecting spinal injury, you have to assume that this patient has got a unstable spinal injury until proven otherwise. So you have to be take extra care in handling these patients, and you have to accompany this patient even if the patient is moved to a X-ray facility or not. So it's the important part.
So once I will recap about the patient now. Now the patient parameters are blood pressure is 100/60 and pulse rate of 130, and of course the saturation is 92%. So can anyone in the audience say whether this is a fairly okay situation for the patient? You can unmute and tell. But I think we will ask Dr. Rohan Sirisela to elaborate on the findings of these parameters.
I think.
So thank you very much, Dr. Abhijit. Actually, his blood pressure is 100/60, pulse rate is 130, and saturation is 92%. So that means obviously he's not doing well. So the blood pressure 100/60 means he's bleeding from somewhere. So basically, if you see a patient with trauma, you're with the low blood pressure, so your first diagnosis is hemorrhage. You don't consider other types of hypovolemic shocks, and this may be due to hemorrhage. And his pulse rate is 130 and saturation is 92%. So that means he has a problem with oxygenation, and he's bleeding, and he may be in class 2 or class 3 shock. So we need to address his bleeding, and we need to find where he's bleeding from. And so basically we have to follow the protocol ABC, airway, breathing, and circulation.
Thank you, Rohan. Yes, I think we had the lecture on shock previously by Dr. Duminda. So I think here one point that as you emphasized, blood pressure of 100/60 is not a normal blood pressure for a young man. So where the moment the blood pressure drops, that means the patient is in class 3 shock and the significant tachycardia and the low saturation. So though, as we very correctly mentioned, he is in class 3 hemorrhage. So he is in sort of a very serious situation. Unless you address this situation right now, then and there, the patient, the next moment will be in class 4 shock, where he may even be in irreversible shock. So what about the oxygen saturation of 92? Sorry, about the right. So what do you think of the oxygen saturation of 92?
So the basic, yeah. So the basically his, I think his oxygen saturation is not maintained, and so the common things are common. So we need to think about the common things. So obviously we know there may be problem with blocked airway, but we need to think about the common things. So oxygen cylinder may be empty. So we are not giving enough oxygen. So we need to think about those things. And then there may be blocked airway. A lot of secretions may be blocking the airway. And so tongue may have fallen, and tongue may block the airway. So therefore, as you correctly mentioned, chin lift, jaw thrust procedure should be applied. And we need to clean the airway. And I think there was a picture there.
Yes.
Yeah, jaw thrust and chin lift. And we need to clean the airway and suck out fluid. And don't forget, there may be common mistakes, something like empty oxygen cylinder or disconnected oxygen supply.
I would like to, I would like to add that when you maneuver the neck, you have to be careful with the not to damage any cervical spine. So you have to be mindful about that.
Yeah, very correctly. You can't extend the neck in trauma while intubating. You have to be, we are not in sort of intubation, but even any of the maneuvers you can't extend. Usual thing you do in open the airways to extend the neck, which cannot be done in trauma. And this you can see as a chin lift as well. And of course, if the patient improves with these maneuvers, that means the patient cannot maintain his airway. So you may have to put an oral airway that you can see in this the picture. I think there are several sizes. You measure the size of the patient for the patient from the external nasal or the external canthus of the mouth to the pinna of the ear. That roughly you can get an idea of the size, and you can insert this and then put the mask until the next steps are taken. So. Right. So you did that. You did the neck sort of your thrust to suck out the secretion. Still, the saturation is 90. What do you think, Rohan, now is happening?
Yeah. So we need to think about the other things actually. So now we have cleared the airway, but still oxygen saturation is not improved. So we need to think about the other things. Something like tension pneumothorax and flail chest, the hemothorax or massive pulmonary contusion. So all these things can contribute to poor oxygenation. So the tension pneumothorax and the flail chest, though, so that is an emergency, and we need to think about those things also.
Yeah. So first you do the maneuver that Dr. Han mentioned. Then of course you think of the life-threatening condition of the chest that can give rise to the low saturation. Of course, you must be mindful if the blood pressure is very low, even sometimes that can give a recording on the finger because the finger is not perfused well. But then again, you have to go step by step. You first address the airway, then you think of what's happening in the chest, like the 5 life-threatening conditions. So you quickly check the position of the trachea and chest expansion, air entry, and then decide what to do. So if there is a suspicion of a, for example, tension pneumothorax, you do not wait for X-rays or any other investigation for your senior to come. You have to decompress them, and otherwise the patient will not survive for long.
And the cardiac tamponade is the other possibility actually. It's a rare possibility. We need to think about that.
Yes, that is also quite high and very difficult to sometimes diagnose in a very busy situation where the muffling of heart sounds are not very clear even, but the normal heart sound sometimes is muffled in a very busy situation, and the ECG changes also may not be evident. So we have to be very, very sort of mindful of these things can happen in sort of unexpected situations. So, so this is. I would like to explain what this X-ray shows.
So basically, there is a deviation of the mediastinum, no? And you can't see the lung shadows in the left side, and this may be due to. So obviously, this is due to the tension pneumothorax.
Yeah. So of course, this X-ray is an X-ray that should never have been taken. Why? Because if you have sent a patient like this for X-ray to the X-ray department to take X-rays, he will not return alive because you will have only few minutes to make the patient correct. Otherwise, he may go into cardiac arrest. So you can see the inflated trachea, as Dr. mentioned, mediastinal shift, and air entry will be less on the affected side, and also there will be probably hyperresonance. So these types of X-rays should not have been taken, but the treatment should have been started beforehand. Right. So we assume that we have addressed whatever the situation. So this, of course, patient needs an intercostal drainage tube, which probably will have to learn through a trauma course during your or before your internship.
Immediate decompression.
Immediate decompression is the life-saving procedure that we usually do in the second intercostal space. You can do it in the sixth space also in the mid-axial line. But wherever the space, you can, if you put a needle and decompress this, you may buy some time till you put the intercostal drainage. Sorry, the top part of the screen is not shown, but it says blood pressure is 100/6 now, 100/60 and pulse rate is 130. So we have addressed the airway and breathing issues, but now still the blood pressure is 100/60 and pulse rate is 130. Rohan, would you like to?
Yeah, that means the patient has ongoing bleeding. So we need to think about the place where he is bleeding from. So in the scenario, it was mentioned that he was bleeding from the leg. So bleeding from the leg, but we need to think about concealed bleeding in the abdomen and the thorax. So first, if the patient is bleeding from the leg, so we can apply pressure. So I think that Dr. Duminda Aryaratne elaborated on this, and so we can apply pressure to stop bleeding. And the splint is very important to establish a fracture. And then at the same time, we have to resuscitate the patient.
Yes, Rohan. I think so. This, as we said, the patient is in class 3 shock where the blood pressure has dropped. So obviously we need to act accordingly. And I think Dr. Duminda Aryatna went into details of these classes of hemorrhage, which I don't think we should sort of repeat them. And
so I want to mention one important thing.
Yes.
If you see the bleeding from the leg, but never forget he may be bleeding from somewhere else. So
Yes.
we always attribute the bleeding from bleeding to the ulcer in the leg or the injury in the leg, but that is not the only source of bleeding. He may be bleeding from somewhere.
Right. So what are the other places that we should be looking at? Rohan,
So basically chest and abdomen, chest and the abdomen and the pelvis. Those are actually concealed bleedings.
Yeah. So basically what we used to say one on the floor, that is but the bleeding you see from the leg or wherever, but and four more. So chest, abdomen, pelvis and the limb compartment. So you have to specifically look for these things. As Dr. Rohan mentioned, in hypotension in a trauma patient, unless proven otherwise, is due to hypovolemic shock. So you have to address that. That is the, as I told you, the commonest killer of trauma in trauma. So okay, so you can see the bucket with the hole. So this is patient is basically a patient bucket with a hole. You can put so much of fluid on top, but still it may not retain. So what are the Rohan? How do you think we should be addressing fluid?
Yeah,
anyway, we talk about fluid resuscitation anyway.
Yeah. So initially we have to start with crystalloids. So we can go up to 1 liter of crystalloids. But if you can't resuscitate the patient with 1 liter of crystalloid, you need to think about blood. In this scenario, already has bled about 30% of his blood volume. So he needs blood. But in other situations, you can go up to 1 liter of crystalloids. If you can resuscitate with 1 liter of normal saline or ring-lactate solution, so you can send the patient, or you can think about doing investigations to diagnose the proper cause. Or else, if you can't resuscitate the patient, you need to think about ongoing bleeding. So the patient needs blood flow. Actually, you have to replace blood loss with blood. And then if the cross-match blood is not available, so you need to think about giving uncross-match blood and O group specific blood. If you have 30 minutes or so, you can probably find a cross-match blood. Otherwise, you have to go for uncross-match blood or group specific blood. And remember, some patients are not resuscitatable. So we can't resuscitate them. So that means they have ongoing bleeding. So we need to think about operating them rather than waiting.
Yes, Rohan. So very correctly, we may need to do a few investigations very quickly. For example, the fast scan, the chest X-ray, and also clinical diagnosis like a pelvic fracture with the ongoing bleeding of the pelvis. And of course, if there's no identifiable bleeders, what do you think? Still, the patient is not getting resuscitated with fluids.
Sorry?
So we have excluded the bleeders. There's no bleeding going on, but still the patient is not picking up blood pressure.
Yeah, so we need to think about the cardiac tamponade and other causes.
Yeah, basically, we have to think of other causes like tension pneumothorax, which are missed, and cardiac tamponade. So this just X-rays and I think we will, due to time constraints, I think the head injury part will be spoken in one of the lectures later. I think I'll hand over to Dr. Pinto for his presentation on limb injury.
Thank you.
So till Dr. Pinto starts his talk. So basically, what you need to do is you have to act very quickly in a trauma patient. You have very limited time, and you need to act quickly. And most of the things as house officer you should be able to do without much senior input to save a patient's life. Thank you.
Very good morning. And my topic is the common orthopedic problems what you see in general surgical ward. And these are musculoskeletal injuries, which includes fractures, dislocations, patients on traction, patients on POP casts, patients on external fixators, and I'm going to touch a little bit on spinal injuries. So the aims of managing trauma, I just want to emphasize the principles. The saving life is the most important thing, and for that we discussed about the primary survey, primary resuscitation. And once you save the life and the life is stabilized, then you think of saving limbs. And once the limbs are saved, then you can think of treating a tendon injury or a fracture. So saving life is a multidisciplinary team, and if you get a patient like this and which we discussed, you have to call for help. It's very important to gather as many people as possible to manage this patient. And a bit of a fracture pelvis, and where there is a concealed hemorrhage into the pelvis in the open book fracture, what you can do is you can apply a sheet, a pelvic binder around the pelvis at the level of the trochanter level, and tight closing this open pelvis. And you can, if the legs are internally rotated, apply a little bit traction and internal rotated, you can facilitate this maneuver, and thereby you can control this concealed hemorrhage with tamponade effect. Then we come to the saving limbs. In fact, there will be a separate lecture for this, because I mean the most dangerous aspect is the vascular injury. And mind you, you have only 6 hours to save this leg. And this 6 hours starts from the time of the accident and not from time of the admission. So, but you have to correct this as soon as possible. Don't play around saying that it's only 2 hours or so. And again, that you have to check for distal pulses, capillary circulation, but don't forget the compartment syndrome, because compartment syndrome, until the late cases, the distal pulses may be present and the capillary circulation may be intact. So check the pulse and compare with the opposite side. And you have to be careful about the just palpable pulse, because sometimes this volume may be initially there can be certain blood flow, and if there is a intimal damage, these blood vessels get blocked after a few hours. So you have to be careful about certain injuries, such as supracondylar fractures of the humerus and supracondylar fractures of the femur, or dislocation of the knees, which has a very high chance of vascular injury. And you have to inform the seniors about this possibility. So, as first responders, if you get a trauma case, I emphasize about the mode of injury. I'm not going into detail. the time of injury is important. You have to, you must mention the exact hour and any treatment given elsewhere, comorbid factors, and the last meal. How to control this bleeding from limb injuries? So these are usually revealed hemorrhage. So what you have to do is you have to apply direct pressure to the bleeding wound with a clean pad of gauze and press it until the bleeding stops. Don't just cover it and put a bandage. You must give adequate pressure to control this hemorrhage. And you can elevate the leg or the hand, so that will control most of our bleeding. A bleeding spurting wound, whether to clamp or not. But we discourage clamping because most of the time, with direct pressure, most of these things will control. But of course, there are certain instances where there is, the wound is big. The leg is severely crushed, and that type of a situation, you can apply direct pressure. Therefore, you have to think of this, saving this patient's life, and you have to resort to a tourniquet. Always, tourniquet has to be applied in a place where there's a single bone. That means thigh or the upper arm. And if you are applying a tourniquet, you must block the apply adequate pressure to block the artery. Otherwise, you can increase the bleeding by making it as a venous tourniquet. So don't forget about the RICE regime: rest, ice, and compression and elevation in other smaller injuries. And most of the time, our in the hospitals, government hospitals, this ice is forgotten. Then we'll come to open wound. This open wound is an urgency because the primary care or the primary management determines the outcome. Otherwise, this patient can end up in infected non-union and so on. So if there is a wound, even though if it is, say, heavily contaminated, this contamination is at the site of outside the hospital, but you must prevent hospital-borne infection setting in there. So you, as soon as possible, you have to cover the wound after taking a photograph. All of you have camera phones, so take it and don't remove to see again and again, risking contamination. You can remove obvious dirt, and you can apply direct pressure to control hemorrhage and splint the underlying fracture, thereby reducing the pain. But you can give additional morphine or pethidine to relieve after excluding head injuries. Antibiotics has to be started. When you start your internship, find out what the antibiotic policy. So if a farmyard injury, you must add metronidazole and penicillin with a broad spectrum antibiotics. Find out from your seniors about this policy. And the tetanus toxoid is important, and keep the patient fasting and prepare this patient for anesthesia. So you may have to do ECG and what sort of other investigations. So if you see these type of limb injuries and fractures with deformities, displaced fractures, the patient will be in severe pain because of the deformity and obstruction of the blood supply. So this type of cases, you have to think of reducing the deformity by applying direct axial traction after giving a shot of pethidine or morphine. It's important, and I have just shown how to reduce it. Your aim is to reduce the deformity, not to reduce the fracture completely. So thereby, you are relieving the pain. You can apply a temporary plaster to protect the leg. Then I'm not going to detail about how to diagnose a fracture, but it is important to clinically examine the patient, the history examination to suspect a fracture. Otherwise, you should not just point blankly ask for X-rays from top to bottom. So if you are using this X-ray, you have to see the joint above and below, especially in the case of forearm and the femur. The shoulder injuries ask for X-ray AP view, but not lateral. If necessary, you can go for an axial view after checking with the seniors. Hip pathology, don't ask for a hip, only the hip AP, ask for a pelvis AP. So you can compare with the other side. And ankle injuries, I have seen people asking for X-ray foot. So ankle AP referral, and if you want to see the tarsal and metatarsal joints, ask for X-ray forefinger. This planning for X-rays are important. You plan the X-rays to see all possible injuries with minimal exposures. If there is a fracture femur, always it's good for take a X-ray pelvis AP so that you see the hip, and ask for the X-ray lower 2/3 of the femur, including the knee, so that you can cover the rest of the shaft and the knee joint. Elderly patient complaining of pain in the hip following a fall, he may be able to walk, but always assume that the patient has got a fracture neck of femur until proven. Otherwise, even if you can't see a X-ray, don't discharge this patient, get seniors help. And patient who is unable to weight bear is very likely to have a fracture. Hip dislocation is an emergency. Even in the middle of the night or the wee hours of the morning, you must inform your seniors and prepare him for a reduction. Don't wait for 6 hours fasting. You can go for anesthesia under this type of special circumstances. Knee is another important joint where you can get serious ligament injuries without a fracture. I have seen so many patients, the ligament injuries have been missed, saying no fractures. Collateral injuries are important, so you gently examine for instability in varus or valgus strain. And if there is an opening up of the knee, you need to admit. And immediate swelling of the knee indicates hemarthrosis, indicating serious injury. So these common dislocations, patellar dislocations, shoulder, elbow dislocations, these common dislocations, wait until you get some experience and see how your seniors reduce these things and go for, you can try those things. I'm not going into detail. So coming to another important topic, the plasters. The plasters, when you above knee or so-called plasters, when the plaster is put, the plaster, it may be loose, but because of the underlying injury, the limb can swell. So once the patient comes to the ward, they can get tight plaster. So you should know about the symptoms of tight plaster. There will be undue severe pain and swelling of the distal parts and pain on passive extension of the fingers or toes. Indicative of a tight plaster. If you suspect, assume that the plaster is tight. Don't wait for paresthesia, coldness, or color changes. They are late signs you have lost the leg. So the treatment is split the plaster cast immediately from top to bottom until you see the skin, and try it open until the patient feels comfort. If the plaster cutter is not working or out of order, you can dip the plaster in water and crush it to remove it, because it's very important to release the pressure. Colostoplaster, managing colostoplaster is important. This is one of the commonest plasters you see. The metacarpophalangeal joints should be free to move, and you make sure that the fingers can be passively extended, avoid to make sure that the plaster is not tight. And when you discharge the patient, ask her to move the fingers and shoulders to prevent stiffness and elevation. And if there is any undue pain, to report to the hospital even in the middle of the night to release this pressure. Then the patient on traction, you should know how to apply skin traction. Best thing is to ask the senior nurse how to do this. You have to shape the leg and protect the bony points with gauze pads. And to apply effective traction, you have to elevate the leg, elevate the foot end of the leg, and always check for pressure sores under the heel and over the bony points. These patients, long-standing patients, can have retention of urine and bowel opening, and they can be propped up, even the foot end is elevated, because to facilitate the respiration. And you must speak to the patient and assess the general well-being of the patient, because they can have silent pneumonia or UTI causing distress. The external fixators, pin tract infection and cellulitis, you have to look for and inform the relevant people. Spinal injury, I mentioned about this, all patients with polytrauma, and I mentioned about this. When to suspect, and if you suspect, you have to assume that this patient has got spinal injury, unstable spine until proven otherwise. So handle him carefully to prevent secondary accident. So you, as a first responder, you must check for any neurological deficit, movements of the lower limb and the sensation, the sacral sensation and the anal sphincter tone, and tabulate, make a note of it. It's going to be vital. And the log rolling is mentioned here, shown here. You should know how to do that to prevent pressure sores and other complications. Finally, I would like to mention this American Spinal Injury Association scale of grading spinal cord injury. This is world recognized classification. Don't worry, this is very easy. There are 5 A, B, C, D, E components. A is complete paralysis below the level, no motor or sensory function. And B is preservation of some function but no motor activity. So these A and B are complete paralyzed patients. And C is there is some motor activity but not useful. D is a useful motor activity is there, and E has no apparent sensory or motor deficit. Thank you very much.
Yes. Please let me introduce you to Dr. Resmi Kazev, Senior Lecturer and Consultant Vascular Surgeon, for a lecture on threatened limb.
Good morning, everybody. Is the limb threatened? Now, as interns, you will have in the next 15 minutes. I'm not going to share with you a lot of theory. as HOs what you should not miss, because these are easily treatable conditions. And if you diagnose it and you're the first contact, because making a diagnosis late even has an implication of limb loss. So you need to know 3 conditions where if you get it, you diagnose it properly and save a limb. So the first one, let's talk about the first condition I want to talk about. I can't change the slide. Excuse me. Slide change. Now it's okay. Okay. First patient in the first 5 minutes, a 65-year-old man comes with acute onset severe leg pain for 4 hours. Now, if a patient comes to you with no pain at all and sudden onset severe pain, always think of ischemia. This is called acute ischemia. Maybe, we don't know. It's just that we don't take it lightly. So if you take time to clerk this patient and then you delay it, and by the time you make a diagnosis, it's too late, because you have a window of opportunity of 6 hours to treat this patient. So the other symptoms will be the patient will complain unable to walk, and this particular real life patient had no other known comorbidity. This is a 65-year-old male who just couldn't walk because of severe pain for the last 4 hours. Then looking at this gentleman, can you perceive a difference in color on the left side of the leg? So there is a color change. So some of these will be more reddish, some of these will be more bluish. So you need to recognize there's a color change. And when we touched it, it was colder than the other side. And the pulse chart showed this. It was a cold limb. The capillary refilling time was more than 3 seconds. Toe movements were impaired, sensation impaired. And when you keep the oxygen saturation meter, there is no regular waveform. So the saturation was not detected. So when you have a situation like this, you know this is ischemia, and with the history, you can diagnose acute ischemia. So sometimes, one of the first things you must do is inform your seniors, your consultant or the registrar, SR or SHO, and then get advice as to whether to start heparin to stop the propagation of clots. Now, so if we can do it within 6 hours, we can save the limb. This particular, and also another situation where there can be acute ischemia, we can caught out as is a human being who comes with, he or she had long-standing pain in the leg, sudden increase. So the increase to severe pain happened in the last few hours. So then it can be, that's called acute and chronic. Whatever it is, severe pain when there was no pain in the start, or long-standing low-grade pain with a sudden increase of pain, think whether this is ischemia. It is essential that you palpate the pulse. And if the pulses are absent and having pain, toe movement may or may not be impaired, sensory may or may not be impaired, consider this acute ischemia unless proven otherwise. What happened to this patient? He underwent emergency left femoral embolectomy and was subsequently anticoagulated, and his limb survived. So why it happened and all, we can have a whole big lecture onto the causes of embolism, and it can come from the heart, from aneurysm, or it can be a thrombosis. That's a different issue. I'm just telling you that. So the first condition that we considered was acute ischemia or acute or chronic ischemia of the lower limb. Now let's get to another diagnosis that you need to make as an intern. This was another patient. I'm just talking of patients who came to our ward. A 63-year-old female presented with fever for 3 days. And this patient was a diabetic patient and was on insulin. Now, if a patient with diabetes comes with fever, there are 4 things you need to think about generally. Whether it is a lung problem, whether it's a pneumonia, whether it's a UTI, but don't forget the legs. There can be cellulitis or a foot abscess. So, these are the common places where a diabetic patient may come with a preference. Now, in our patient, we came to our ward because they are noted a slightly red second toe 2 days back. So, and poor glycemic control, and the problem with these patients may not have any pain at all because they both feet are numb. So, only presenting can be fever. Only thing can be a smelly foot or due to pus or something like that. So, don't now, whereas acute ischemia always comes with pain, here the presentation with fever, pus, or a high white cell count. Now, this is the picture we had with this patient. So you can see the base of the second toe is all discolored, and the second and third toe are getting dark and gangrenous. So this is what we would generally see. Then we need to diagnose diabetic foot sepsis. Now, if you miss this diagnosis and then leave it alone or treat it alone only with antibiotics, that won't be enough because there is a principle of source control. You need to control the source of this infection. If not, whatever antibiotic you keep the source, it will keep on ascending eventually till you lose the limb. So this is the second most important condition where in a diabetic patient not missing foot sepsis. So there can be cellulitis or abscess formation in the foot. So what would you do if you get a patient like this? We started on empirical antibiotics, depending hospital to hospital, depending on your consultant, the broad spectrum antibiotic underwent urgent wound debridement in the second and third toe. And amputation was done, tissue cultures were sent, and eventually this was healed. Now the problem here is the diabetic foot sepsis also can be confounded by the fact that it can be ischemic. So always check whether there is a ischemic element. So if the diabetic foot sepsis also the foot has absent pulses, you need to consider referring to a surgical unit or a vascular surgical unit to get a second opinion whether anything further needs to be done. Because if there is absent pulse, there is a condition called chronic limb-threatening ischemia. So in an absent pulse, if you get chronic limb-threatening ischemia, we call it CLTI for short, you can't miss. So second condition that you should not miss is diabetic foot sepsis and chronic limb-threatening ischemia, because the long-term sequelae of missing this is very great. So the patient may not have any pain, will not consider we have delayed the diagnosis, and because of our delayed diagnosis, because the patient does not complain of pain, we have lost 4 foot toes and we have delayed the debridement and drainage of diabetic foot sepsis. Now let's go and consider another condition. A 33-year-old male comes following a motorcycle accident with a compound fracture left tibia and fibula. So, so we have several gradings of compound fracture. Gastilo 1 is the lowest form, Gastilo 2, 3 is highest, but you don't have to worry about all those. The just compound fracture is open, that is the fibula with a concomitant wound also. Now the problem is the fracture alone causes pain, but following the fracture, the pain intensity starts increasing. So the severe pain started. So initially you have pain, and as time goes by, the pain starts increasing. Usually the maximum pain happens at the point of fracture, but after that, nothing. I mean, it is constant. But here, this is the image that you are seeing. That is on the left side, you see the small wound that the fracture has caused. On the side, you see the spiral fracture that has happened in the tibia. I can't see a fibular fracture in this patient. So now, what are we dealing with now? When you examine the pulses are palpable. The next condition which you cannot miss is compartment syndrome of the leg. How does compartment syndrome occur is because of this severe trauma, there is tissue edema and muscle edema. And in the leg, there are 4 compartments. So what happens is when there is edema and swelling of the leg on this inside these compartments, the venous pressure starts going up, and then the perfusion of the perfusion pressure decreases. So then what happens is in the capillary bed, your pressure starts increasing to a point where there is ischemia. Now, how you diagnose this is all 6 features of ischemia may or may not be present. There may be developing paresthesia, there can be developing paresis, that is weakness, so the numbness, and one. So now, if you really want to diagnose this, you need to put a needle into the compartments and fix it to a manometer and check whether the pressures are high in these compartments. But what natural history of this is, all the muscles will die if it is not perfused, if you are left untreated for 6 hours, and then what happens is it will end up with a bony amputation. So let's say you're a house officer and now you want to diagnose whether this person has compartment syndrome. All you have to do is passively dorsiflex and plantar flex the second toe or the toes of the foot and see whether there is pain in the calf region. If there is increasing pain on passive movements of the toes at the calf, that means this may be compartment syndrome of the leg, or maybe it is. And also another specific sign is between the not between the first toe and second toe, that is the first web space, there is paresthesia. So this is another early sign to compartment syndrome. So don't miss this. So if in doubt, just dorsiflex and plantar flex the toes and see whether there is increase of pain. If there is such increase of pain, immediately refer to your seniors. A very simple therapy to decompress the compartment and therefore get it open and get the perfusion pressure going. So emergency 4 compartment fasciotomy done for compartment syndrome and the pain disappears. And then the muscles won't die. So you won't lose the leg. And another rare instance where you can lose a leg is external compartment syndrome. I'm sure all of you have seen this. Even though we know all this, if you apply, now what happens is if the patient comes early and we have put a POP backslab, not a backslab, a POP full plaster. One on the left is a below knee plaster, on the right is a above knee plaster cast. So plaster of Paris, plaster cast. Now what happens here is once the if there is ongoing inflammation, because once the injury occurs for the first 24 to 40 hours, acute inflammation occurs. So then if the inflammation occurs, there is ongoing edema. So the plaster of Paris won't yield. It's a tight. So inside the pressure starts increasing because it's trying to swell but cannot swell. So now you start getting compartment syndrome of the leg. And if the pressure is not released, what will happen? The blood flow to that muscle compartments will decrease like in the previous patient. And that was the internal compartment syndrome. Then this is the external. All the muscles will die. And on and off, we still read in papers and unfortunate patients where tight plasters not diagnosed or delayed diagnosis. We have to do a above knee amputation and above elbow amputation. Not long ago, I think it's about 3 or 4 years, one law student or lawyer, I can't remember, the tight plaster cost her upper limb. We had to do a above elbow amputation. So how you diagnose this is also very easy. If you feel because the pain is, the patient talks of increasing pain. So usually when you put a plaster, the pain should stabilize and be constant. The pain is increasing, and so you suspect it's compartment syndrome. Now you can see the toes are visible. All you have to do is dorsiflexion, not active, passive dorsiflexion and plantar flexion. If there is an increase in pain in the calf region, then this is compartment syndrome. All you have to do is totally bypass the plaster cast, that is cut it in 2 places, that is right full thickness, full length. don't give any bands even. So sometimes and then release it. So this is why when we are not sure of the edema, the continuous swelling, we rather put a back slab and stabilize rather than putting a full plaster. So till we know the final size that the leg is going to take, so sometimes you put a back slab for the first 48 hours and then complete it. So you just bypass this plaster in an emergency, because you can always put another POP plaster, but if you lose the leg, you got so passive movements of the toes causing extra pain there, excessive pain at the calf is a diagnosis of compartment syndrome. So these 4 conditions, what are do not miss: acute ischemia, sudden severe pain on the lower limb, check the pulses. If the patient comes with foot sepsis, check whether there is ulcers, pus discharge, or discoloration of the feet. Don't miss a foot abscess. Don't miss compartment syndrome, that is the pressures are high, and these tight plasters. Thank you.
Please let me introduce you to Dr. Nirukshan Javira, consultant neurosurgeon, for a lecture on acute scrotal pain. Over to you, sir.
Yeah, I'm trying to get the screen.
Can see your screen, sir.
Right, can you see? Can you hear me?
Yes, sir, we can.
Yeah, well, so my topic was actually given the low GCS or deteriorated level of the GCS, that is the unconscious patient. But I rephrase my topic saying that unresponsive patient and the intern house officer. So what is this unresponsiveness? So you should know, because if I say unconscious, the patient is just lying, it could be dead, patient just on the bed, you don't know. So what I rephrase is responsive patient. The definition is patient present with, this is the other thing, this is a spectrum of conditions, the unconsciousness. It could be the impaired consciousness, can be considered in terms of reduced alertness or ability to be aroused, or awareness, or both. So basically, they do not respond, and sometimes when you call them, it's very difficult to arouse them, or they don't have the awareness about the surrounding. So it's a spectrum, as I said. So sometimes they are aggressive, they are struggling, they are not listening, so they could be aggressive. Sometimes they are sleepy, they're drowsy, and sometimes they, even though they respond, they can be confused, or sometimes they are in coma, they no response and they just stay still, or sometimes they may be dead. So it's, you may understand that is it's a spectrum of conditions. How one can identify this? So if you see a patient, or if you suspect a patient who is unresponsive, as an intern house officer, go to the patient and call him hello, and call by his name and see whether he is responding. Or if not, then give a tactile stimulation, tap him and give a slap and see whether he is waking up. Or then if it's not responding, give a small pinch or cause a little bit of pain on the sternum
on the forehead. See whether the patients are responding. So if they are not responding, so as a house officer, what are you going to do? So whatever, when the patient is unresponsive, you don't know whether this patient is alive or dead. So your basic, as a house officer, when you see a patient, you can't have time until you call for your seniors or your consultant. You have to start. So you have to save the life. So primary survey, as you all aware, so that is airway, breathing, circulation, and disability assessment and exposure. These are primary survey. And with the same time, you do the initial management and to get the patient hemodynamically stable. So this is wherever you see a patient in trauma situation, wherever you do the airway basic things in ATLS, advanced trauma and life support. So you do the airway, the breathing, circulation, and disability and exposure. So these are the basic things that you should know. I'm sure you have had this ATLS, the lectures before.
Excuse
so
me,
then,
sir.
Yes.
So the presentation, it is not fully visible, sir.
Presentation is not fully visible. What can I do for that? You mean it's not clear or the screen is not
we can see only a part, sir. If you can minimize it and share it again.
Can you see it now?
No, sir. I think you will have to stop the screen share and then reshare again.
Dr. Nirupshan, I think you are not in slideshow view.
So you will have to go
Is it
show
okay
the
now? No, slideshow.
share it again, sir.
Right. Is that okay?
Can't see the slide yet, sir.
Wait.
So I have to share the screen again.
Yes. Yeah, I'm trying. Yeah. Can you see now?
Yeah, that's good.
Yeah. Now, okay, sir. Thank you, sir.
Right. Is that okay?
Yes, sir.
Okay. So so then you have to do the quick workout as I mentioned. So airway, breathing, and circulation, and make sure the patient is alive and do the initial management. So while you are doing that, so you have to think of what are the possibilities of unconsciousness or the unresponsiveness. So there are various medical conditions are there, which I'm not going to talk to you today. But since you are a surgical casualty house officer, think of the surgical causes. And it could be head injury, or maybe a shock following polytrauma, hypovolemic shock, or there could be any intracranial pathology like tumors, hydrocephalus, and spontaneous hemorrhages. So you have to think of these things. And if you go into the internet, you can see the very many causes for unresponsiveness, the neurological, metabolic, and diffuse brain functions. And you should not forget the psychiatric conditions like psychiatric coma or malingering. So sometimes they can pretend that they are not responding. So there are many causes. So so as I mentioned before, now, so you have done the initial airway, breathing, circulation, and you do the initial management. So next you have to think of, so why he is not responding? Then you have to go into the details, right? So then you need to go for the details, like need to diagnose this. So basically for each and every patient, you should know how do you diagnose is the history taking, examination, and do the appropriate investigations. So you have to go for the diagnosis. So history. So can you all take a history from unconscious or unresponsive patient? No. So therefore, how you gather information? You can gather information from the eyewitness or family members if they are around, or sometimes ambulance crew who has brought the patient to the hospital, or sometimes maybe police is around, or maybe if he is transferring from a primary care center, probably the transfer form should contain the details of the patient, what happened, how he brought to their hospital, what was the level of consciousness at that point, and then how they transfer. So all this information is very, very crucial and important. So if you suspect a head injury now, so in the history, you should go and see whether the history of trauma to head, whether there is involving a polytrauma like a motor vehicle accident, and then more information about the mechanism of injury. It's a road traffic accident or fallen from a height, assault, and there are any external evidence. Sometimes you should be able to see any external evidence of trauma to head, wounds and contusions, lacerations, or sometimes most of these patients could be associated with alcohol. Or sometimes these patients should have probably has come to the hospital alive and responding well, and while waiting they have deteriorated. You call it lucid interval, the lucid period. So it's well described in the extradural hemorrhages. So all these things you have to take into account. So information. So in the history, you have to take the ample history that you know all these things. And especially nowadays, the medical history is very important, whether they have on any antiplatelet drugs like aspirin, clopidogrel, or they have any coagulopathies which can cause the bleeding and increased bleeding tendencies. So this is very important as a neurosurgeon to me. And about the incident, time of incident, if it's a road traffic accident or fall, and then the mechanism, the fall, and then the details of the incidents. Any other victims, anybody died, whether he was thrown out of the vehicle, or time to rescue or evacuate from the incident, how long it took him to come to your hospital from the primary care center. All these things matters in the management of these patients. So taking these informations are very, very crucial. So as house officer, so how do you assess the level of consciousness? So well-recognized way of assessing is the Glasgow Coma Scale. It's a very objective way because it does not depend on any other parameters. It's independent. You can assess independently, and it's a universal. You monitor the Glasgow Coma Scale here in Sri Lanka or any other country. So everybody is talking about the same language, and it can be compared. So you do it several times, and you can compare with the previous Glasgow Coma Scale and now, and you can assess the patient. So this Glasgow Coma Scale chart. So everybody, I hope that everybody should have seen this and everybody knows about this. You have to by heart this, and you should know how to give marks. So basically in the Glasgow Coma Scale, you assess the verbal response, sorry, eye movements and the verbal response and the motor response. So you are given the different marks for each of these, and you have to assess this. So I don't think I need to go into this to describe much about this. It's an assessment of Glasgow Coma Scale, but at the end you are giving marks out of 15. And there's another way of, it's a crude way of assessing the level of consciousness. Usually this is done at by the paramedics or the primary care workers, this AVPU scale. So this is a rough way of assessing the consciousness. So with the patient with head injury, most of the time, these patients are subconscious or unconscious. They cannot make a complaint. So everything depends on your assessment. And could be associated with polytrauma. You have to think of the intra-abdominal injuries, chest injuries, limb injuries. You should not forget that, even though you are dealing with unconscious patient. And you have very limited margin of error. So you have to diagnose properly. So if you miss something, it's time. Will result in death. So it's a time critical. So if it is especially in head injury, the time management is very, very crucial. So you have to be very careful, rapid diagnosing of his the level of consciousness, and find out the reason for deteriorating level of consciousness. So you should have the special skills and special knowledge to take histories and diverge this information. So to gather and forward correct information, adequate information, and you should be able to resuscitate the patient and stabilize the patient, as I mentioned before. And then once you detect or diagnose this patient as having head injury, you should be able to transport in the correct means to the neurosurgical center. And whatever you do, that you are trying to prevent the secondary insult to the brain. That is the most important thing in the management of head injury. So head injury. So head injury, that we say any trauma to skull and brain. So you can see the patient with these scalp contusions or lacerations, and probably it indicates the trauma to the head. And sometimes they can present with this degloving type of injury. Or sometimes they can come with these bumps in the head, like subgaleal hematomas or subperiosteal hematomas. Or sometimes they have a X-ray which says the fractures of the skull. It could be linear fracture, or this may be a compound depressed fractures. Sometimes it's a compound fracture. So they are presenting with their primary head injury, which you cannot do much about it. It could be the skin injury, bones injury, could be damage to the meninges, brain, blood vessels. So you cannot do much about the primary injury which has already occurred. Your main target is to prevent the secondary insult to the brain. So which is by expanding hematoma, brain edema, swelling, the hypoxemia, ischemia, shock, and later on the fever, infection, and electrolytes balance. So that is why the airway breathing circulation assessment is very important. So initial primary survey and resuscitation is very, very important to prevent the secondary insult to the brain. So as I mentioned, our goal is management is to prevent the secondary insult. And also you should, the secondary insult. And you must have heard of this Monroe-Kelly doctrine. That is to say, so these patients, when there's a mass lesion, the hematoma expanding in the brain, so initial period with the mass, the volume of the mass, it's increased, but the intracranial pressure on this axis, it's not rising. Due to auto-regulation, it compensates. When you reach this point, it's a rapid, it's even slightest increase in the volume, the intracranial pressure could rise so rapidly, leading to the brain herniation. So you should not wait till the patient comes to this point. You have to identify at this level and do the appropriate management. So according to the Monroe-Kelly doctrine, the total volume of intracranial content must remain constant. The cranium is non-expansile box. So if you look at this, see this normal states, the brain, it's in the intracranial space, you have the brain, the blood, CSF, and maintaining the intracranial pressure around 10 millimeter mercury. So when there is a mass lesion, it's the hematoma, so it takes some volume. So how do you compensate? Or the auto-regulation? So it get rid of some of the CSF out of the intracranial compartment. It initially cost 10, now it's 5. And reduce some venous blood. It initially cost 10, now it's 5. So it's reduced the venous blood. So it's compensate for this, and you can see the intracranial pressure remain the 15. So it's compensated states. So but the further increase the mass lesion, so it has fully compensated with the CSF and the blood, so venous blood. But now they have to compromise with the arterial blood. So if the arterial blood supply does not come, they reduce the brain perfusion, causing the secondary insult to the brain due to brain ischemia. And also see the mass is enlarging, and it try to push the brain out. So what happened is the brain herniation. So you can't allow to have these two, compromise in the arterial flow and the brain herniation. So this uncompensated ICPs rise so rapidly, you cannot wait till this happens. So you have to act at this level. So briefly, in the classification of head injury, with the Glasgow Coma scale, you can classify it to minor head injury, moderate head injury, and severe head injury for the management purposes and descriptive purposes, and which also helps in the prognostication. So If severe head injury GCS is less than 8, you call it a coma or severe head injury. And moderate head injury is GCS 9 to 12. If the GCS is more than 13, we call it the minor head injury. So you should not remember the spine. So about 10% of the head injuries can have the cervical spine injury. So you always treat the patient with the head injury as having cervical spine injury until you prove otherwise. So when you are examining these patients and you have to look at the patient, you might have seen this posturing, the motor posturing. So cerebration rigidity, when there's an injury to the brainstem or thalamus level, they will present in this kind of rigidity. You call it decerebration rigidity. And the abnormal flexion due to decortication, the cortical ischemia can result in decorticating rigidity. So you have to look at these postures. This is very important. And also, see behind the ear, the contusion. This is called the battle sign. So which indicate the skull base injury, especially the middle cranial fossa. And look at the eyes. You can see this orbital, the eyelid swelling. This is the black eye, right? But it's quite different to this type of eyes. So this is called the panda eye and the raccoon eye. Both are same panda eye, raccoon eye. This is, you can see this around the eye, there's a discoloration. So this is due to the skull base injury, especially frontal skull base injury, tracking the blood around the orbit to under the skin, causing this raccoon eye or panda eye, which you should be able to differentiate from the black eye. This is due to direct blow to the forehead. And also look at the conjunctiva. You should be able to see the conjunctiva hemorrhages in the head injured patients sometimes, and look at the posterior margin of it. So there you can see the posterior margin. This indicates the local trauma of the eye causing the subconjunctival hemorrhage. But whereas this, you cannot see the posterior margin, which indicates the blood tracking from behind, causing skull base injury, frontal skull base injury. So these things, these signs, you should be able to demonstrate in your unresponsive patient in order to diagnose the head injury. So next, now you think that this patient is having head injury. So whether this patient needs a CT scan, what are the indications? So GCS less than 13 at any stage on admission up to 2 hours. If his GCS less than 13, so definitely this patient needs a CT scan. Or GCS 13 or 14 after, because on admission it could be 15, but 13 or 14 after 2 hours. So you need to have the CT scan. And suspected open or depressed skull fractures, evidence of skull base injuries, and post-traumatic seizures, any neurology, and focal neurological signs, and post-traumatic amnesia more than 30 minutes are indication for CT scans. If somebody is having persisting vomiting, because in a small kids, sometimes vomiting once or twice is not that significant, but if they're persisting, you need to think of the CT scan. Definitely in coagulopathies, they are on anticoagulants. If they are on antiplatelets or the hemophiliacs, definitely even whatever the head injury, even a minor head injury, may need to have a CT scan of the brain if you're suspicious of an intracranial bleed. And if the mechanism of injury is severe, again, you may consider. And also along with the cervical, the CT scan of the brain, think of the CT cervical spine. If the GCS is less than 15, they cannot say anything about the spine tenderness or spine pain. So then think of doing a cervical spine CT. And any neurological suspicious of a spine injury or any midline tenderness, so you should do the CT cervical spine, because X-ray cervical spine does not usually demonstrate usually in C1 to T1 region in supine X-ray. So it's very difficult to take a full view of the X-ray. And again, the details are not very clear. The gold standard is cervical spine of the CT. So once you diagnose these patients are having head injury, so your main target is to prevent the secondary insult. You have to prevent the hypoxemia, ischemia, or shock. Like you have to protect the airway, make sure that their airway is clear, and suck out all the secretions. And if you think the GC is less than 8, and they cannot maintain the airway properly, it needs the intubation and give some oxygen if needed. And you need to replace the blood or colloids and make sure that your volume is replaced, and you have to maintain the blood pressure, at least mean arterial pressure more than 90. And in latter part, you have to make sure that the electrolyte is maintained. If there's having fits, you need to control the fits quickly, and glycemic levels has to be controlled. And later on, the infections, coagulopathies, and nutrition is also very important in the latter part. So you as a house officer, the take-home message from the unconscious or unresponsive patient is a timely management. History taking is very challenging and is very, very important. You also have to think of the cervical spine injury. So you have to take precautions to protect cervical spine injury in unconscious patient. And when required, intubation is utmost important. Those who cannot maintain the airway. And the CT scan, which is gold standard. And you should communicate with your seniors and consultants. It's very important. You have to pass the message, and you have to make sure that they attend to the patient quickly. And then properly transfer to the neurosurgical unit for the definitive management. So I think I sort of give you a quite wide covering of how to manage this unconscious or unresponsive patient as a house officer. So it's very important to diagnose this, identify your unconsciousness or unresponsiveness, and attend timely. Any questions? Hello, I think I'm concluding my lecture now.
Thank you, Dr. Nirukshan, for your lecture. Now let me please introduce you to Consultant General Surgeon Dr. Nisanka Jayawardena for a lecture on abdominal pain.
Savitya?
Yes, Savitya.
Savitya, my daughter. Right. Thank you, Savidya. Can they hear me?
Yes,
Yeah,
yes.
right. Okay.
Okay.
Yeah. Well, good morning. And today I'm going to introduce you to a complaint where most of the house officers, very common complaint, you will encounter in your future job as an intern house officer, intern surgical house officer. So when this is the sequence of events, what happens, the cascade of events when the patient is admitted. First, the admission at the OPD, and mainly in the peripheral hospitals, you have to see the patient, then take a history and examine the patient, and you have to order as an intern initial investigations. And of course, you have to go behind and get the results. No point ordering investigations if you don't get the results and if you don't have a look at the results. Then, of course, sometimes you may have to communicate with the patient's family and also communicate with your superior. So admissions can be two types. One is actually three types. One is emergency admissions, stamped patients, where the OPD medical officer has seen the patient and he has thought the patient had to be attended quickly. So these patients you have to see as soon as possible. Then you get non-stamped patients. Still you have to see the patient as soon as possible, any surgical patient, because the patient spends in the OPD a very small time, short time, and
the patient, the OPD medical officer might miss an important condition which has to be attended fast. Then the question comes, when it comes to the abdomen, is there peritonitis or no peritonitis? If there's peritonitis, then you have to act very fast and warn your superiors. Now these days, you have to always treat the patient as COVID positive. When you go there also, you might, the COVID epidemic may not have been resolved. So you will have that additional burden which we didn't have as interns. The patient might be COVID positive. So that you have to take all the precautions also when you are attending to this patient to safeguard yourself. Okay, so let's see what you have to think about the pain. Now I'm simplifying this as much as possible because I don't expect you to be consultants. I expect you to be good intern house officers who can save lives. So pain, the duration of pain, as you know all these things: site of pain, somatic pain or visceral pain, the severity of the pain, whether it's very severe, character, whether it's colicky pain, dull, sharp, burning, radiation, relieving factors, aggravating factors, and associated phenomena as you studied in the medical college, which are very important to come at a time. So when you are thinking of distribution of visceral pain in the abdomen, which is actually it is related to the nerve supply. So abdomen, there are paired organs, as you know, like kidney, adrenals, and of course testes, and of course in the unpaired organs. So unpaired organs is the gut and its derivatives. So gut, when you go to embryology or development, the gut is divided into three parts: foregut, which is up to the second part of duodenum; midgut, from the duodenum to the transverse colon; a small bowel, appendix, everything is there; and the hindgut, where from the transverse colon to the rectum. So generally, when the pain is felt, there is a rough rule. You can see the organs which develop from, if you are talking about the single organs or midline organs, the derivatives develop from foregut up to the duodenum, and even the gallbladder, which comes out as a bud from the foregut, and pancreas. They will cause pain in the epigastric region, which is depicted in the green. And then the midgut, which the appendix belongs, small bowel, and the ascending and the major part of the transverse colon will have pain in the periumbilical region or umbilical region. Then you get hindgut pain in the suprapubic region, which is again drawn in yellow. Then you have your paired organs like kidneys, where you get pain on the sides, on the flanks, and then the lumbar region, right? So this is a rough rule from the pain itself, from the site itself, where you can guess from which organ the pain comes from. But this is the visceral pain, not the somatic pain, when the organ involves the rest of the peritoneum and the parietal peritoneum, which causes somatic sensation. Then there is types of colics. So all these colics arise from the hollow organs in the abdominal cavity. So as you know, the ureters, which are tubes, intestines, biliary system, and then you get gynecological colics, where you get fallopian tubes and the uterus. So with these colics also there is a different pattern. Now ureteric colic is a pain which comes and stays, very severe pain, stays for about, if you draw a graph, it will stay for about another half an hour, then it will relieve or it will go down a little bit, but the baseline doesn't touch the baseline. The pain will remain. Then again, the pain will come up. So that's the style of typical ureteric colic. On the other hand, intestinal colic is different. Intestinal colic, as all of you know, when you are having a stomach upset and you want to go to the toilet, you get the intestinal colic. There you get urge and pain and remains for a few minutes, and then it nearly comes to the baseline, and again it comes up. So that is intestinal colic, the style of pain. Then there also you can guess the organ involved with the history. Biliary colic is not actually a colic. Biliary colic, generally the pain reduces or goes off in a very slow manner. When it comes, it is severe, then it persists for hours and then slowly settles. Actually, it is not a colic, though it is called a colic. It's a pseudocolic. And then you have this gynecological colic. Always you must remember ectopic pregnancies and gynecological other infections where the pain is felt generally in the suprapubic areas and painful conditions. So these are the types of colic. Then when you examine, you have to always check for vitals as soon as the patient comes, because you are not going to waste time examining in a very urgent patient examination in detail, because you have to do A, B, C, D, E, as all of you all repeat like parrots. And first you have to think of resuscitating the patient if the patient is in shock or need urgent intervention. Then you have to take a good history. So you have to act according to the situation where you are faced. Then you have the examination of abdomen, classical examination. You decide the patient can, wait for your little bit of time for you to examine. Then you have this classical inspect, palpate, percuss, auscultate, and then all these things. You know the signs, you know the danger signs, and you go according to the order. And always remember, you have to think of pain relief and not to cause pain when you are examining the patient, because you have to always treat the patients as live beings and not inanimate objects. Now, patients, now these are the danger signs. The age over 65, immunocompromised patients, that is HIV or chronic glucocorticoid steroid treatment, then alcoholism, cardiovascular compromised patient, and other major comorbidities like cancer, gallstones, pancreatitis, then prior surgery or recent GI instrumentation, then early pregnancy, because there may be risk of ectopic pregnancy. Then the character of pain, if the pain is sudden onset and maximal at onset, then it is a serious thing. Then subsequent pain and then subsequent vomiting. That means the pain causes sympathetic activity. That's why pain is visceral. So pain and vomiting, that's significant. Then constant pain for less than 2 days duration, constant pain, that means there is something severe going on inside. Then examination findings, tense or rigid abdomen, all of you should be able to decide that. There is involuntary guarding. The patient may be very shy and guard. That is not involuntary guarding. Involuntary guarding is when you press, patient automatically guards. Automatically, because of the pain, he guards. Then signs of shock.
So I have put here some simple investigations which you can do before your superiors come into the picture. So that if you do this on urgent basis, and if you have the results at hand, you may find, your superiors may find it is easy for them to make a diagnosis, and it is easy for them to make a decision, and then your consultants will be pleased. What I have put in green are investigations where HO cannot order or cannot do. So that I have put in green. That of course you can suggest, but you cannot order. So as you know, full blood count, CRP will give you many things, like if the patient is bleeding somewhere, or if the patient is having inflammatory condition like or infection, because there will be granulocytosis and high CRP. UFR, of course, is self-explanatory. You can get either pus cells in an infection, and then proteins, red cells in a uterine colic. Serum amylase or lipase, in Sri Lanka, we normally do amylase, but lipase is the more sensitive investigation. Serum amylase will tell you whether the patient is having pancreatitis for sure. If the amylase is more than 1000, they say it is diagnostic of pancreatitis. So if you get amylase of that more than 1000, you can avoid unnecessary laparotomy for that patient. So amylase is important in any epigastric, severe epigastric pain patient. Then you have to do creatinine for one thing, to look at the renal functions, and the other thing is to start drugs, because some drugs are renal toxic. Electrolytes to see whether there's fluid balance, because in intestinal obstruction and certain other situations, there is imbalance of electrolytes. Urine HCG or serum HCG to exclude early pregnancy and therefore ectopic pregnancies. Then blood gases, if it is available. Some hospitals do not have. You might find some hospitals don't have blood gases, but blood gas will give you a picture of acidosis, and it will indicate something, some acute thing going in the abdomen. Then one of the most useful X-rays is X-ray erect chest. X-ray erect chest PA view, posterior anterior view, where you are looking not only the lungs to see whether there is some basal pneumonias which can cause abdominal pain, but you are looking at the diaphragm. Just below the diaphragm, you may see gas. You may see a radiolucent area, not radio-opaque, radiolucent. But be careful, on the left side, you can have the gastric air bubble, which is normal. So you can be mistaken for the gastric air bubble. Then X-rays, if you take, if you have only one X-ray to take, it is much better to take supine abdomen rather than erect abdomen, because erect abdomen, supine abdomen, the details you can see is more. I will come back to these X-rays later in my lecture. So other things, USS abdomen, if it's a fast scan, then of course it is permitted. Of other things, NCCT KUB for renal stones, and CCT abdomen and pelvis, these things will come after seniors see this patient, because one thing, they are more expensive, time consuming, and also patient may need a laparotomy before CECT to save his life. So your seniors will decide on that. So what is the initial management when the patient is there with abdominal pain, severe abdominal pain? Well, you keep the patient nil by mouth till decided by the senior whether to, because he may have to undergo, once your senior comes and sees, he may have to undergo some sort of surgery. So you have to keep the patient nil by mouth till seen by the senior, or till you are experienced enough to decide, not very in first few weeks at least. Then you must establish good IV access
because patient might collapse. In that case, you might not be able to access the IV of the patient, and also at the same time you can draw blood when you are having IV access and send for investigations, and also administer any drugs like antibiotics. If you want to start antibiotics, say you have high white cell count and there is RIF pain, so you can start antibiotics. Those days we didn't start antibiotics for appendicitis, but I think it is okay to start antibiotics and then operate. So resuscitate and correct electrolytes in this patient, look after fluid balance, catheterize when necessary, and of course, look after the acidosis. Then manage pain. So in this acute situation, the best pain analgesic, especially when there is abdominal pain, would be an opioid. So in that case, best analgesic would be morphine. Still it is considered morphine in the acute situation. But in our setup, you might find pethidine, because most of our nurses are still scared to give morphine IV, which is very safe in correct doses. And they are not scared to give pethidine IM. So in that case, you can't help if your nurse refuses to give patient morphine and look after the patient. Then of course, if you can't persuade the nurse, then you better give at least some pethidine and phenergan. Then keep a close eye. Don't close your eyes, but keep a close eye. That means you have to monitor the patient, right? So you have to monitor the patient, because patient is always a dynamic object. It's not a static thing. The patient's condition change. So there are charts like early warning score. You have to always you can attach these scores. You can monitor the vital parameters like blood pressure, pulse, respiratory rate, renal output, these vital parameters of the patient, and monitor how he is doing, whether he is deteriorating. Monitoring is very important. Then consider whether the patient needs a catheter, in nasogastric tube, whether he needs multi-monitor to have a better monitoring when indicated. Because we live in a, sometimes we might not have all these facilities, because still our country is a poor country with poor resources, but still a lot of hospitals have these material, and what you have with you, you can do a lot. Then what are the pitfalls when it comes to abdominal pain? Now these diagnoses, you won't think, if you don't think of it, you won't suspect and you won't investigate to diagnose. One thing is pancreatitis. Pancreatitis comes as abdominal pain. If it is coming for the first time, you might think pancreatitis, something other illness, and then you might operate. So simple thing you have to do is to do a serum amylase. Think about pancreatitis, that the pancreatitis can present with pain. Then leaking abdominal aortic aneurysm. Patient will tell you, classical stories, he will tell you that somebody hit him from behind. He felt that somebody hitting from behind with a pole, and then there is this pain. So leaking abdominal aneurysm being not very common in our country, we don't suspect that, but we have to. Then ischemia and infarction of bowel. That also, if you don't take a good history and if you don't suspect and do investigations like blood gases, it's difficult to diagnose, and you don't, mainly because, not that it is difficult to diagnose, because you don't suspect, as it is uncommon. So remember this. Then of course, they can have undisclosed traumatic events. This comes with child abuse also. What is told to you is not actually what happened. Child may be kicked in the abdomen by the parents or the father or the mother or someone else. Then they will not give you the, they will not own up, and child also will be scared to talk. So you have to always, the falls, childhood trauma, then there are sometimes when the fall occurs and then you get only internal injury, especially the bowel, when where at a point where fixed point, like in the first part of the jejunum, where fixed and mobile points are there, you get tears. And then you come with peritonitis. That is after a small fall. So you have to always think of undisclosed traumatic events. Now we are not talking trauma in abdominal pain here. This is not trauma because trauma has been covered. But in abdominal pain also, undisclosed trauma, you have to keep that in your mind. Then of course, abdominal pain caused by extra-abdominal pathology. Myocardial infarction, lower zonal pneumonia, diabetic ketoacidosis, and abdominal migraine. Abdominal migraine usually in child 3 to 10 years old. So these things you have to just remember. There are certain things which might not in the abdomen, but will present as abdominal pain. So these are about the X-rays. Royal College of Radiologists guidelines on chest and abdominal X-rays in abdominal pain. You have to do when there's clinical suspicion of obstruction of the intestine, acute exacerbation of inflammatory bowel disease, palpable masses in certain circumstances, constipation in certain circumstances. That also comes with obstruction. When the patient is constipated, you can do X-ray. Acute and chronic pancreatitis to see the changes caused by chronic pancreatitis. Then sharp or poisonous foreign body. This includes ingestion of the drugs and gems. Some people, they ingest to hide from the police or authorities. Some people try to swallow, when they smuggle various abusive substances or gems, they swallow it, but they don't own up. So you have to keep that in your mind, and you can do X-ray to verify these. Then smooth and small foreign bodies, coins, batteries, and then I have encountered many sharp foreign bodies also, which you can actually manage conservatively, like safety pins, needles, and whatnot. And you will be surprised when you encounter in your in your long medical career how many things and what things they have the people of world swallows. So they swallow almost everything. Then you have blunt or penetrating abdominal injury in certain specific circumstances. You may do these X-rays. Now this one is what I said. This one is abdominal erect chest, erect X-ray chest, where this is the gas. This is the gas under the diaphragm. And then that is very important because now this is the diaphragm. This white thing is the diaphragm. And underneath it, gas. And here, now this one is, I think, a gastric bubble, but here there is gas again. So erect chest, when you send when the patient for X-ray, if the patient is, is clinically stable, and you have to accompany the patient, somebody responsible should accompany the patient to the X-ray room, because sometimes the orderlies go and keep the patient there and come, and then patient might collapse and die. So patient always, these patients should be, you have to at least have some idea where this patient is, and then ask somebody where the patient is, because patient may be, I have seen patients lying down, lying on a trolley near the radiology department for 2 hours with a totally transected spine. So I have seen that. So you have to always, as a HO, you have to run behind and these patients. And this is a very important X-ray you have to remember, because this indicates almost always a laparotomy. Almost always a laparotomy, right? And this one, again, this is a supine abdomen X-ray AB. And what is this? This is the This is a small bowel, right? Here you can't see much of the large bowel here, but you can see the small bowel. Generally, you don't see small bowel in normal plain X-rays. You see only the duodenal cap and very small amount of small bowel in the X-ray. So if you see something like this pattern is called concertina pattern. A concertina is the thing which you that this piano accordion, what is being pulled and to bellows actually to pump air. So that is something like that. So the line coming straight across the abdomen, across the lumen. So this is the small bowel distended, and unless proven otherwise, this looks like a small bowel obstruction because there is a cut off. There's some stools here in the colon, but generally no gas in the colon. So probably there is some small bowel obstruction in this patient. So this one you have to identify. And this is large bowel. You get horstrations. You don't get complete lines. You get only half lines in large bowels, right? So this is large bowel obstruction. So large bowel obstruction, as you know, can be pseudo obstruction or mechanical obstruction. Pseudo obstruction, the whole bowel is enlarged, and it occurs due to certain things. It is not my lecture today, not my topic. So it's a very large topic itself. So anyway, this is the obstructed large bowel which you have to identify as an intern and warn your consultant or SHO or whoever they are to report, so that somebody has to take some serious action regarding this patient if you see. What is this? This is an extreme case of chronic pancreatitis. This is a pancreas which is calcified, right? So you can look at an X-ray and see that is diagnosed chronic pancreatitis with a patient who is coming with abdominal pain. But only thing is, always remember, you can have two pathologies also. A person with chronic pancreatitis can present with perforated peptic ulcer. So always don't come at a diagnosis and leave it. Always think of another possibility also, especially if the patient's clinical condition is not tallying with the diagnosis. Again, this is actually, he has lost all his features of the peritoneum. So this is a picture of fecal peritonitis, how he sees fecal peritonitis. This is abdomen. They call it football appearance. Now this is the football they call about. It's actually not a football. It's actually American football or a rugby ball here as in our setup. So this is an elliptical ball actually. And you get feculent material on the flanks, right? And the bowel is being pushed medially, and that shows the football, right? It's an American football or a rugby ball appearance, right? But it is called football appearance. Okay, so those are the things which I wanted to know. I didn't want to, overload with so much of theory. Now, those are the important things which will help you to save 1 or 2 lives and also get some good points or good remarks or some good comments from your supervising surgeon when you do internship. So these things I think you have to remember. These are very important to actually not only the internship but also for the rest of your career. So all the best. Have a happy internship, whatever it permits. Thank you.
Thank you, Dr. Nisanka Jayawardena, for that very informative lecture. So please welcome Dr. Nishanta Liana.
Hello, can you hear me?
Please welcome Dr. Nishantha Lianapathirana for a lecture on acute scrotal pain. We can hear you, sir.
Okay, right, let me see. Can you see the slides?
Yes, sir.
All right, okay. Right, very good afternoon. I'll be talking to you about the acute scrotal pain today. So we just, is one of the common clinical scenario which you will encounter during your internship. So I think it's quite important to get a clear idea on what is going on when somebody comes with acute onset scrotal pain. Right, so we'll take a small case scenario and we'll discuss through. So this is a 13-year-old boy and he presented to your casualty ward, surgical ward, with a right-sided sudden onset scrotal pain. And the boy walks up in the morning with the pain, and that was so severe, and he's got some nausea and vomiting at the same time. Interestingly, father gives a history of falling from a bicycle about 2 days back, and he tries to attribute that to the groin trauma which has happened about 2 days back. So how would you proceed in this case? Screen is not visible properly. Is it properly seen now? Can you see the screen now?
Yes, sir, we can see the screen.
All right, okay, right. Sorry about my internet connection. Right, so so how do you proceed? So you can see during your internship, many patients come with their own versions of story. But as an intern house officer, you need to sort of keep your eyes open, and you need to sort of come with an open mind. So, so what are the possibilities in this case scenario? So number one, torsion of the testis. It's a classic story of an adolescent coming with sudden onset right-sided scrotal pain. So torsion of the testis should be high in the list. What are the other differential diagnoses? Then epididymitis or epididymocarditis is a common differential diagnosis. Then the torsion of the appendix testis is another, not so common, but we can still see them time to time. Then trauma or hematocele is a possibility. And in a patient with the history of inguinal hernia, acute incarceration of inguinal hernia can present with acute onset scrotal pain. Then scrotal wall cellulitis, you cannot see them in sort of very young patients, but especially on elderly patients with diabetes, you can see some scrotal wall cellulitis coming with acute scrotal pain. Then again, you should not forget the referred pain. Is it really a scrotal pain or a referred pain? You can especially see them when somebody comes with a distal ureteric calculus. It is usually referred to the groin and towards the testis. So these are the differential diagnoses or possibilities. So let's move to the next slide. Right. So out of these four possibilities, two things that you should know. Torsion of the testis is the most serious one. However, the epididymocarditis is the commonest one out of them. So those are the two things that you should keep in your mind. So how do you differentiate torsion from epididymocarditis? So this is one of the commonest clinical scenario that you will get during your internship to sort it out, right? So if you look at the torsion, it's completely a clinical diagnosis. So you need to be very thorough with your clinical diagnosis of history and examination. So if you look at the typical age grouping of torsion, it is usually the adolescents. So the age of 13, 14, they have a peak. And during the whole adolescent age period, patients can present with torsion. Whereas epididymocarditis is usually in patients who are sexually active, if it is young, but even at the old age, if there are low tract symptoms and prostate enlargement, they can come with adult onset epididymocarditis. So the key feature is the acuteness of the pain. So in torsion, patient comes with sudden onset pain, which is just peaked within a couple of minutes, 5 minutes, 20 minutes, pain really gets worsened and it's quite acute. Whereas if you look at the epididymocarditis, it usually starts as a mild or less severe pain, and the pain gradually worsens to a severity during the course of 24 hours to 48 hours. And usually the torsion is associated with nausea and vomiting, whereas in infections, you don't get them much. Again, torsion doesn't have significant urinary symptoms, but epididymocarditis usually have a preceding history of dysuria and LUTs, but it may be or may not be there. It's not a must. And fever is more likely in infection, whereas in torsion, you don't get much of fever. So again, the most important part is the physical examination of the testis or the scrotum. So one of the key things is the severe tenderness. So if you look at the torsion, if you go through the features of torsion, severe tenderness, and patients barely allows you to touch the scrotum. You have to be very gentle because you need to elicit the signs and as well as come to a diagnosis. So it's very tender. And then if you look at the anatomical lie, usual testis is vertically lying in the normal position, in a normal anatomical testis. But in torted testis, it is usually transverse. And also because of the torsion, the testis is elevated compared to the other side. So it's slightly high riding testis and transverse lie. Then if you'll be very careful and very gentle about the testis, upper pole of the testis, you might be able to palpate a twisted cord, and it feels like a matted mass because of the twisting. Again, elevation is not a very good sign. We call it friend sign, but it's not a very reliable sign. But usually in torsion, whatever the moment will aggravate the pain, it doesn't relieve the pain. So pain is the key feature. Pain and the tenderness is the key feature at the torsion, in a case of torsion. So in a case of epididymocarditis, again, when you examine the scrotum, you must remember what we are seeing is a brown skin or Asian Sri Lankan skin complexion. So you won't get the typical, don't expect the typical textbook redness and bright red inflammatory features. What you get is very dull looking, a dark skinned scrotum. So again, tenderness is a key feature, but if you compare that with the torsion, tenderness is slightly lesser, and patients will allow you to gently examine. But what is most important is to examine separately and palpate separately the testis as well as the epididymis. So you can see sometimes very subtle sign of significant epididymal tenderness compared to testicular tenderness will drive you more towards epididymocarditis than torsion. So that is one important thing. So examination of the testis and palpation of the epididymis. Again, the lie of the testis is a neck differentiation feature. So the lie is usually vertical. It doesn't change to horizontal. Most of the time, these infections can they can have an associated scrotal wall inflammation. So you can have some skin turgor, increased skin turgor in the scrotal wall and edema when you palpate the hemiscrotum of an epididymocarditis patient. Not very reliable, but textbooks say elevation relieves the pain, but very hard to sort of elicit most of the time. Anyway, they're having significant pain in the testes. So those are the ways that you can differentiate the torsion from the epididymocarditis. So as house officers, when you sort of think after carefully assessing the history, examination, if you think this is a torsion, what is the first thing that you should do? So this is very important, right? You need to communicate with your seniors because probably your boss may be about to start an amputation surgery, which can probably your senior house officer maybe sort of trying to attend some other non-urgent case, but he'll be occupied in the next couple of hours. So you need to immediately discuss with your seniors, inform them that there is a possible case of torsion so that they know that they need to come down there within the next couple of minutes or hours and they need to explore the torsion. So communication is the key. And the moment you call them, they will ask you a set of questions. One of the important things is the time of onset. So when is the time of onset? Because there is a sort of 6 hours to 8 hours window to have to explore because time really matters for the to save the testicle. Then on the other hand, the anesthetic department, the anesthetic team will ask you when was the last meal, because we don't wait for 6 hours fasting here, but that we can go for a rapid sequence induction. So we can go for anesthesia, but they really wanted to know when was the last meal. Then again, the proper consent and clear documentation is quite important in these cases because there is a medical legal implication. So as a house officer, what are the component in the consent that which is more important in a particular case of torsion, suspected torsion? Just before you go for a testicular exploration, you need to have the consent. Usually these patients are adolescents, so you need to know that you need to get the consent from the guardian or the parent. And again, the other important thing is you need to explain there is a possibility of orchidectomy if the testis is not viable, and you need to get the proper consent for that. And also you need to explain the possible consequences when you take the consent of the orchidectomy. Then again, you need to explain and get the consent for fixing of the other side of the testis. These are small things, but these are quite important and you should not forget them when you take the consent for testicular exploration of a suspected case of torsion. So I'm sure that most of you must have seen, depending on the centers where you have trained, you may have seen torsion. So this is a testicular exploration of a torsion. So you can see a dusky color torsion with a twisted cord. So when we explore, we untwist the cord, and then we wait for a couple of minutes to see the color, to see whether there is any improvement. And also we explore the other side of the testis, and finally, so we fix them with inside the tunical sac to prevent future episodes of torsion. So that is what we usually do. And yeah, the key points or a few key take-home messages in testicular or scrotal emergencies and torsion. It's a clinical diagnosis, so you should not waste time finding ultrasound scans or sort of arranging various other investigations, Doppler. There is no clinical indication. If you think this is clinically torsion, you should not waste time. And just because we don't have much of time, we know that for successful testicular reperfusion, will have to do the exploration within 6 to 8 hours. After that, gradually the testicular viability drops down from sort of 100% to 0, 10%. Again, having a high degree of clinical suspicion is quite important. And again, proper communication with your seniors urgently is quite important. Again, this has a medical legal implication, so you need to have a clear documentation and clear consent on the BHD. So finally, we all want you to be safe interns. So we want you to sort of have a very good clinical sense and quickly diagnose, and without waiting, save the testes. What we don't want is to waste time and then lose the testes with the gangrene. Right, with that, I will just conclude, and thank you very much.
Thank you, Dr. Nishant Lianapathirana, for that very informative lecture. Please bear with us while we get hold of the next speaker. Next, please let me introduce you to Professor Bhavanta Gamage, who is a professor in surgery at the Faculty of Medical Sciences, University of Sri Jawajanapura, for a lecture on waiting for a surgical procedure. Over to you, sir.
Good afternoon, everybody. Can you all hear me well?
Yes, sir, we can.
Okay. So these next 20 minutes, I will talk about how you should treat and manage a patient who's waiting to go to operating room. So these 20 minutes, I won't put any slides on the screen because this now your internship is basically a practical yeah, your internship is basically practically based thing. So you should be able to practice and get more experience on what you have learned in books. So you have to put that into practice. So therefore, don't try to write down anything. Just list off hard disk, right? And then put that into practice. When you are a house officer in a surgical ward or any ward for that matter, number one is patient safety. So you have to make all efforts and make sure that your patient is safe at the end of the surgery or at the end of the treatment that you're planning to give. So then Now you have got a lot of theory knowledge. Now this is the time to put that theory knowledge into practice. So basically, when a patient comes for a surgery, or when the patient is admitted to a surgical ward, what are the things you have to do in preparing that patient for surgery? Now, there are certain investigations that are necessary to do, but those are routinely people will tell you to do, and you have to make sure. In surgical wards, there are 3 types of investigations. Number 1 investigation is there are certain set of investigations that you do to diagnose a particular condition. Number 2, the second set of investigation is to see whether there are any complications of the disease, or if it is a malignancy, staging set of investigations. Number 3 is, if the patient is coming for surgery, to see whether this patient is fit to undergo that particular surgery. So these are the 3 broad sets of investigations. So patient will come to the ward with set 1 and 2. They have been diagnosed most of the time, and if it is a malignancy, they have been staged, or to see whether there are any complications of the disease. These sets of investigations will be there. Then, as a house officer, you should check whether this patient is fit for surgery by history and examination. That is important. So you ask from the patient certain questions to see whether this patient will withstand the surgery. The surgery will be done under general anesthesia, under spinal anesthesia, or under local anesthesia, or any regional anesthesia. For that particular anesthesia, you should assess this patient is fit for anesthesia. Then also you have to check whether this patient is suitable to undergo the stress of surgery. Then, most importantly, when you encounter a patient, this is applicable to any aspect of medical care, the communication is the most important thing, right? Sometimes I know it is not the correct thing. Consent is taken by the house officer. You are not a person who is capable of taking the consent, right? Because you can't, sometimes you can't explain what exactly is going to happen, or what are the possible complications. You may not know. Therefore, if you don't know, it's always better to tell somebody senior to you to explain the surgical procedure and possible complications to the patient, right? Not only the patient, you should also talk to the patient's relations, because sometimes, even though you explain everything to the patient, right? If something goes wrong, and if a complication, a recognized complication, even a recognized complication occurs to the patient, if you haven't explained that these type of complications are possible to patients and as well as the relations, then if you haven't explained that, then the people, natural tendency is the people will think that is something that has happened because of not a complication, incapability of a medical care person or a surgeon or person who did the surgery. That is not the case most of the time, because there are recognized complications which can happen after any surgery. So if you have explained, for example, if a patient has come for a ERCP, after ERCP, there's a possibility of pancreatitis. So if you haven't explained to the patient that there is a 10% risk of pancreatitis after ERCP, and if unfortunately if that particular patient got pancreatitis, then after patient has got pancreatitis, if you try to go to the relations and explain this can happen, they won't, I mean, they may not believe you. Therefore, always better to explain what are the possible complications prior to surgery. So, so communication is very, very important. And unfortunately, if patient dies after a surgical procedure, even though you have explained everything to the patient won't be there to tell anybody. And the relations will tell, we know we were not informed about this complication. So therefore, it is very, very important that you should talk to the patient as well as to the closest relatives of the patients, right? So that's about the consenting. So if you are not capable of taking the consent for that particular procedure, please ask your senior and get some information, and then you can, with your senior's permission, you can get the consent. That's a different matter. But if you are not sure, don't try to take consent from the patients, right? And you must remember, you are under a consultant. This is still your training period. You haven't got your full registration. So therefore, there are certain things that you should not do by your own. And one thing is taking the consent of a patient if you don't know what exactly is going to be done, right? Then other important thing is, now there are certain surgeries that are done on paired organs, right? For example, kidneys, inguinal hernias. So there may be one side or the other, the problem is. So as a house officer, you should, once you finish your history, once you examine the patient, you should mark the site of the surgery. Sorry, I got disconnected. Can you hear me again?
Yes, sir, we can.
Right.
So always marking the surgical site is a very, very important thing to do. And please practice that so that your consultant will not fall into trouble. Because sometimes, even though inguinal hernias, people think, okay, it's a spinal, under spinal anesthesia, so always you can ask from the patient. But still, good practice, you should mark the side of the surgery. So consenting, checking before consenting, always develop a good rapport with the patient, communication. These are called non-technical skills. Always explain the procedure to patients' relations, right? And then the consenting process and checking whether the patient is fit to undergo the particular surgical procedure. When you're checking that, you should know what sort of a surgery this is, whether it is a minor surgery, whether it is an intermediate surgery, or whether it's a major surgery or major complex surgery. Depending on that, there are certain set of investigations that may be requested, that may have been requested by the anesthetist. So make sure that those investigations are done and they are in order. Other most important practice that you should have is when you request an investigation pre-operatively, let's say a patient admitted in the morning, you have requested electrolytes, you have requested full blood count, and then make sure before you go out of the ward in the evening or when you come to the evening ward round, make sure you check these investigations, whether they have come, not only whether they have come, whether they are acceptable, right? If they are not acceptable, you have to take remedial measures. That's number, right? Otherwise, no point of sending this investigation. Then other important aspect is some patients will require blood products, right? So you have to make sure, now most of the hospitals, cross-matching is done early in the morning, right? So they ask if the patient is going to surgery at 8 o'clock, the blood samples are sent or cross-matching at 7 o'clock in the morning, right? So make sure the forms are duly filled and then the bloods are sent early in the morning before patient goes to the theater. If certain surgical procedures are done with the cover of certain blood products like fresh frozen plasma. Now, if a particular procedure is done and it is necessary to have fresh frozen plasma, you have to know that those things has to be requested well in advance, because unlike red cell concentrate, you can't just quickly get fresh frozen plasma and infuse to the patient, right? Because those are frozen. Those are kept under minus 35 degrees Celsius. So it has to be thawed into body temperature before the patient is given those things. So those things are important, right? Right. So these are the important things that I have to tell you. Now, in surgical wards, other important thing is you have to always ask for patients' allergies, drug and food allergies. Right? Drug to a patient will develop a reaction if he is allergic, then you can treat that. But sometimes the drugs are given to patients in surgical wards or in theaters when they are under anesthesia. So if you haven't asked allergic history from the patient, no one knows, and patient can be easily given a drug which is allergic to patient, because anesthetists can't ask that, because patient has already has been given anesthesia. So allergic history is very, very important in surgical wards, and you have to check, right? So those are the important things that I have to tell you. Any questions, I'm happy to answer. So in summary, first thing, communication with the patient as well as with the relations, right? Consenting, if you are incapable of taking that consent from patients and the relations, don't try and take consent. You have to get your seniors involved, and then ask, if the seniors want you to take consent, please ask from them, what should I tell the patient, what are the possible complications should I tell the patient? Because our patients' education levels are different. So you have to do that. The safety is most important. Marking the surgical site in patients who undergo surgery on paired organs, checking the investigations, what you have sent, double check whether they are in order. If you are to use blood products, you may contact the blood bank and make necessary arrangements, right? And most importantly, the allergic histories, right, from the patients. So those are important things. Any questions I can answer? I've got 1 more minute. Okay.
Thank you, Professor Bhavantagamage, for that very detailed lecture. Next, please let me welcome Dr. Gayane Kanayaka, Consultant Plastic Surgeon at National Hospital of Sri Lanka, Colombo, for a lecture on burns. Thank you.
Right. I think, sorry about that. Can you hear me now?
Yes, sir, we can.
Okay, sorry about that. So we will talk about burns because it's a very important thing. As I remember when I was an intern and we had burns coming into the Colombo South Teaching Hospital or Colombo Hospital, and of course our knowledge was pretty basic back then, and it doesn't have to be. So we will try to talk about conditions like this. Now, this is a 16-year-old boy who came to us with a severe burn. You can see what has happened, and he has fallen on a heater after a water heater after an electrocution, and he has sustained this injury, very gruesome injury. Why we need to focus on burns and change our attitudes towards burns when we start internship is this case is a very good example. He's a 16-year-old boy. It could be your brother. This child is going to have a very, very difficult life ahead, and he's not going to die of this burn, but he's going to get scarred, and he will have problems in going to school. He's going to lose his school time, and he's going to be ridiculed in the school because not everybody will be empathetic as we could be. And also he will find it very difficult to find a suitable partner, and even his kids will despise him, even if he finds a wife and get married and have kids. His children will not like to have his, the deformed face. There's a chance that his kids might be scared, would not like to go with him to school. And there's a lot of psychological trauma that's going to come to this person.
he's not going to die because he's going to live his normal life expectancy, and he's going to live through this horrific injury. And along the way that you have, he would have met you, and you could share a bit of kindness towards this person's agony in life. And as interns, and sometimes you are the first person that will come into contact with these sort of unfortunate individual. So why do we need to look at them very empathetic, with sympathy, great sympathy and kindness? Because they seek your assistance, and they will look up to you for any sort of help that you can provide them. And it's not only this case, and you get a lot of case scenarios. Every burn will have a sort of story attached to it, and it will always have some sort of a psychological impact on the patient as well as the staff and also the family of the victim. So this the burns that you get, this is the thing that you need to worry at the first go. So I will share this slide with you, so you can actually do the primary survey and the secondary survey, and in between there's something called FAT, and you need to look after these things. We will go through this very quickly. So the incidence is not very sure, so very, very poor data is available because we don't fill the proper data into the bedhead tickets. So for that, I have already shared the PDF that you need to carry when you go and see a patient. Of course, you can get them printed from your hospital, or it just from your printer, and have it with you. So you just need to tick those boxes, and you will not miss important areas that covers the burn totally during the first 24 hours. So please make use of that document which we use at the National Hospital. And in case you if you are transferring the patient, please take a photograph and send it across, or attach to the BHT or the transform when you transfer the patient. Okay, it's a very, very costly affair. The burns will have a lot of cost, and even if it is government sector, it costs very much to the government to look after these patients. So making sure that they survive and you get the cost, going to at the end you get a live patient is very, very important. And the causations of male adults is usually accidental flame burns, and females also accidental flame burns. These are major burns, not minor burns. I'm sure you all had minor burns when your day-to-day activities, when you try to iron your shirt, try to take a hot pan out of the stove or the cooker, and you would have got a burn. They are very nasty things. They are very painful, and these are things that can happen to anyone at any time. It may be you, it may be the president, it may be a king or a queen. You are still liable to get a burn even during your day-to-day work. So, and in children, the accidental burns, scalds are common. That's hot water burns, and self-inflicted burns or self-immolations are very, very common among females. So this is a really a tip of the problem, and you should never look down upon them because you have never lived their life. You can never criticize them for what they have done. It's not up to you to decide what they have done is correct or wrong. You just have to treat them as any other condition. So this is basically the first aid. This is how you do the
අදත් මොනවද ඉගෙන ගන්නේ? මං ඔයාලට කියලා දෙන්න හදන්නේ ඔයාලගේ ඇඳුම් වලට හදිසියෙ ගිනිය වෙලුනොත් මොකද කරන්න ඕනේ කියලා. එහෙම වෙන වෙලාවට කලබල නොවි නතර වෙලා බිම දිගා වෙලා පෙරලෙන්න ඕනේ. අපි පෙරවුරුවක් කරමුද? හරි. දැන් ඇඳුම් වලට ගිනිය වෙලුනා කියලා හිතන්න. දැන් දෙන්නම නවතින්න. ඊළඟට බිම දිගා වෙන්න. මුණ ගින්නෙන් ආරක්ෂා කරගන්න අත් දෙකෙන් මුණ වහගන්න. ඊට පස්සේ ගින්න නිවෙනකන් බිම පෙරලෙන්න ඕනේ.
හුළඟෙන් ගින්න වැඩි වෙනවා. බිම් පෙරලෙනකොට හුළං.
Right. So this is stop, drop and roll. This is just a small video that we have created. And the next important thing is the cooling of the burn, minimum of 20 minutes. And these are things that are effective up to 3 hours from the burn for thermal burns. But chemical burns, whichever time that the patient comes, you need to irrigate the burn so you get the acid or the alkali of the patient. So sometimes an hour, sometimes few hours till the patients becomes symptoms become better. So what is a burn? Burn is not a superficial thing. It has a depth. So the most important area that necrose is the zone of coagulation, which has coagulative necrosis of cells in the skin. And this can be surrounded by a zone of stasis where the blood circulation is limited and sluggish because the cytokines and the neuroendocrine response of the surrounding area causes the stasis. And the surrounding area to this becomes hyperemic. So this is an effect that we will see up to 20% where it is localized. When the burn surface area is more than 20%, this extends to the entire body. So this becomes a disease. So burn is no longer a wound, it becomes a systemic problem. So this, you can see this type of a burn coming in. Burns are heterogeneous. You get very deep areas, superficial areas, and you get a charred area. Sometimes it can even go down to the bone. So the burn depth will change from center to periphery. It changes, and initially for 3 to 4 days it changes. So what are the factors that are important are the adequacy of first aid and also adequacy of resuscitation. So these will change the burn depth. As you have been taught earlier, the burn shock is a type of shock that we will get during the first 24 to 48 hours. So your idea is to maintain the circulation by means of IV fluids. What is the IV fluid we give? Not saline. It is Ringer's lactate, or that is RL solution. So don't give saline for severe burns. Only give Ringer's lactate because the patients will have sodium overload later on. Once the fluid comes to the system, they will have a lot of sodium, and they will die with hyponatremia if you don't remove, if you give normal saline. So remember that. And you need to start colloid. The best colloid that we recommend is fresh frozen plasma, not albumin, because albumin itself carries a lot of sodium. So don't give albumin for big burns because they tend to store albumin in the system. So remember this extravasation of fluid albumin. If you give during the first few hours albumin, that will also leak out, and that will increase the lobe edema. And this is the same thing that happens in hypovolemic shock that can lead to hypovolemic shock. So there are metabolic effects. I don't want to go into details, but these have been taught to you. And these are the effects. There's cardiac suppression, respiratory distress syndrome, immune dysfunction, and loss of gut integrity. So how do you tackle these things? Cardiac suppression, of course, you need to monitor these patients, and respiratory distress, you need to give them oxygen and look after their airways. And also sometimes you might need to do bronchoscopic lavage to get rid of the soot that is going in and causing a chemical burn inside the lungs. And immune dysfunction is something that is very, very dangerous because these patients, even if they survive the initial period, they will die due to sepsis. So the idea of saving them relies on resurfacing deep burns and waiting out for superficial burns. We'll talk about the burn types very soon. So there are three categories. They can just come with only burns, and there may be some other injuries covered by the burn. They could have fallen from height after the burn. And there may be sometimes other burns. They could have got a burn while, car getting, caught catching fire. They might have jumped from the thing and they got a fracture and then got a burn. So there are different things. Never get distracted with the burn. They all of them should be treated as a trauma victim, and then looking after while you look after the burns. So they can be unconscious, intubated, psychotic, substance abuse. So these are uncertain scenarios. So first aid, stop, drop and roll while covering the face, and water for cooling for minimum of 20 minutes. And immediate life-threatening conditions will be done by the primary survey with this slide. And I have shared the Association of Plastic Surgeons Facebook page. Please join this page so we can give you updates, and you can also post your requests and your queries to these sort of events that you need to have more knowledge on. And the primary survey is something like that. Airway management will always go in line with the cervical spine control. Breathing, you supplement with oxygen. Circulation with hemorrhage control. Remember, disability, you check the neurological disability, and you do check the pupils and whether the pupils are reactive, and whether the patient, it's just whether the patient is having a neurological deficit. Exposure is the important step where you calculate the burn surface area and with the environmental control. Now, these sort of patients where there are a lot of burn will look like this when they come into the resuscitation bay or the emergency admission, but few hours they will look like this. They get bloated up, and you will find it's very, very difficult to intubate them, and you might need to intubate them fairly early if you are going to save this patient. And so always try to have very good access. So take, at the same time, when you have good IV access, take blood for investigations, and also cross-match blood and start trigger lactate before even calculating the fluid levels. Now, disability, this is another AVPU. You saw, you were there when the neurosurgeon was explaining about this. But do the AVPU quickly, and then you can go into GCS if you find something not really normal. And you cover the patient and keep the patient warm while you expose the patient, and log roll the patient. Remember to log roll always to look at the pack. Now, use the rule of 9. This is what we do, very, very quick and very accurate way for adults, and use the palm aspect of the hand of the patient and the entire palm like this, and that is equal to 1% of the patient's body surface area. So, this is the chart we use for kids. As you are aware, when we have more head size, so double the head size when compared with the body proportions, and then slowly the head size will proportionate shrink and becomes 9%, and those 1% every year will be added to lower limbs, and while the lower limbs grow, and the last 1% will go into the perineal area, so that becomes another 1%. So the fat in between, once they are primarily resuscitated, go to fat. That means fluid, check the fluid, and then take X-rays, and analgesia is very important, and tubes, several tubes has to be there, like the catheter, urinary catheter, NG tube, and also sometimes the endotracheal tubes. So the fluids we use, if you're not in a ICU setup, use this modified Parkland formula, where 3 to 4 ml for the weight of the patient and burns, burn surface area, total burn surface area, TBSA. And in children, remember, don't give, not only you need to give the burn fluid, but you need to give the maintenance fluid through another line, and it will be basically half normal saline with dextrose and added potassium chloride, and the maintenance calculation is given here. So burn is a very painful condition, and nobody wants to get a burn. Remember that you need to calculate the morphine dose that you are going to give, and then give it so the patient will have pain relief. If you have the X-ray there in your emergency, you can do some X-rays, but I would recommend get the fast scan done if you have this ability, and then you can slowly do the X-ray facility once this primary survey and secondary survey is done. These are the tubes that I suggested, and start monitoring the patient. Urine output is the most important thing in our setup, because you need to maintain the urine output 1 ml per hour per kilogram for adults, maybe half ml, maybe half ml or up to 2 ml is normal, but you need to keep an eye on hourly urine output. And the fluids that you give have to be given within half within the calculated fluid, half within first 8 hours. Rest is divided even during the next 16 hours. If the patient comes very late, maybe 4 or 5 hours, you might need to give a fluid bolus and see the urinary response, and then you start giving fluids and slowly titrate it to the calculated amount. So secondary survey is the same thing that you will be doing, and the examination will be like that. Remember to keep documentation. I have sent you the documentation that you need to do essentially, and tetanus prophylaxis is another important thing, and consent issues. Because if the patient has been burnt alive, you need to get the statement before you intubate, because even if once you intubate, you might miss a murder. So you might need to get these important facts out of the patient. Don't threaten the patient, but try to get it. Even if you can't get it, you have to say whether it's a suspicious situation. You need to document that in your ticket. Whether it's you smell kerosene, whether the patient have doused herself or himself with petrol or kerosene and set themselves on fire, we don't know. But if you smell it, you have to document it. That is the most important thing. So evaluate, reevaluate. So it's up to you to. You might be saving the patient if you detect any deterioration of urine output, and you remember to look at the blood urine output as well as the color. So the dying patient is another important aspect. When you know it's a 90%, 100% burn coming to you, they are going to die. So there's no point intubating those patients. Let them talk to the relatives, and let the relatives know that this is not a salvageable. Next problem is the relatives might pressure you to transfer this patient to National Hospital or the burns unit close by burns unit, which every hospital has every major teaching hospital has a plastic surgeon who are trained in burns. They have had their fellowship in burns, and they have been in centers where they have saved up to 80-90% burns. But at Sri Lankan setup, we cannot go beyond 50 to 60% on a constant basis. So if you think the patient is dying, if the patient's relatives are threatening you to transfer the patient to a national hospital or somewhere, take a call. I will leave you the number, and just take a call to the burns unit and tell them that this patient, the relatives are asking, you understand this cannot be, resuscitated, even if they land in the national hospital where I treat burns patient. You will realize that the easiest way is for us to take the decision by not accepting the patient, explaining to the patient's relatives that this, although the patient is going to be transferred, we will not be able to save this patient. It's just going to add to their transport cost. You are going to transfer a dead body from this hospital back to your place. So this is another way of handling this sensitive issue. And please don't hesitate to contact the burns unit or myself if you think you need to explain this further to the patients. Right. So there are unstable airways. You need to see whether the patients needs intubation. During the ward stay, you need to check whether the patient can breathe on their own. If you think the level of this level of consciousness is decreasing, make sure that you think of intubation. And carbon monoxide poisoning and cyanide poisoning, which is cyanide. Interestingly, cyanide is something that is produced by burning plastics. So ultimately they are referred to us. With this cherry color, of course, we don't see cherry color in our skin because we are totally brown. And the carbon monoxide and cyanide poisoning, both treated with oxygen, and remember that. So carbon monoxide poisoning, you get these unconscious patients with very bad. So burns, we have 3 types of burns: superficial burns, mid-dermal burns, and deep dermal burns. So this is a epidermal burn. You get this sort of epidermis getting burnt. They recover without any problem. So superficial dermal burn, they recover within 14 days because the hair follicles are intact and sweat glands are intact. So they recover. You need to keep them without getting infected. So need to put better dressings on it. So these are the superficial burns. You get blistering and those things. And mid-dermal burns do recover, but it may not recover also. Sometimes you may need skin grafting. Remember that. And these are sometimes, we see some blotty areas where the white area is deep though, right? Deep dermal burns can be brown to white, and it can be just red mottled patch on the surfaces. Can you see some of the deep burns? And full thickness burns are something like this. It's a charred thing. You can just, and burns change with time. Remember, this is a slide to show how the burns change. Urine outputs are, these are the urine outputs. Adults, it's 0.5 and can be up to 1 ml. And children, remember, it's 1 ml, always 1 ml, but there's a range that you need to maintain. So we talk about underhydration, overhydration, and sometimes hemoglobinuria, or sorry, myoglobinuria is another problem. So burn wounds, remember, burn scrub is a very important thing. You take the patient in as soon as the patient is suitable to get a GA and scrub the burn off and put a dressing, which you can get the advices from the burn surgeon. And these are the burns that needs skin grafting later on. So this is a slide that I want you to see. And remember to wash with clean water or saline, and then dry cloth and clean with a clear plastic film or cover it. And you need to have topical antimicrobials unless definitive that means if you are going to transfer this patient, you can have something like silver sulfadiazine applied on the patient before you transfer. So pediatric burns need to be transferred, and this is the summary of what you need to do. Contact the closest plastic surgical unit or refer or transfer as an outpatient basis. Those are the important steps. And I haven't touched other steps like, when they are in the ward, what to do and all these things. But for those things, you need to communicate with the plastic surgical team in your teaching hospital, or the surgeon, general surgeon who is looking after. They are all experienced. They have worked for a long time, and you have to ask them for their guidance. Right. Thank you so much. So this is the burns unit number, and this is my email. If you want to have any ask any questions from me, don't hesitate to ask questions. Am I on time, guys? Hello. Hi. Any questions? And remember that I have already right. So the dressing summary, somebody has asked about dressings to apply. So we recommend initial dressing to be, if there are superficial burns, of course, there are newer silver dressings. Unless you are experienced to how to apply them, don't apply them, because if you clean with saline and apply the dressing, that you are going to destroy the silver in it. So there's no point doing it. And don't apply it on dead skin, because it's not going to do anything. These are for superficial burns. After a burn scrub, not to apply in a ward setting. So the silver sulfadiazine is a good antibacterial thing, but you need to apply it daily, so you get rid of the antibiotics. Never start antibiotics. I have not mentioned anything about antibiotics. If you start antibiotics, it's just going to, you are going to run out of antibiotics after 3 weeks. So it's a race between time and the skin grafting and death with death after running out of antibiotics, because ultimately within a month, usually major burns has to be skin grafted and finished off. Otherwise, the patient is going to die with the sepsis that we cannot treat with the current available antibiotics in our system. So if you start the antibiotics early, then you are going to get only the resistant bugs on the patient. Then you're going to end up with less time to treat the patient. So remember, don't start antibiotics unless you have culture positive or something growing in the culture. You can call the microbiology lab within 24 hours. They will tell you whether there's a growth. And the first line would be a simple antibiotic. Don't use something like meropenem as first line, because they are usually pseudomonas and they gradually go into these areas. And don't keep the burns patient next to the toilet. They are critically ill. Remember, they need constant monitoring, constant nursing, a lot of NG feeds, and start about nutrition. Lot of eggs. Give them about 30 egg whites per day. The blender them, just cook and blender them and give it to them, and they will be their protein levels will go up. Nothing works. Don't give expensive milk products to them. It will just increase the cost to the patient's management, but it's relatively less effective than a good healthy diet and NG feeds. Remember, NG feeds are very important in burns. As interns, you should look after the nutrition of burns. And even if once you treat the patient and once the patient is discharged, remember to refer to the occupational therapy to get the patient's scarring under control and all those things. Maybe refer to a plastic surgeon if your surgical unit has finished the treatment, but the treatment, the rehabilitation never ends. It needs about another 2 years of treatment. Did I stay within the time, guys? Hello?
Yes, sir. Thank you so much for that lecture.
Right. So if there's anything that you need to, so somebody has again, so yeah, you can apply silvasulfadiazine, available drugs to remove scars. There are no available drugs to remove, but the scar management itself is a big area. Scar management has to be done by a professional, where there are professionals in your hospital. The occupational therapists are the professionals that we have trained to look after burn scars. Ask them to manage it, but you need to give the recommendation. Get the recommendation from a plastic surgeon, send the photographs across and ask what to do, and they will advise you. And you can directly communicate with the Facebook. I have put the Facebook link to you, so you can communicate with the entire plastic surgical community at your fingertip. You don't have to be scared to ask us, because we are a friendly bunch of people. And yeah, somebody has raised a hand. I'm not sure why, but anyway, thank you so much for listening to me, and hope you will change the attitude towards burns patient. That is, even if you don't treat a single burn patient, have sympathy. I don't mind not having empathy, because it's a very difficult because you have not been undergone burning, so you don't know how it feels. So just have sympathy. That is all I will ask you. If you have sympathy, give plenty of sympathy towards them. Thank you so much.
Okay, so thank you so much. Please take a 5-minute break before we move on with our next session. And please make sure you fill in the feedback form. You can find the link in the chat.
Hi. Can I start, please? Hello. Here, I'm online. I'm on.
please let me welcome Dr. S. Rajendra, Consultant General Surgeon, for a lecture on the topic, patient has just returned to the ward after major surgery. Over to you, sir.
Okay, good afternoon. Welcome back after break. The topic that I'm going to discuss sorry for that. The topic that I'm going to discuss today is a patient has just returned to ward after a major surgery. What should the intern do? In this presentation, I will briefly touch on the concept of major surgery with examples. And then, of course, I will highlight the concept, aims of post-operative care and the influencing factors. But the main focus of my talk will be on the patient who has just arrived ward after a major surgery, and what should the intern do, a stepwise guide. And towards the end, I thought I will give some important issues related to subsequent post-operative care on ward, and also some post-operative complications following major surgery. So to start with, what is major surgery? As you all know and you all understand, this is an invasive operation. For example, a thoracotomy, a laparotomy, or a craniotomy where the body cavity is entered. And usually it involves extensive dissection and resection such as organ removal and change of normal anatomy. So you all know the examples for minor surgery, intermediate surgery, and major surgeries. I would focus on the major surgeries based on this topic. So when you work as an intern medical officer, you can come across patients coming after major surgeries such as laparotomy with a small bowel resection, colonic resections, major amputations, arterial surgeries or vascular surgeries with bypass, cholecystectomy with CBD exploration, total thyroidectomy, APR, AAA repair, aortic aneurysm repair, Whipple surgery, and gastrectomy, and so on. I have just given you some examples. So we are going to deal with the post-operative care of patients following major surgery. As you all understand, the post-operative care of a patient after surgery has 3 phases. The first one would be the recovery phase. And in the recovery phase, the patient will be closely monitored for the vital signs. If the vital functions are stable, he will be sent to ward. If the patient needs some organ support, he will be sent to either HDU or an ICU. When the patient is arriving ward, the subsequent post-operative care will be at the ward level. And when we decide the patient is stable and he can resume the normal function, and he will be discharged home. And the subsequent post-operative care will be given at clinic level. Now we are going to focus on the inward management of post-operative patient after a major surgery. So the aims of inward post-operative care of a patient following major surgery, first is to maintain the stable general condition. That means to keep the patient in comfort and in pain-free. Secondly, we have to monitor the vital signs, and we have to detect complications very early. We also should detect post-operative complications specific for certain major surgeries, which I will mention towards the end of my lecture.
Of course, the other aims of post-operative care in ward would be to prevent complications like DVT and also to maintain fluid electrolyte balance. Keeping this in mind, we should always think in terms of monitoring the patient following major surgery, and the intensity with which we are going to monitor and the frequency with which we are going to monitor the patient will be influenced by certain factors. These would be the type of surgery and the pre-surgical health status of the patient, extent of the disease, that means the extensive resection has been carried out or not, the duration of anesthesia, and the amount of intraoperative blood loss. Keeping these basic facts in mind as to what a major surgery is and the aims of in-ward patient management following major surgery and the factors associated or influencing the post-operative care in the ward, we will move on to consider the topic proper. That means the patient has returned to ward after a major abdominal surgery. What should the intern do? Okay, now when you are working as an intern medical officer, you will receive a call saying that, doctor, a patient have from after a surgery like, a laparotomy or a peptic ulcer perforation has come to ward. Okay, what should you do first? First of all, you must tell them, okay, well, can you just keep the patient close to the nursing station? I will come in a minute. So you have to be there in the ward and assess the patient in person. So basically what I would like to stress is that these sort of instructions and management of patient immediately after surgery in the ward cannot be done over the phone. So you have to reach the particular ward and you have to assess the patient. You have to organize a bed close to the nursing station. And then you must first see the bed-headed ticket and you must write down the summary of the disease status, comorbidities of the patient, and the risk factors and the type of surgery. For example, you can write on the BST like this as an initial document when you start seeing the patient. Say, for example, a 63-year-old obese, hypertensive, diabetic patient with early renal parenchymal disease underwent laparotomy for peptic ulcer perforation or a gastric ulcer perforation. So that would sum up, that should suffice. So that would be the first step, to mention what has happened. The second step you should do is that you have to document and follow the instructions given about the post-operative care by the anesthetic team and also the surgical team. So for example, in the previous scenario or example that I gave you, you would see sometimes the notes would be written like this. In the post-operative care of the patient in the ward, you have to prop up the patient, give oxygen via nasal prongs, keep the patient ill by mouth, and about intravenous fluid, analgesia, antibiotics, and about the parameters that have to be monitored in the ward, and also about monitoring charts. So this is basically an example of what would have been written in the post-operative notes. So try to read that and then document that in your observation, in your writing, and you have to document it and you have to write it on the bed-headed ticket. So once you have finished these two steps, then of course you have to talk to the patient. You have to talk to the patient, inquire and document. I'm stressing the fact you have to document each and everything that you do and your results. That is very, very important, especially in a patient following major surgery who's coming to ward. So when you inquire the patient, you have to concentrate about general comfort of the patient, about the pain, about the thirst and other specific symptoms. So this gives a sort of great comfort to the patient when you ask about the patient's problem after a major surgery, rather than just jumping onto investigations or jumping onto some examinations. Just talk to the patient first. And then the step 4 would be the examination. Well, it is not a sort of very detailed examination, but when the patient arrives the ward, you have to examine the general condition of the patient. Is the patient comfortably breathing? And where the airway is patent, or the mouth is filled with some secretions or anything like that, airway patency, effectiveness of breathing, and about just auscultate the chest for air entry, and also make sure about the pressure areas where the patient is just lying down on the bed after a major surgery. So with this quick examination, you can document if you want. For example, the patient is comfortably lying on the bed. He can speak, so that the airway must be patent. Auscultation, air entry is equal on both sides. Likewise, you can document. The step 5 would be to check the tubes, lines, and the dressing. So make sure the nasogastric tube, urinary catheter, abdominal drains, whether they are kinked, whether they are blocked, and also note the contents in it. And you must also focus on the IV cannula, whether this is functioning, and just have a glance over the surgical site. Don't remove the dressing. Just look at the drapes, the dressing over the wound, to see whether they are soaked with blood, any sort of oozing from there. Those are very, very important observations immediately you have to do when the patient reaches the ward following surgery. So this picture shows you a patient who has a nasogastric tube in place, and also he is given oxygen by nasal prongs. You can see in this patient, in this picture, the patient with a nasogastric tube has got a nasogastric output, which is slightly greenish in color. And then you can see a patient here with a indwelling Foley catheter and the urinary bag filled with urine, slightly darker color, and the drain from abdominal side. So this is following a surgery, a major surgery, abdomen. So once you have done that, you move on to the step 6, where you have to check and document the vital parameters like pulse rate, blood pressure, the oxygen saturation, and the urine output. Usually we do hourly urine output monitoring, and about the fluid balance and the sugar level, especially important in a diabetic patient. So these will have to be checked, and you have to document that in the metadata ticket. For the documentation, you all know there is an observation chart in the wards, and you have to fill it. So you can place the time, and you can fill the respiratory rate, saturation, temperature, pulse rate or heart rate, blood pressure, and so on. So this will be available. You have to do it. So this will give you a sort of overall idea as you go on filling this chart. You will get a sort of graph, and that will give you a good guide as to what is happening to the patient and the clinical status. Okay, when you are doing like this, the patient may have tachycardia. Then you have to analyze why this patient has got tachycardia, whether this is because of inadequate pain relief, whether this tachycardia is because of inadequate fluids replacement, or whether the patient is bleeding inside. Has he got fever so that the patient has got a tachycardia or increased pulse rate? So this is how you should have an analytic mind while taking and checking these parameters. And when you come across sort of abnormal reading, you have to find out the possible cause and possible reason for it. So if you can do that, then of course you should move on to the step 7, where you have to assess and document the level of consciousness, where the patient is alert, conscious, and rational. So if the patient is slightly confused following a major surgery in the ward, what would be the reason? Simply, you can remember the 5 S. Whether this is because of sepsis, which can be a pre-existing sepsis for which he would have been operated on, or whether has he developed any electrolytes abnormalities, serum electrolyte abnormalities like hyponatremia. Is there a problem with saturation of oxygen? Is it because of the opioids that we have used for pain relief? Is it because of old age of the patient? So sepsis, serum electrolytes, saturation of oxygen, sedation, and senility. So these are basic reasons. I mean, there may be a couple of other reasons, but as an intern medical officer, if you can think in terms of these 5 initially, this would help you. So if you can work out on that line, the most important step would be the pain management. Now you have studied in your curriculum to become a medical graduate, you know, you have mild analgesics, you have moderate analgesics and strong analgesics, and there's a step ladder pattern, you all know. But in case of a major abdominal surgery, we can't go along the step ladder. We have to straight away use strong analgesics. So usually following major surgery, we have to use opioid analgesics like morphine, pethidine. And sometimes the patient may be with an epidural analgesia, and sometimes the instruction would have been given to place diclofenac suppositories in addition to opioid analgesics. Because usually patients are kept nil by mouth following major surgeries. Usually, immediate post-op, usually they keep nil by mouth. That means the patients won't be allowed to take anything by mouth or will be allowed to take some sips of water alone. You can see 2 pictures in this slide. So in the first one, patient is not given proper analgesia. The second one, the patient is comfortably sleeping because we have given adequate analgesia. So this is the basis of what I told you, that you have to get down from the ladder rather than climbing up the ladder following major surgery. So you have to start opioid drugs and other drugs together in major surgeries, and subsequently you can reduce the doses and the drugs, you can change the drugs as the days goes on. So this is basically an important one you have to always remember when you treat a patient in the ward following major surgery as far as the pain management is concerned. The other important step would be the intravenous fluid management. Always follow the instructions given by the anesthetist and the surgical team in the post-operative notes of a patient following major surgery. And they would have mentioned about what IV fluid will have to be given and what would be the drip rate or the amount of IV fluid. And those, of course, you have to follow. And most important one would be to maintain an input and output chart. The reason is because to assess the adequacy of fluid management, the amount of fluid that you are giving to the patient, is it enough? Are we giving more, or are we giving insufficient amount of IV fluid? So that, of course, you have to assess by your monitoring pulse rate, blood pressure, and urine output. For example, a patient has come after a perforated peptic ulcer surgery, a major laparotomy, and he's in the ward, and you are giving a fluid, and the patient passes urine, which is lower than the needed or required amount. That means if the patient is passing less than 0.5 ml per kilogram per hour, for example, in a 60 kilogram man, about 30 to 35 ml per hour is the needed amount. So if the patient is passing less than that amount of urine, that means the patient has got a condition known as post-operative oliguria. Why? Is there a block in the catheter? Is it because of our inadequate IV fluid given? Is it because of low cardiac output or any sort of cardiac event is taking place? Or has he got an impaired renal function so that whatever that we are giving is not coming out in the urine? So if you can just work out on that basis, then of course you can get a clue as to why the patient is not passing enough urine. So basically what I would like to stress is that you have to monitor the patient to check and assess the adequacy of your IV fluid. The step number 10 would be to review and document the medications. There would be instruction about the IV antibiotics. There may be instructions about H2 blockers and to prevent stress ulcers. And the patient would have been on medications for hypertension, diabetes, and so on. So the regular prescription medicines, and of course, DVT prophylaxis. So those, of course, you have to go through, review, and document in the better ticket, especially in the drug chart, where you have to mention the dose, route of administration, and frequency, and you have to sign. So as an intern medical officer, you would be given this chart, and you must be knowing how to fill this medication, name of the medication, the route, dose, and the frequency, and you have to sign. So this, of course, you have to keep very clearly, and you have to review this chart daily as you go on with the ward rounds. So if you can do these 10 steps, basically you have done most of the things that you have to do when you have received a patient following major surgery. But that doesn't stop there. You have to discuss with the patient. You have to inform the patient about the surgery, because patient is conscious and alert. You have done something, the patient may be watching as to what you are doing. So you have to tell about the surgery and the progress following surgery and the expected course of treatment in the following days. And then, of course, you have to communicate with your seniors or the consultant in charge of the ward to inform about the post-operative clinical status of the patient, because you have assessed, you have documented it, and you can give a summary of what you have done to the consultant in charge. So when you inform them, you will get an additional management plan or some additional requirements that you have to do over the phone or from your consultant. So these things you have to write in the bed ticket. That means you have to write in the notes. So this is what you have to do when a patient reaches a ward after a major abdominal surgery. Well, the subsequent care on the ward is also important. That means a patient has come to the ward by about 3 o'clock in the evening. You have done the review, you have done the immediate post-operative care, and by about 6 o'clock, you have done a couple of monitoring so that you can inform your consultant about the status of the patient. Okay, now you know some management plans which have been given by your consultant. Then now you are coming for the ward round on the next day. So daily you have to do the same. You have to assess the patient, you have to check the charts, you have to review the analgesia and medications, and you have to communicate with the patient as well as your superior. And in the ward rounds, you have to document it. Especially following a major abdominal surgery, the sort of detailed abdominal examination with the superficial palpation and deep palpation may not be suitable, because the patient will definitely have pain. So you have to have a look at the surgical site drapes for oozing and bleeding. If the patient has got abdominal distension, of course, you can try to measure the girth, or you can go for a very, very superficial gentle palpation if the patient complains of severe, very severe abdominal pain. And of course, as you proceed with fluid management in the subsequent days, you must always consider the daily requirements, insensible losses, losses from gut, nasogastric tube, urinary tract, and also losses from stroma and drains. I didn't mention about the exact way to calculate because of the time constraints, but I'm quite sure that you all are aware of the fluid management and the amount of fluid calculation and so on. Of course, following major surgery, you must always test the blood. That means lab tests are frequently done to assess the hemoglobin status and also electrolytes, and also the blood gas and acid-base status, not to all patients, but to selected patients based depending on the type of surgery the patient underwent, and of course the liver function test accordingly. So you have done the fluid management and you have done the laboratory tests required, so that you have to make the request accordingly. When you do these sort of daily ward rounds, you must always keep in mind the patient can develop complications. So this is again one of the aim of doing inward postoperative care to a patient, as I mentioned at the beginning. So you could see in this slide, the patient can have different types of system involvement. Likewise, you can have complications arising early, immediate postoperative period or in the later period. So basically, following a major abdominal surgery, you can have immediate postoperative complications like hemorrhage, that means at the local site of surgery, or the patient can have general complications like hypoxia or sort of obstruction to airway by inhaled vomiters, or if it is an older patient, the patient can develop myocardial infarction. But as you go on with subsequent ward rounds and management of the patient in coming days, so with the early postoperative period, you can have complications which can be local and general, like paralytic ileus, or the patient can develop pneumonia. And later on, you can have different types of complications developing, so that you must keep these things in mind. Depending on the type of surgery, you may have local complications and general complications at different time intervals. So if you can keep these things in mind, then of course, you won't be having much problem in identifying these complications by your frequent monitoring and observations. If you have identified it, don't forget to inform your superiors and get the opinion for subsequent management. So having said that, when you are going to work in surgical units, you will be working in different surgical units. Different surgical units may be doing different major surgeries, but for common surgical complications, of course, I have listed already. But there are some few important specific complications following major surgeries. For example, if a patient underwent total thyroidectomy, when you're coming for a ward round immediately and also in the night, always check whether a patient has got respiratory distress or stridor because of bleeding inside. That is a very common postoperative complication you must always keep in mind. If a patient underwent prostatectomy, then of course, has he got bleeding and has he got a clot retention? Has he got a palpable urinary bladder? And the patient has undergone an anterior resection, then of course, you can always think in terms of bleeding immediately after surgery, and the next day or second day or third day, the patient may be having paralytic ileus. And of course, another dreaded complication would be anastomotic leak. But likewise, you know, each and every major surgery has got its specific complications. Abdominal aortic aneurysm repair, of course, danger is bleeding, and subsequently you can have other complications like, you know, fistula formation and so on. And if you are working in a GI unit, then of course pancreatic or duodenectomy or Whipple surgery, as you all know, bleeding would be a complication immediately after surgery, and subsequently the patient may also develop bile leak. So likewise, you have specific postoperative complication apart from general complications. So those are the important aspects that you should keep in mind when you manage a patient in the ward following a major surgery. So I think I have covered the needed topics in brief. If you have any questions, I can answer. Thank you for your patience listening.
Please welcome Dr. Chintaka Vijayasundara, Consultant General Surgeon at Base Hospital, Kantale. He'd be speaking on post-op pyrexia and recognition of a septic patient. Over to you, sir.
Yes, hello. Can you see my screen?
Not yet, sir.
All right. So a very good afternoon to all of you. So the topic given to me is post-op fever and recognizing the septic patient. All right. So I would take you through the salient things under this topic through a case scenario. Let's say Mr. A, a 56-year-old. Yeah, just a minute.
So will you be sharing some slides?
Yes. Is there any problem?
We can't
You
still
can't
see.
say, sir.
Okay. Can you see the slide now?
Not yet.
Okay. How about now?
No.
Okay.
Now we can see the
How about
screen.
now?
Yeah, good.
All right. Okay. So let me start off with a case scenario and take you through the salient things under this topic. Let's say Mr. A 56-year-old, undergoes an open anterior resection. Um, that is, if I simplify, excision of a rectal tube, bringing the ends of the remnant bowel, or what we call an anastomosis. So it's a major operation. He's been in your ward and you're the intern. So on post-op day 4, you get a call from the nursing officer who's looking after this patient, saying that the patient feels a bit unwell and he's developed a fever spike and he's complaining of some bloatedness in his abdomen or abdominal distension. If you go to the ward, you might find this chart, commonly seen in the government sector hospitals here. It's a temperature chart wherein the name of the operation. So day 0 is the day of the operation, day 1, day 2, so many days after the operation. So as you can see, there are 2 fever spikes developing in the afternoon of day 4 and in the morning of day 5. All right. So before I get on to the rest of the assessment and management, I would like to give you an overview of the likely spectrum of cases that can present with fever in the post-op patient. Of course, it's categorized in this way. I will have to tell you that there is a considerable overlap and anything can happen at any time. So broadly, there are infectious causes and non-infectious causes that can give rise to post-op fever. As surgeons, as doctors, we are more concerned and worried about infectious causes because they could lead to a worse outcome. Generally speaking, after an operation, within the first 48 hours, non-infectious issues can set in and can give rise to this low-grade temperature. As you saw in the temperature chart, you could see low-grade temperature spikes within the first 48 hours, touching to a baseline, and that's usually because of the body's response to trauma or operation. Also, things like atelectasis, lung collapse could give rise to fever within the first 48 hours. But after the first 2 days, the real infections of different causes can come into play. Sepsis, urine infections, line-related sepsis, pneumonia, and so on can give rise to problems in your post-op patient after a major operation. All right, so from there onwards, what are you going to do as the intern house officer? So you get this call from your nursing officer who might have woken you up in the middle of the night at midnight, who says that patient's got fever, feels a bit unwell, but his parameters are stable. What are you going to do? If you think of telling the nursing officer, okay, give some paracetamol, give me a call in 1 hour's time, and let me know if there is fever. If that is the type of response, you're likely to end up in trouble because the nursing officer who informs you clearly documents in the bedhead ticket that she has informed you where she passes the responsibility over to you. And unless you go and see the patient physically in person, you're likely to miss a golden opportunity of picking up a patient in sepsis because time is of essence, as you'll understand in the following slides. So you need to go to the patient, have a standard protocol of assessing any sick patient, A, B, C, D, E approach. So airway and breathing. So in this patient, airway is likely to be patent, and let's say saturation is 100% on air. You need to assess the breathing. So it looks like the patient has got tachypnea. Respiratory rate is 28 breaths per minute. You need to check the air entry, look for areas of loss of air entry, crepitations, which could be due to a pneumonia. And also you need to check the circulation. At this point, you can connect the patient to a monitor, a multi-para monitor if it's available. So the nursing officer, when she checked, the blood pressure has been 100/70, but when you check, it's 90/75. And when you check, the pulse rate is 120, so he's tachycardic. And D is disability or the neurological status. You can use the ABPU system in your initial assessment, and you note that the patient is a bit confused. And thereafter, you need to expose the patient, check the temperature, look for all foci of possible infections like cannula sites, lines if there's a central venous line, look for any possible evidence of infection there, and also check the abdomen carefully, look for evidence of peritonism. And also, if there's a surgical wound, you can see if there is soaking of the dressing with pus or any other material. And also, if there's a stoma, see if the stoma has been working in this case. Also, having done this clinical assessment, you need to see all the monitoring charts that are part and parcel of a patient management with this sort of an operation. So, out of all of those, urine output is of significant importance. You need to see the trend, and the use of these monitoring chart is, rather than to make decisions by having a look at one single reading, it is always useful to see the trend, to see if the pulse rate has been creeping up to be tachycardic, or if the urine output has been tailing off gradually within the last few hours. All right, so at the end, you need to ask yourself, am I dealing with a man or patient in sepsis? All right, what's next? Sepsis, infection, and septic shock. These are three distinct entities. I would give an overview of it initially. Infection is presence of an infection, and when you have an infection alone, your organ systems might be working fine without any failure. When you say sepsis, according to the latest definition, when a patient in sepsis, the patient has got an infection, documented or suspected infection, plus evidence of single or more organ failures. Now, these organ systems could be the kidneys, one of the early hits in case of sepsis. It could be your central nervous system, in which the patient might get a bit confused or delirious, and it could be a clotting. It could be any other system, the circulation. The moment sepsis affects the circulation system, the blood pressure crashes. That is when you call a state of septic shock, which I'll come to next. So sepsis, by definition, is a life-threatening organ dysfunction caused by dysregulated host response. If I elaborate, all the changes that you see in a life-threatening infection that leads to organ dysfunction is because of the body's response to the infection, which leads to a state of vasodilatation, that leads to shock, that leads to renal hypoperfusion, that leads to an AKI, and so on. And it is a medical emergency in your surgical ward. Timing is crucial. Why do I say that? Mortality, they say, it rises by at least 7.6% for each hour a patient is kept without antibiotics, if a patient is in septic shock. Now let me come back to our patient. Now, a few years ago, even when we were trainees, we were taught about SIRS, or Systemic Inflammatory Response Syndrome, as a screening tool to suspect a patient in sepsis. Now that is considered obsolete, and this is considered a quick bedside screening tool. It's called Q-SOFA. It has three basic elements. HAT, you can use it as HAT. H is hypotension. It's systolic blood pressure less than 100, not 90, mind you, and any alteration of mental status, and tachypnea, respiratory rate more than 22 breaths per minute. And if your patient has got 2 or more of this Q-SOFA or the HAT score, the patient is likely to be in sepsis, and that could suggest a poor outcome. So if you go back to our patient fulfills all of these three criteria, and he's likely to be in sepsis. And the other point that I want to highlight here is fever, although commonly believed, is not an essential prerequisite for you to say that this patient could be septic. The patient does not have to have fever to say or suspect your patient is septic. All right, so septic shock is a subset of sepsis where the circulatory system collapses, and you can diagnose septic shock when the patient fails to maintain an adequate blood pressure, which means mean arterial pressure of 65 or more without the need of vasopressors. Now, lactate is an essential investigation in a sick patient like this. Lactate, as you know, is a product of anaerobic respiration, and it indicates, high lactate indicates hypoperfusion or poor blood supply at cellular level. So if you suspect a patient to be septic or septic shock, you need to do lactate. If lactate is higher than 2, that indicates your patient is in septic shock. All right, so let's come back to our patient. So you have assessed, you have gone to see the patient, you have assessed, and you have seen the initial parameters and the monitoring charts. And you initially suspect, okay, am I dealing with a patient with sepsis? What you got to do? You need to get the seniors on board. Definitely inform the registrar or senior registrar, or if not, the consultant on call. Connect the patient to a multi-para monitor. Check the saturation. And you must start by resuscitation. Get adequate IV access if the cannulas are not working. Make sure you get wide bore IV access. You can see the colors, orange or gray, and you must initiate fluid resuscitation. If the blood pressure is low, you need to give a bolus of crystalloid. The type of fluid, I reiterate, is crystalloid, and that is Ringer's lactate or normal saline. Of course, Ringer's lactate is preferable over normal saline nowadays. And how much fluid to give? If your patient is hypertensive, you need to give a bolus of 30 mils per kg. And then you need to see if you're achieving a target mean arterial pressure of 65 millimeter or more. If that is not received, that is an indication to start vasopressors. As you know, the pathophysiology of septic shock, the patient is in a vasodilated state in response to the infection, and however much fluid you push in, if there is a dilated system, there is an ineffective intravascular volume. So you need to press or compress the vascular system, so you need to start noradrenaline. Of course, by this stage, the intensive care team and your seniors would be on board. And without any delay, I have to highlight this, you need to obtain, do a septic screen and send the cultures, urine cultures. If there is a wound infection, do a wound swab and send it for culture. Discuss with your seniors without any delay and start broad spectrum antibiotics. Could be a 3rd generation cephalosporin or higher. Please do not start antibiotics blindly without obtaining cultures. I need to reiterate that. And as I said, delays in initiation of antibiotics could mean high mortality. All right, so having done the initial resuscitation, you need to do the other basic investigations: full blood count, CRP, renal functions, electrolytes, clotting, and as I said, lactate, in case if you suspect septic shock or sepsis, and of course, radiology, chest x-ray. As you can see, this x-ray shows a right lower lobe consolidation. Okay, so coming back to the summary, what I've been discussing up to now was the 1 hour bundle. If you suspect a case of sepsis or post-operative sepsis, we need to achieve these 5 elements within the first hour since suspecting or detection. So firstly, you need to measure the lactate level if you suspect septic shock and obtain cultures without any delay before administering antibiotics, and you need to start broad spectrum antibiotics. And fluid resuscitation, that's rapid administration of 30 ml per kg of crystalloid for hypotension or if the lactate is high. And if the blood pressure is not picked up beyond 65, then we need to add vasopressors. And all of these things are needed to be done as a bundle within the first hour because time is of great essence. And of course, even now, it's a common complaint that we do get from our intensivists, anesthetists, is that we have delayed detection and we have under-resuscitated or poorly hydrated a septic patient. So it's a common feedback that we do get from the anesthetic colleagues. All right, so what are the tools for early identification of post-operative sepsis? So as Dr. Rajendra highlighted or discussed in the previous lecture, there are certain monitored parameters in these monitoring charts. The temperature chart, the pulse rate, blood pressure, respiratory rate, saturation, urine output, and so on. And also I have to reiterate the value of this bedside tool or Q-SOFA or HAT. And also early warning score, a little bit I'd like to tell you, although it was introduced to our country, it's not widely practiced. It's something like this. It's basically the same monitoring parameters, but a score is assigned for any change in each of these monitoring parameters. It is used in some units, some teaching units, like Kalam South. And the difference is when you score using this early warning score, there's a predetermined plan of action. Who to inform, how frequently you need to increase the monitoring, and how to escalate the place of care of the patient. So this is also a very vital tool for early identification of post-op complications, including post-op sepsis. All right, so that winds up my presentation. You're free to ask any question. I'm happy to answer.
Thank you, Dr. Chintaku Vijayasundara. Up next, we have a panel discussion on safeguarding yourself and others from unexpected legal problems. It would be conducted by Dr. Channa Pereira, Judicial Medical Officer at Teaching Hospital Ratnapura, along with Dr. Satish Gunasinghe, Consultant Neurological Surgeon at Teaching Hospital Karapitiya.
Hi, can you hear me, please?
Yes, we can hear you.
Yeah, hi. Rather than a panel discussion, myself and Chan, we thought of giving some salient points about medical legal aspects. Good afternoon and welcome, and hope you all would have a great internship. Litigation and legal action have becoming very common in Sri Lanka at the moment. People become more litigious, but we must not look at them from a negative point of view. Because if we do good work, if we do dedicated work, and if we document what we do accurately in the bedhead tickets, it's very unlikely that one is caught in a legal process. I think this was very well stressed by Dr. Rajendra, and he said documentation is of vital importance. So if you do dedicated good work and you document your work and you work with concern for patients, it's very unlikely that you will be subject to litigation. And you have to be an effective communicator as well. Be honest with the patients, the relatives, to talk. Then I think litigation will not come in your way. But always you have to be defensive as well by documenting. And also you should not work to get away from litigation, but you have to work with utmost interest on the welfare of the patient. That is the most important thing. Our focal point is the patient, not the law. Law is second, but still, if you do good work, litigation will never come your way. So it should not be defensive medicine or surgery, but it should be patient-centered management. In medical ethics, we have few principles that we have to understand, that there should be a respect to the patient's autonomy, the independence of a patient to decide for himself or herself. That is something. Doctor can't play the role of God or a superior being. This is the case. Doctor thinks he is superior. Never. Patient is superior, and we are servants of the patient. That has to be borne in mind. They are not things, but they are human beings, and we have to respect their autonomy. Second principle that you should know is that we have to work for the benefit of the patients, and in ethics we call it beneficence. That's another very important thing. Always we have to we cause benefit to the patient. We should never harm a patient. Actually, a patient after surgery ideally should leave in a better condition than he or she came. Of course, there can be complications, but in general, the objective of doing good surgery is to make sure the patient goes in a better condition than he or she came. The third principle is not to cause any harm, non-maleficence, where we should not harm the patient. This is common sense. I think as doctors, we can't harm the patient. We can't harm them mentally, we can't harm them physically. There are complications, they are unintentional, they are medical incidents, but we should not never cause harm to the patient. We should never be rude to patients. We should be calm and gentle and friendly with patients. That's very important. So autonomy, beneficence, which is benefit, non-beneficence, not to harm. And fourth principle, which is important as interns, whatever the theory, practical skills that you have, is distributive justice. There are certain situations where we'll have to be equitable. If there's a lot of patients, which patients are going to get benefit? If there's inundated with trauma, unfortunately, we don't see polytrauma situations with bomb attacks now, but then we had to see what type of patients would benefit from care. So then we have to see all these patients. That's what we call distributive justice. Those are the four important principles of ethics. And also respect for persons. We must never consider a patient as being inferior, even if he comes from a village background, wherever from where he comes. Even if it's a person who's begging the streets, you have to respect him for being a human being. And you should not be sarcastic towards patients. You should never sort of converse in English and condemn a patient, this chap, this fellow, never. They are human beings, and always you have to respect them. Litigation would come if you are rude, bad, critical. Sometimes, without knowing, you may be criticizing a person who is knowledgeable, who is educated. So you have to be very careful. Truthfulness and honesty. That's also very important. When you become a doctor, you have to be truthful and honest. Those are actual legal problems arise when ethical principles are not adhered to. So that is something which we have to understand. Now, coming to litigation, there are a lot of aspects that we have to cover. I think for a short period of 10 minutes, it's very difficult for me to cover. But confidentiality, that is another important factor. We are not going to talk about patients' problems with others, even with an unknown person. That is very important. But when it comes to surgery, another important aspect is informed consent. But unfortunately, if you look at most of the hospitals in our country, the consent amounts to a small signature or an initial that is made on the bedhead ticket, Shalya Karmeta Kamathiyam, or consent for operation. And he just puts a signature, or there's a thumbprint from a patient who is not well educated, and that is considered as consent. That is total nonsense. When there's no adequate informed consent and a procedure is done, or some sort of treatment is meted out to a patient, that amounts to negligence. So the concept of informed consent, all of you should learn. Informed consent means patient should be aware of what type of procedure he is going to have. And that should be done in a language, in a way where the patient can understand. So that has to be done. And patient should understand it, and also we should know what are the complications of the procedure is. Is there a bleeding, any nerve injury, depending on the procedure, any permanent deficit or a deformity of the surgery as a complication. And also, it's very important to tell the patient what could happen if the surgery is not done. So what is the surgery that is entailed? What are the complications of the surgery? And what would happen if the patient doesn't undergo surgery? That too has to be told to the patient. All those have to be documented adequately. Now, then you have to get the signature of the patient or thumbprint. I don't know how valued they are, that is, but at least you have to get the signature of the patient that he has consented, and in a real legal situation, you have to countersign as well. But there's no legal requirement as such that you have to take written consent, written informed consent. But that gives you excellent defense. So actually, consent is not one step, it's part of a process. So it's very important for us to understand that informed consent in surgery is very important. But there are situations when we cannot obtain informed consent from patients. It's the situations where there's patient is unconscious, patient comes after polytrauma situation, where patient is not conscious, there are no relatives around, but in the interest of the patient's life or function, we have to resort to surgery or do some procedure. There we have a defense in criminal law called necessity, where I have a necessity to save a person's life. So it's very important to document, as Dr. Rajendra said, to prevent or be away from litigation, document all what you do. Even if you do hard work, no point if you don't document, because ultimately before the courts of law or inquirers, it will be the documentation that you do. And please don't fabricate, don't write lies. Write what you have done, what has been done. And also important to record the times at which things happen, what type of resuscitation was done. Those are the important things that we have to document. And consent-wise, tell what the patient, what the procedure is, what the complications are, and what would happen if the patient does not have surgery. The patient refuses consent without knowing what would happen if there's no surgery. It's not informed consent. So that is very important. And also we have to practice, as I told earlier, not to get away from litigation, not to prevent or be defensive from litigation, but with our conscience to serve the patients well. Thank you very much, and wish you all a very happy, fruitful internship and all the very best in your careers. Now, order Dr. Chandra Pereira. Thank you.
So we can't hear you, sir. No, sir, we can't hear you still. Sir, if you could remove the headset and try.
Can't hear.
Can you hear me now?
Yes, sir, we can hear you now.
Okay, I'm sorry about it. So when it comes to medical legal aspect of a surgical management of an internee, mainly we have two aspects, the management of a dead and management of living. So when it comes to clinical management by a JMO, as you know, the patients are being referred to a JMO through a medical legal examination form or from a court order. The only exception is that a consultant can refer a patient for medical legal purposes to a consultant to obtain the consultant opinion. So let me start with the management of death. When there's a death in your ward, first of all, you should certify death. It's extremely important. First of all, you have to put the date and time of certification, and you have to record the absence of pulse, absence of heartbeat, absence of spontaneous breathing. I emphasize on that. And you have to take a torch and check the pupils for pupillary reactions, whether the pupils are reacting to light or not, to check for the brain functions. And then you certify death. You write that is confirmed and put your signature by putting the date and time. All these things are extremely important. Then if the death is natural and if the cause of death is known, like for an example, an acute myocardial infarction or whatever, then of course you can write the death declaration form, which is also called as the declaration of death form or the B33 form, which is there, the book is there in your wards. So you write the cause of death and the other detail, and you can release the body to relatives only if the cause of death is natural and if it's known. Though the manner is natural, and if the cause of death is not known, you are compelled to request for an inquest from the head of the institution. Later on, I will tell you how to do that. But the point is, in most of the surgical wards, the patients come with unnatural events. So therefore, the manner of death will be most of the time unnatural. Either it could be accidental, either it could be suicidal, either it could be homicidal. Then of course, even if you know the cause of death, you must request for an inquest. So the way to request for an inquest is you write to the head of the department, head of the institution, the director or the medical superintendent or the DMO, dear sir, please authorize an inquest into this death. So for an example, if it's a road traffic accident, if the patient was treated for a long time, for 2-3 weeks, and even if the person dies as a result of hypostatic pneumonia following prolonged bedridden state, still the underlying cause is trauma. Therefore, you should request for an inquest. And when it comes to the inquest, of course, who is going to handle it is immaterial for you. To save the time, I will skip that. But inquest is being held either by the inquiry into sudden death or the magistrate. Now here, a question arises why I told you about the reactions of pupils and checking for brain functions, because the certification of common deaths involves of somatic nature. These are called somatic deaths. But when it comes to the brain death situation, the certification of death is totally different. And so you have to check for most of the vital functions of the brain. So that is a different situation altogether. Now, once you have certified death, there's a common practice to keep these bodies in the ward for 2 hours. And why is that? Because now there's a concept called suspended animation. I'm pretty sure you may have heard recently, about 3 months back, there was a dead person who stood up from the morgue at Nigam Base Hospital, General Hospital. So the reason is there's a concept called suspended animation where the persons are not really dead, but their physiological functions are functioning at a very low level. So once they recover from that situation, they will look, I mean, it's not a deadly situation. So they will look like you and me normally. So, I mean, in that kind of situation, it's extremely important for you to check the people reactions. Then, of course, you can spot whether there's suspended animation or not. But the advantage of keeping these dead bodies for 2 hours in the ward is, at 2 hours, there's onset of rigor mortis, the postmortem stiffening of the body, which is a definitive sign of death. So, I mean, then as I told you, in unnatural deaths, there's mandatory inquest. In natural, where there's no cause of death, you need to request for an inquest. And the other thing is the clinical examination. Clinical examination, of course, as I told you, patients are being referred from the police with a medical legal examination form. It is extremely important for you to record injuries on admission, because by the time the JMO sees, it may be 2-3 days delay or even more. So therefore, you must record all the injuries in the bedhead ticket. So apart from that, when it comes to the defensive practice of medicine, in good old days, of course, it was not defensive medicine altogether. Now today, as the previous speaker spoke, of course, we are compelled to defend ourselves and to practice medicine. Now, what could happen if you do not practice proper? I mean, if there's any negligence. So let me briefly speak of medical negligence. There are 2 aspects of medical negligence. One is the civil medical negligence, and second is the criminal medical negligence. So for a patient or the next of kin of the patient, if the patient is dead, to sue a medical professional, there are certain components which should be fulfilled. Now, in brief, what is negligence? Negligence is an act of commission a reasonable, prudent person would not do, or an act of omission a reasonable, prudent person would do. That is the common definition of negligence in general. When you apply this principle to medicine, if you do not perform what should be done to a patient is negligence. That is act of omission. And if you do something which should not be done to a patient is also negligence. That's why it's called act of commission or omission. Now, when it comes to civil medical negligence, there are, as I told you, there are certain components which should fulfill for a patient or the next of kin to sue you. That is, first of all, there has to be a doctor-patient relationship. So there has to be without a doctor-patient relationship, a patient or the next of kin cannot sue a doctor. Now, when there's a doctor-patient relationship, the doctor is compelled to exercise a reasonable degree of skill and care. Now, what is the reasonable degree of skill and care? That does not mean that you should practice all the things under the sun in medicine to this patient. Now, there was a surgeon who spoke from Kantale. I have a lot of experience from Kantale because I was a post-intern at Kantale in 1996. So when it comes to facilities at Kantale, we may not be able to exercise all our skills. Whereas at National Hospital, you may be having more facilities. So therefore, you should exercise a reasonable degree of skill and care to the patient. So there's a doctor-patient relationship. You should exercise a reasonable degree of skill and care. And if you have performed an act of commission or omission, there has to be damage to this patient for the patient to sue you. And the damage has to be as a direct result of your negligent act. Then only the patient can win a case in a civil court. So the civil medical negligence is being heard in civil courts, whereas the other entity is the criminal medical negligence. In civil medical negligence, of course, the doctor will not be arrested. But if the patient will win the case, you'll have to pay a monetary compensation. I mean, you have to pay the damage to the patient by paying money, giving money to the patient. When it comes to criminal medical negligence, the difference is apart from these 4 components that I mentioned, the doctor is absolutely disrespectful to the patient's life. So criminal medical negligence, the difference of civil and criminal is if the doctor is absolutely disrespectful to the patient's life, then of course that amounts to criminal medical negligence, where the case is heard in magistrate courts and the doctor is liable to be arrested and remanded. And in criminal medical negligence, it's very difficult to be proven because the case has to be proven beyond a reasonable doubt. There cannot be any doubt to prove this case. But the disadvantage of civil medical negligence is the case is being heard on the balance of probability. 50 plus is sufficient for the patient or the next of kin to win this case. So I think my 10 minutes is over. So if you have any questions, of course, I can answer. I just discussed 3 small entities: clinical examination by a JMO, certification on death and releasing of these bodies, and about a little bit of medical negligence. If you have any questions, I can answer. Any questions? I hope you could hear. Were you able to hear my lecture?
Yes, we could hear you, sir.
Okay. Any questions? I think it's done. Thank you very much.
Thank you, Dr. Channa and Dr. Satish. Next, we have a brief session regarding what the intern should do when the patient has to be transferred to a bigger center. Please let me introduce Dr. Mihira Bandara, Consultant General Surgeon at North Colombo Teaching Hospital, Raiba. Over to you, sir.
Can you hear me?
Yes, we can hear you.
Right. Good afternoon, everyone. I'm sharing my screen. Is it working? Can you see my screen?
Not yet.
Now?
Not yet, sir.
Now okay.
Yes, sir, we can see.
Right. Right. So I'm going to talk on the very important topic, because as an intern, you all have to deal with this condition, because you have to, not only one, there are many patients you need to transfer for various reasons. So therefore, it is very important for you to have a very good understanding of certain principles of transfer, and to do a safe transfer, and to benefit the patients in a rational way. Right. So we will discuss this transfer of patients by taking a case scenario. 21-year-old motorcyclist admitted to after road traffic accident with head, chest, abdomen injuries and right femur fracture. Vitals on admissions: blood pressure 90/60, heart rate 120, respiratory rate 36, saturation 85, GCS 30. The fast investigations done, and chest X-ray right-sided pneumothorax, X-ray pelvis stable rami fracture, and the fast scan small amount of free fluid. So as you can see, patients is having unstable vital signs, tachycardic and low blood pressure, sort of a shock, and the patient is having desaturation, saturation 85, and the tachypneic as well, and the consciousness has reduced. So I'm not going to do a detailed discussion of the trauma initial management, but once you perform initial management of this patient, 100% oxygen with the cervical collar, IV fluid, chest tube inserted the right side chest, and right femur splintered, pelvic bind applied. So after initial treatment, the patient responded and become more stabilized. Blood pressure 170, pulse 105, saturation 96, and GCS 13, and IC tube drainage was 100 ml, and after that only the air bubbles and fluctuating. Fast still relieving only the small amount of free fluid. Right. So if you are managing in this patient in a base hospital where a general surgeon is available, and X-ray and ultrasound facilities, and but no CT scan. So does the management of this patient exceed the institutional capabilities? What do you think? Can you manage this patient in a this kind of a facility? There's a general surgeon, there's a X-ray facility, and ultrasound facility. What is the problem of this patient? As you saw in the previous slide, patient after the initial treatment with the IV fluids, patient responded and blood pressure became more stable, and saturation also picked up. We know that patient had chest injury with the pneumothorax, but it's not continuously draining. And small amount of free fluid in the abdomen, and the right femur fracture. Right femur fracture also can cause significant blood loss to amount to even a shock. But so either there may be abdominal injuries evolving, we don't know, and there may be injuries inside the brain, we don't know. It may be intracranial hemorrhage, maybe evolving EDH or SDH or ICH. So, but without further evaluation, further imaging, very difficult to manage this patient. So for neurosurgical wise, to manage this patient, you need the imaging of brain to understand what is going on inside the brain, because there's a definite criteria for CT scan imaging in this patient. The GCS is not normal, it has reduced. So loss of, therefore this indication for CT scan. And so now this patient, you need to arrange to a transfer where there is CT scan facilities, and also better if that institution has the neurosurgeons facilities or neurosurgical facilities, because in case if these patients reveal any intracranial hemorrhage, so then you can take the opinion of a neurosurgeon or operate then and there. So you have to select where to transfer. And at the same time, when you're doing CT scan in this kind of patient, the multiple injured patient, all the body compartments have been injured, abdomen, pelvis, limbs, chest. So it's likely that possibility that there may be cervical spine injury, and also maybe the hidden intra-abdominal injuries. So better combine those areas also. So CT brain with the CT spine and CT abdomen also may worth combining with this patient. So you need to arrange a transfer to a place where there is CT scan facilities, functioning CT scan, and the neurosurgical capabilities. Right. What are your priorities in this process? What do you mean by the arranging transfer? It is not just one thing. You need to look into the several aspects. Most important thing is the patient's stability. And once you decide on clear indication for transfer for a particular patient, then you need to decide whether a patient is fit enough or stable enough to transfer, because it may take half an hour or 1 hour, 1.5 hours. Therefore, you have to stabilize sensing. So in this patient, blood pressure is 100/60 is fairly stable, because certain patient after trauma, you cannot take the blood pressure back to 120 or over 70 or something. But after giving fluids, it has become stable, but we don't know whether it's continue to stay. It might drop again. So you should get ready. And particularly this kind of patients, critically injured patient or other critical patient, can deteriorate at any time. So you should avoid any delay. And you should do only the investigations that are really necessary for the patients. Usually in trauma patient, you can do investigations needed for the primary survey, that is chest X-ray, pelvic X-ray, but all the other views of X-rays can be done later, because that will increase the time, or they can delay the transfer process. And definitely these patients need transfer with certain equipments, because you need to get ready with the instruments with the intubation and the, if needed, blood transfusion. Better start a blood transfusion because this patient blood pressure initially unstable, responded to the fluids after maybe 2 pints, and but we don't know whether there's a continuous bleeding inside the abdomen and whether going to deteriorate further. And patient might deteriorate the GCS even further, so there may be the desaturation again, so might need even intubation. So you should be prepared to do a intubation when needed. If you are not skilled, if you are not happy, then better intubate and transfer, because on the way, if the patient deteriorates, if you cannot manage the patient, because we know as intracranial hemorrhages enlarges, the GCS can suddenly drop maybe 13 to 8 or 7, 5, like that. And the patient cannot maintain airway. The tongue itself can block the airway. So that can happen. Therefore, intubation may be mandatory. But if you cannot deal with that situation, if you're not skilled, better intubate and send. And other most important thing is the communication and documentation. Whenever you transfer patient, you need to clearly communicate with the receiving and receiving hospital institution. It may be for investigations, it may be for a specialized opinion of maybe neurosurgeon, maybe vascular surgeon, maybe the thoracic surgeon. So you need to contact directly the surgeon involved, and you have to tell the incident and the what you have done, and say that you want to transfer this patient for these reasons, and then get the further instruction from him what to do before sending and during transfer, and then you can transfer. That is the very safe way, rather than just writing a transfer form and sending. And also, if are transferring patient for a investigation, like for a CT scan, make sure that the hospital has a functioning CT scan. Sometimes we come across sometimes these machines are overworked and they go out of order certain times. So if you don't check and transfer, then you may unnecessarily transfer patients to a place where there is a that can cause certain delay. So better check those things and transfer. And documentation is very important, because you have to clearly mention why do you transfer. What is the indication for transfer, and what was the incident, and what have you done, what are the results of particular investigations, and also any special incidents, like if you notice any spurting bleeding, or if you notice any fits occurring in the patients, or if the patient develops some short cardiac arrest or respiratory arrest or allergies, those kind of special incidents you have to mention. So there should be adequate description of all those things before sending the patient. What government has this kind of a transfer form is very limited rules for mentioning those kind of things. So I think you can better the other side of the form to write whatever the needed, because I think that is to mention the adequate information in a critically ill patient, critically injured patient. This kind of a form is not adequate. You have to have either device when you inform, or use the several other pages, or use the other side to write it down. So communication and documentation is very important. Right. So before transferring, you have to make sure you have the stabilized the life-threatening conditions, particularly in a trauma patient. Primary survey should be completed, and you should see the patient is improving, stabilizing. And while awaiting transfer, you can do even the secondary survey, and you can put the catheter NG during that period. And stabilize the disabling injuries like fracture femur, fracture pelvis. You can put the splints for whatever the fractures, and put the pelvic bind. And after transfer arrangement, because ambulance won't come if you don't arrange, you have to particularly write to the director for arranging and the inquiry office for arranging the ambulance and ambulance staff, and inform the nursing in charge for arranging a nursing staff to accompany with you. So, and without doing any unnecessary investigation, doing only the necessary investigation to minimize the delay. During transfer, because when you're accompanying the patient, you have to monitor the patient and look for any deterioration. Look out in the vitals in the monitor, because patient might again crash the blood pressure, the pulse rate may rise. So you have to increase the dip rate, or make sure that drip running and the cannula is working, it is not dislodged. And make sure, especially in this patient, now that you have inserted the intercostal tube, so make sure it is functioning, because there's a practice among some to clamp the tube and transfer, but never do that, because there should be functioning IC tube throughout the transfer. Therefore, keep the bottle below the patient's level, patient chest, and you should see that it is functioning, fluctuating all the time. Otherwise, the air might accumulate, blood might accumulate, and the respiration might compromise. And intervene if needed, like for a blood pressure crash or the saturation dropping, you have to repeat the primary survey or the look for what is happening and correct that thing. So you should be skilled enough, and you should have adequate knowledge to manage that kind of a deterioration. With regard to the documentation, your writing should be very clear. There should be a clear indication. Presentation, what are the mode of presentation and the history and treatment you have given should be included. Investigations done, like primary survey, chest X-ray, pelvic X-ray finding, fast scan finding. If you have done CT scan, sometimes if you are working in the general hospital, you may have a CT scan, but still, if the CT is, according to the CT scan, if there's some lesion, you have to discuss with the neurosurgeons. Then they might instruct whether to transfer, just go on observation and repeat the CT in certain time. So likewise, then if the neurosurgeon asks to transfer, you have to carry the patient. And any special incidents, as I mentioned earlier. So that's all what I want to tell regarding the transfer of patients. But make sure that the transfer is very important procedure you need to be very familiar with, because invariably you will come across this requirement, this kind of patients, and you may have to accompany the patient, you have to arrange. So remember the principles. Be clear about the indication. That should be usually that decision is taken by your senior doctors, maybe the registrar, SHO, after consulting with the surgeon or consultant. And after that, you have to make sure the patient is stable. And you stabilize all the other disabling injuries and make sure that in proper time ambulance is arranged, staff is ready to go, and avoid any unnecessary investigations, and be prepared to do whatever the intervention and monitor during the transfer process. I think that comes to the end of my presentation. If you have any questions, you can ask. Right. In the absence of any other questions, so I will stop my presentations. Thank you very much.
Thank you, Mihira. So as we move towards the last segment of the program today, it's my honor to introduce Professor A. Cherif Dean. Of course, he's one of the surgical giants of Sri Lanka and a most respected teacher to many of us, an emeritus professor of surgery, Faculty of Medicine, University of Colombo, and most importantly, he is one of the distinguished past presidents of the College of Surgeons of Sri Lanka. So may I kindly invite you to the present, the pinnacle, I would say, the entire program today. Over to you, sir.
Thanks. Thanks very much. And thank you. And I hope all of you are awake. You had a rather sort of trying day today. I see the program has been full of very useful thoughts, and you've been given a lot of knowledge, taught a few skills over these computers, but I have been given this talking beyond the knowledge, beyond the skills. That is, as you all know, medical education is all about knowledge, skills, and attitudes. And we'll talk a little bit about attitudes, because you are going to be a professional. A professional is a person who has got skills. He's got a certain amount of knowledge. But what is most important about a professional is that he has a code of conduct. He has to behave himself as a professional, and this is expected of all professionals, whether he be an engineer, he be an architect, or whether he be a doctor. But also, what is important is that this code of conduct is an unwritten code of conduct. It is something that we acquire. Now, this code of conduct is, of course, in this word, ethics. And we should all know something about ethics, which you may have been taught at some time in your medical school, but it has been defined as obligations of a moral nature. Obligations. Obligation is not a law or rule. it governs behavior. All said and done, it boils down to one's conscience. You see, you are the one who will decide whether it is right or wrong when you're doing something. And where did this conscience come to you from? Parental influence. So if you do something that is not correct, your parents will be blamed first. Then lessons and examples from schools. If you do something incorrect, school teachers will be blamed. Religious and medical teachers. If you do something incorrect, it is they who will be. Role models, consultants in the medical profession, it is they who will be blamed if you do not have these or follow these obligations. And then obligations of a moral nature. Morals. Morals means some right versus wrong. The problem is who decides what is right, what is wrong. What is right in certain cultures, certain countries may be wrong in other countries and other cultures. So this is again, there is no strict definition, but everybody knows what is right. Everybody knows what is wrong. And so you will have to therefore place yourself in a situation where it is you who will decide, self-regulated. You decide, and all this comes from a common school. All of you probably have been to various different medical schools, either in this country or abroad. But there is one common school that we have all been, the school of life. And this school of life has taught us so far, I hope it has taught you, these obligations of a moral nature. There are three components to medical ethics. Okay? That is primacy, or that is patients. Patients come first, primacy. Then there is something called patient autonomy and social justice. I'll talk about in that moment. Patient welfare. Who is a patient? We all talk about, patient may sometimes be a number, bed number 32. Or he may be a flow patient or patient in the corner of the ward. That is how we recognize our patients. Please remember that every patient is a very important human being, whether it be a beggar or whether it be a king. That I look at every patient as being the center of a little universe with planets all around you. There are planets and in circles. And in these, the first circle would be his immediate family. The second circle would be his friends. The third circle may be the extended family. The fourth circle may be his colleagues, where he's working. So this person is a very important person who controls this planet, and any collapse in the system will occur if something happens to this person, to whoever he is. So if you keep that in mind, you will take a little extra care dealing with these patients. And so they will need a satisfactory level of care, whoever the patient, whatever the social state. You must follow the protocols that are given, and when you go into wards, usually these are laid down sometimes in pieces of paper or in the computer, or it may be protocols that are communicated to you by the consultant or by your peers. Always, never be frightened to ask for a second opinion when you are in doubt. Don't think that it is below your status. In fact, respect people who come for a second opinion, saying that he had the courage to come because he had the primacy of patient welfare at the back of his mind. And to achieve all this, you need to communicate. Communicate with your staff, the laborers, the nurses in the ward, your fellow house officers, senior house officers, registrar, the consultant, and with the patient, the most important person. Communicate, communicate, communicate. I heard the JMOs talk to you earlier. If you don't communicate properly, you get into trouble. Even medical legal problems occur as a result of that. So that is patient welfare. Other one is patient autonomy. Patient autonomy is where the patient is the most important person that we are dealing. Unfortunately, today, in the medical systems that we have, it is either the doctor, the nurse, the matron, those are the people, or the minister of health or the health officials, they are the important. It is this person who is the most important. And that is the person who will decide what is going to be done, what his treatment procedures is, and especially if there are alternate forms of treatment. That person will decide if it's surgery or no surgery. That, you went, give all the options to the patient and then decide, let the patient decide. Some patients have personal preferences. Some people will say, due to religious reasons, I don't want a blood transfusion. You can't force the blood transfusion down the veins of that particular person. You have to, therefore, respect patient autonomy. And always address their concern, both with the patient and with the relative. Try, I told you earlier, communicate, communicate, communicate. Try to answer all their questions. Never say, it's none of your business, it is we who decide, you have to take it or leave it. And lastly, there is this thing about confidentiality. Never discuss patient's problems outside within the ward complex and the people who are involved in looking after this patient. Then the third one is, of course, social justice, a very, very important component of patient care. It is the same quality of care that should be given regardless of social status, whether I told you the beggar or king, race, caste, color, country of origin, religion, beliefs, as I told you about the blood transfusion, sex, whether it's male or female, sexual preferences. It is not you or I who decide on that. We decide only on the patient and the illness and try to do the best possible for this patient. Physical, mental disabilities, then prisoners, addicts, tobacco, alcohol, hard drugs, those who have a different dress code, they all, prejudice should not come into your mind saying, oh, I don't like to treat this patient. You must, as I told you, look at the illness and the patient as a human being and then make your sort of decisions. Unfortunately, this is becoming more and more common and we are finding it hard to sort of take away. The problem with prejudice is that once it starts, once you have dislike for something, then it tends to grow. And you get more and more prejudices that keep on piling up. So that towards the end of your career, you will find that there are lots of things that you don't like and that you are prejudiced against. Fight against them and try to overcome that line of thinking. The difficult patient, but I have put as LAMA, some of you may not know what that stands for. It means left against medical advice. Some house officers are very, very happy when patients leave against medical advice. That means one less problem to tackle. The problem is that if that person is going against medical advice on his own, and he is going because he's got some problem in the ward, try to find out what the problem is and try to put that right, rather than delighting and sort of celebrating the fact that one person has to deal with today in the ward, let him go. Difficult patients, sometimes when a patient is sort of grumbling the whole time, he has got an undiagnosed problem. And only when you sort of finally diagnose it, or only when it is revealed at postmortem, that you turn back and say, oh, no, we missed it. What a shame. No, what a shame. What a shame you missed it when the patient was alive. Try to avoid these situations. There is no person called a difficult patient. So that a difficult patient is a challenge for you to go and investigate better, take another history, look at the patient's problem with independent thinking and try to then solve the problem. Abuse in social justice. Abuse is very common. Isn't it? Whom do you abuse? You know, you only abuse a person who is below your social status. You don't abuse a person who is above. And so that is common. Try to avoid as much as possible if you want to maintain good relationships in your ward and in the hospital and your work. But of course, sexual abuse is a huge problem. You will find in the newspapers in the last few days, doctors being accused of sexual abuse of one type or the other. You see, for every 2 cases or 3 cases that are reported, there are 200 to 300 cases which are not reported. So it is common. I have seen patients come to me and say, I don't want to go back to that particular ward. Why? You see, from the laborer to the maybe the nurses, the medical students, the junior doctors, senior doctors, sometimes even in the laboratories, the X-ray attendants, and various other places, these patients are being abused in one form or the other. Abuse of patients, in my opinion, is a type of disease. And it is always good that if you see this, either sort of have a discussion with the person who is doing it. And if you think that you're also getting into this habit, try to get some form of advice because that's very important before you fall into trouble. Lastly, this is all, medicine is all about trust. Trust. Patients trust you to deliver, to treat them, look after them, send you home. I told you, both with primacy of patient welfare, autonomy, and social justice at the back of their mind. Don't betray that trust. Your superiors, that is your consultants, trust you to deliver a good service in the world. Don't betray that trust. Your medical teachers taught you with great love and care, and they are very proud, saying, here is one of my staff students, now become a doctor, he's practicing. Don't betray the trust. Your school teachers have trusted you, and they take so much delight in talking amongst themselves, saying, well, our student now is going to be a great doctor, and they look up to you. Don't betray the trust. Your religious teachers taught you good habits and ethics, good behavior, a good code of conduct. Don't betray the trust. Your parents brought you up with loving care, fed you, taught you, and they, when you became a doctor, how much they delighted, how many times they have gone to various religious places of worship to thank whoever they believe in for what you have achieved. Don't betray the trust. Society and the medical community looks up to doctors. They will give you a special place where you go. When you go and to a bank and say, I'm a doctor, they will give you a seat and their manager might come and meet. Wherever you go, when you sort of say you're a doctor, you're given special treatment. Why? That is because they respect you. They respect the medical profession. By your actions, please don't betray that trust. Thank you very much.
Thank you, sir. Thank you. Your words of wisdom, they are very important to us as always, sir. I think the participants, they are much privileged to hear your voice and your words at the end of this very important course. So before we wind up, sir, and may I kindly pass few messages. We have sent the second evaluation form, the feedback form, kindly fill that. And then may I kindly invite Dr. Amila Jayasekara for the closing remarks. Amila, over to you.
Thanks very much.
Hello everyone. I'm Dr. Amila Jayasekara, consultant surgeon, one of the co-organizers of this. I think you had a very fantastic today. All the leading senior surgeons sharing their knowledge and experience with you all today. And we sincerely hope that you will benefit from this course, one-day course. And have a very successful internship and ultimately become good doctors and good specialists, and hope that one day you will, at least some of you will return to College of Surgeons of Sri Lanka as good surgeons, and in the future deliver this kind of training programs for your juniors. So I take this opportunity to thank all those involved in organizing this course, our resource persons from very senior to junior who took their time off to dedicate their service to us, and also on behalf of College of Surgeons and President Professor Srinath Chandrasekhara, Secretary Dr. Angul and Council, I thank you all for joining with us today, and please make sure you send us all the feedback forms. In case if you think any of your friends have missed this course, don't worry, because we are planning to hold a similar program again in the near future, and that will be almost similar to this, probably the same content, but we might make modifications according to your feedback. So with that message, I would like to conclude this program for today. Wish you all the best, every success in your future endeavors. Thank you.
Thank you, Amila. So this will conclude the pre-intern program, the internship and insight into surgery organized by the College of Surgeons of Sri Lanka. And please send us your feedback form 2, which will enable us to finalize your certificates. And your e-certificate will be sent through your email, the registered email, which you have used to log into this program. With those notes, we will conclude the program, and we wish you all the very best and great success in time to come, and also hope you will have a great weekend. Thank you.